Welcome back after the tea break. And now we'll start the session 3, a primer on SVT. Chairpersons, we welcome onto the stage Dr. Natarajan KU, Dr. Meera R, and Dr. Prabha Nini Gupta.
Good afternoon all. Just have a small announcement to make. We have got various simulators available for practice like pacemaker, CRT simulator, intracardiac echo simulator, and our live usual EP workstation, basic for a basic EP study. All these are available outside. So whenever you get time, you can try that.
I'm so happy to be here today. Then we are going to have a wonderful session on supraventricular tachycardia. And I invite Dr. Natarajan KU to talk on approach to narrow QRS tachycardia, clinic to EP.
Thank you, because it encourages on the 10 minutes provided. So we'll approach a narrow QRS tachycardia from the outpatient department when you clinically evaluate a patient, and how does that help in the process which takes place subsequently in the EP lab. All SVTs arise before the bifurcation of the bundle of His. These are the common atrial all the supraventricular tachycardias have been enumerated here. Why is the QRS complex usually narrow in supraventricular tachycardia? It's because of near synchronous activation of both the ventricles. So the entire ventricular depolarization happens quickly, and that's why you have a narrow QRS in supraventricular tachycardia usually. When does it become wide? When there is a bundle branch block. As shown in this cartoon, there is a left bundle branch block. So the impulse goes down the right bundle, it activates the right ventricle, then it has to activate the left ventricle later on. That's why SVT in this situation becomes wide QRS, about which Dr. Narayan Nambudiri will speak after me. So these are some typical examples of narrow QRS tachycardia. This is the commonest tachycardia. All of you know it is irregular narrow QRS tachycardia. It's atrial fibrillation. This is a regular narrow QRS tachycardia, which you commonly see, something like what you call as an AVNRT or an orthodromic AVRT. This is yet another example of a regular narrow QRS tachycardia. This is one more example. These are all regular narrow QRS tachycardias. This is again a regular narrow QRS tachycardia, but you can see sawtooth waves here. Probably it's a 2:1 atrial AV conduction in the context of atrial flutter. So these are some of the common garden examples of supraventricular tachycardias with narrow QRS, because there is no bundle branch aberrancy or antegrade conduction through an axillary pathway. So the journey of successful care of a patient with cardiac arrhythmia actually starts in the clinic. A meticulous analysis of symptoms, paying attention to the ECGs during tachycardia, comparing with the baseline ECG. For example, a narrow QRS tachycardia patient has a pre-excitation pattern in the ECG in sinus rhythm. You know that the narrow QRS tachycardia is most likely an orthodromic AVRT. And this exercise helps to diagnose, prognosticate, formulate the line of treatment, timing of ablation. For example, if a tachycardia was not hemodynamically tolerated by the patient, you have to advise the patient an expeditious ablation procedure and not try medicines and postpone the procedure. If the patient had a faint during a narrow QRS tachycardia, it calls for an early ablation. It guides the EP by localizing the substrate and plan the ablation. For example, it localizes a pathway. If there is a manifest pre-excitation, you can localize the site of origin of an ectopic atrial tachycardia from the P wave morphology, so on and so forth. And a good clinical assessment helps to improve the success of an EP procedure. An EP procedure is never a blinded procedure. It is an extension of clinical examination. And these devices are quite useful even in today's time. It's called the stethoscope. People say it is the death of the stethoscope, and what is between the two earpieces also is very important, and that applies to cardiac electrophysiology as much as applies to all fields of medicine. Let's begin with two typical case examples of narrow QRS tachycardia to highlight the importance of paying attention to details in the outpatient department to guide the subsequent EP procedure in the lab. This is a story of a 16-year-old female with recurrent palpitations of many years, termination with vagal maneuvers, failed ablation some time back, breakthrough episodes on drugs, and during OP evaluation, this is the ECG. This ECG clearly shows a regular narrow QRS tachycardia. The P wave is closer to the next QRS than to the preceding QRS, so it is a long RP tachycardia. And during an earlier episode, this patient needed a hospital visit. Fortunately, this patient brought the ECG during the earlier hospital visit. You see a similar tachycardia going on top here. It is a long RP tachycardia. It is closer to the next QRS than to the preceding QRS. And adenosine was given here, and the tachycardia abruptly terminated, as you can see here. And what happens next is quite interesting. You have a similar VA pattern during the sinus bradycardia. The sinus bradycardia is probably because of the adenosine effect still being there. So during sinus bradycardia, you can see there is a VE, which is a P, which is inverted, something similar to what you saw in the tachycardia. So we can call it as an aborted re-entry. This also probably is related to a VA conduction mediated by a slow axillary pathway. And what happens next is reinitiation of tachycardia during sinus rhythm, having a similar P-wave morphology that you saw here with almost near identical VA times, meaning the atrium is linked to the ventricle here. So it's likely to be an AV re-entry tachycardia because an atrial tachycardia has nothing to do with the QRS. So this we call it as a VA linking, which is a feature of conditions like an AV RT. And this is probably a long RP tachycardia, which is called the PJRT, about which we will discuss later. This is a coronary angiogram done in this patient to look for levo phase. There is a prominent lateral vein that you see here because most of these time these pathways are epicardial in location. And this is the ablation site. You can see that the ablation catheter has an earliest atrial electrogram compared to any other site. And during ablation, the tachycardia terminates with a VA block. So this is quite typical. So we saw an example where we demonstrated VA linking as a feature of AV re-entry tachycardia rather than an atrial tachycardia that was confirmed by maneuvers and ablated successfully. This is a 35-year-old lady, recurrent narrow QRS tachycardia, breakthrough episodes despite medications. This is the ECG at baseline. You can see obvious pre-excitation and completely negative delta in lead 2, which is a sign of a coronary sinus diverticulum. Whenever you see a posteroseptal axillary pathway like this, which is completely negative delta in lead 2, you should suspect a CS diverticulum. And again, you can see a very prominent combined venous kind of anomaly here. And that is exactly where we got this kind of signal. You can see VA fusion during sinus rhythm, and during ablation, the VA separation happens. So again, an ECG told us that there could be a CS diverticulum, which was quite useful during the EP procedure. Otherwise, you'll spend long hours chasing this pathway. You may do a septal puncture unnecessarily, so on and so forth. So the clinical informations that can potentially guide the electrophysiologist are, again, prognostication. If you see a pre-excited atrial fibrillation with a very narrow pre-excited RR interval, in this case 200 milliseconds, you know that the pathway is very, very robust in terms of antegrade conduction. So this calls for an early ablation because it has got bad prognosis. In contrast, you look at this case example of a patient whom I saw very recently in our clinic, who presented with brief effort-related palpitations, no sustained palpitations, structurally normal heart. The ECG showed a manifest accessory pathway, early transition, leftward axis, probably a posteroseptal axillary pathway. The question is, how risky is this pathway in terms of causing rapid pre-excited AF, causing sudden cardiac death? Can this ablation wait? Because this patient never had a sustained documented tachycardia. You do a treadmill exercise in this patient. It's pre-excited at this stage, stage 1 of Bruce protocol. It is again stage. There's abrupt loss of pre-excitation when the rate crosses 140. So you know that when the sinus accelerates to more than 140, this pathway is not able to conduct, means the antegrade refractory period of this pathway is quite long. That means it's not one of those dangerous pathways, so you can always postpone this procedure electively based on mutual convenience. And the tachycardia indeed wakes up when the rate falls below 85. So these are all some of the textbook cases wherein a clinical evaluation gives you a lot of inputs as to what you should expect in the EP lab, when to do a procedure, how best to do, so on and so forth. Localization. Accessory pathways can be localized if they are manifest in sinus rhythm. As you can see here, this is a left lateral accessory pathway. Yeah, I've got 2 more minutes. That's what it says. So an accessory pathway can be localized in sinus rhythm. This is a left lateral accessory pathway. This is the site of the accessory pathway. This is a delayed transition. The QRS is becoming positive as late as V4, V5, delayed transition, and a leftward axis, typical of a right-sided accessory pathway in relation to the tricuspid annulus that you can see here. This is again a posteroseptal accessory pathway, early transition, negative to positive in V2, and 2,3 AVF is negative. So a posteroseptal accessory pathway, that is where the location of a posteroseptal accessory pathway is. And you can see in this location, you have completely fused VA in sinus rhythm. and you abolish this axillary pathway within 2 seconds of delivery of RF in this particular site. Even during an orthodromic AVRT mediated by a concealed axillary pathway localization is still possible by looking at the P wave morphology. In this example, the P wave is negative in the left-sided leads. Lead 1 and AVL is negative. I'll stop with this example. And it is positive in the right-sided leads. It's positive in AVR and V1. So the activation of the atrium is happening from left to the right. That's why left-sided leads are showing negative P, whereas right-sided leads, left to right, towards the right-sided leads, that's why the P is positive in AVR and V1. This is an evidence of a pathway on the left side, a left-sided axillary pathway, even if it is concealed and not appreciated in sinus rhythm. If you have a tachycardia ECG and you pay attention to the P wave morphology, you can localize this tachycardia. I had 100 slides in this presentation. It's not possible to cover. So I just wanted to tell you again and again that, like in most fields in medicine, whether it is neurology, whether it is cardiology, whether it is electrophysiology, there is a big role to play in the clinic. Talk to the patient, find out the patient, the symptom status, the hemodynamic status, look at the ECGs. They will come with multiple ECGs. I tell my residents all the time, more the ECGs, better it is for us. It's not a nuisance, it's going to be an asset for you. Thank you for your kind attention.
Yeah, it's a very interesting talk. But I have, you can add two more things. Suppose you have a narrow QRS tachycardia and suddenly you get a left bundle branch block. What is the information you will look for and how does it help?
What you're asking is, what happens, I'm sure Dr. Narayan Nambudiri will address this particular issue. If a tachycardia is faster when it is narrow QRS, and if the tachycardia slows down and it becomes left-sided, it suggests an axillary pathway on the left side. An ipsilateral bundle branch block slows the tachycardia because it prolongs the VA time, and that is I'm sure he will allude to that in case time permits for him also.
No, but he might be going over VTs. That's why I asked that question.
This is a primer on SVT. So obviously he'll talk about SVT.
Oh, okay.
with
Sorry.
sorry. That's what I hope.
Sorry.
How do you suspect multiple bypass tracks? That is often the dominant axillary pathway is what is seen in sinus rhythm. You cannot diagnose multiple axillary pathway from a single sinus rhythm ECG unless you are lucky enough to have two sinus rhythm ECGs, one showing a different pathway from the other.
Yeah.
Oftentimes it is diagnosed in the cath lab. The dominant pathway may be a post-receptal. Upon ablating the post-receptal axillary pathway, you may have a concealed right-sided pathway and things like that. It is more an EP phenomenon rather than a clinical phenomenon. Unless you are lucky enough to see two different patterns of pre-excitation in the same patient at two different times.
Epstein's anomaly. In Epstein's anomaly, you can expect two pathways.
Yeah, Epstein's anomaly is one condition which is notorious to have more pathways than one. Yeah, you're right.
So in atrial fibrillation, Natarajan?
Yes?
Dr. Natarajan, in atrial fibrillation paroxysmal.
You are talking about paroxysmal AF.
Yes, paroxysmal AF. Is it mandatory to do a EP study?
Again, madam,
So I was
it's a very
discussing with
controversial
one of my
topic.
colleagues.
With the advent of better mapping techniques and ablation modalities now, we have reduced the threshold to subject these patients to ablation. But having said that, an atrial fibrillation in conventional parlance should be ablated provided the patient is drug refractory and symptomatic. Now people have lowered the risk. For example, a structurally normal heart in a young person with distressing symptoms, you can offer it as a primary procedure itself. It used to be a drug refractory AF in a patient.
No, Natarajan, that is not what I was asking. Whether it is the substrate for a pathway or no.
Patients with axillary pathways are more prone for atrial fibrillation because of dispersion of activation of the atrium in a retrograde pathway conduction, let's say. So patients with, lot of times we have seen this pre-excited atrial fibrillation. Once you ablate the axillary pathway, they never have a recurrence of atrial fibrillation.
So that means they'll always have pre-excited AF only if they're symptomatic.
Or rather, a patient with a manifest axillary pathway is more prone to develop atrial fibrillation consequent to the pathway related conduction. So you get rid of the pathway, the AF may not recur.
Yeah, it's just like what Thomas Peter used to say, that if you have a accessory pathway, it's like a loaded gun. Will you give your child a loaded gun?
We will unload it. Yeah. Thank you very much for your kind attention. We move on to the next presentation by my good friend Dr. Narayanan Nambudri,
Yeah.
who will speak about SVT with wide QRS complex. In the he's
Oh, yeah, sorry.
his topic is a little
I
luxurious
was-
that he's straight away going into the EP lab.
Okay. No, sorry, sir. I thought you were going to talk about VT.
So now the loaded gun is with me. So in fact, it's on wide QRS tachycardia, though it is in the SVT session. We know the definition of a wide complex tachycardia. It's any tachycardia should be, the ventricular rate should be more than 100 beats per minute. And the QRS duration for a classical wide complex tachycardia should be more than 120, though you can have a relatively wide or a relatively, narrow at 100 to 120 milliseconds. This is the case not purposefully, but by serendipity, this is the same case which I'm showing, which Madam was mentioning and Dr. Natarajan was also explaining that time. You have a wide complex tachycardia, just transition into a narrow complex with a change in the cycle length. The wide complex tachycardia has got a longer cycle length and the narrow has got a shorter one, and the difference is almost around 32 milliseconds. So what is the possibility? In the EP lab, it is not unusual to have this transition, and these are the choices: ORT, right free wall, atrial tachycardia, ORT. So the answer is B. We all know ORT with the left free wall accessory pathway. With the development of ipsilateral multi-branch block, the conduction time through the, because with the right bundle branch block there is no change in this, but you have left bundle branch block, there is a change in the activation time. So there is widening of the circuit, lengthening of the circuit. So in the EP lab, when you have a wide complex tachycardia or narrow complex tachycardia in a case of SVT, in fact, it is only an epiphenomenon. It happens only in the ventricle. This aberrancy happens only in the ventricle, and it's often, unless you look at the ECG, it's often very difficult to find out the, of course, with the left bundle branch block, you have a late activation of the posterobasal left ventricle. But of course, this mechanism of the SVT or the circuit of SVT is often unaffected, unless in this case, like a orthodromic reentry with the ipsilateral bundle branch block. When you have when you go through the differential diagnosis, most often it is ventricular tachycardia. In SVT with aberrancy is the second most common. You have pre-excited tachycardia, you have antitromic, the classical one where you have antegrade conduction through the pathway and the retrograde through the his bundle. Then you have diodromic tachycardia through two pathways, SVT with a bystander. You have modified width of the QRS by hyperkalemia, pace rhythm, drugs, all these things are relevant. And most of the time, the diagnosis is often obtained based on the history, tachycardia ECG, intracardiac tracings, baseline ECG, and the diagnostic manuals. In fact, three important characteristics would help us to make a differential analysis in the EP lab. I'll be concentrating in this talk only on these 3 points because of limited time. One is QRS morphology. Second is his ventricular activation. And third is the atrial activation and atrioventricular relationship. So let us see the tachycardia in a case of SCT with aberrancy. As already mentioned, the aberrancy happens beneath the mechanism, like often away from the mechanism, unless it is a orthodromic reentry with aberrancy. In atrial tachycardia and AVNRT, bundle branch is not a part of the circuit. So it should correspond to a classical aberrancy pattern. Unless you have a typical right bundle or left bundle aberrancy pattern, practically aberrancy, SVT with aberrancy is not possible. Unless you have a pre-existing aberrancy, RVB left axis deviation, it is possible, but in a landmark study, it has been shown that it is less than 1%. A new onset bifascicular block coming up is extremely uncommon. Then HV sequence is a must, because all these supraventricular tachycardia, the wavefront comes down through the his bundle and then activates the ventricle. So HV sequence is a must. So HV interval is equal or slightly more because of the decremental characteristic of the conduction system, but it cannot be shorter than that. One-to-one AV relationship is almost a must. Atrial activation pattern is unaltered by the aberrancy, as I mentioned. Then you have a pre-excited tachycardia. Here you are short circuiting the normal his ventricular activation system part. So its HV is shorter than the normal HV. An ECG corresponds to a non-pre-excitation pattern. You may ask what is a non-pre-excitation pattern, but if you have a negative concordance, it cannot be a pre-excited tachycardia. Activation from the LV apex to base, you cannot have a pre-excitation. You may have an S in V6 in a case of posterolateral pre-excitation and all, as Dr. Natarajan had shown in a case of coronary sinus diverticulum, but it is often uncommon again. In atrial activation pattern, when you have a pre-excitation pattern and one-to-one AV relationship is almost always important, though you can have some of the rare pre-excited tachycardias like nodoventricular and with VA dissociation. VT can fit into any morphology. It need not be an aberrancy, it need not be a pre-excitation pattern, and VH sequence in most. Though HV could be positive and shorter than the baseline in cases of some of these fascicular VTs, HQ could be longer in bundle branch 300 VT, but often VH sequence is in most, and V more than A, and retrograde activation is concentric through the AV node if there is a one-to-one VA relationship. So we have gone through all these things. We will see some of these cases. You have got a patient with a near positive concordance and axis almost northwest, AVR is positive. So what is the mechanism in this case? As I mentioned, it is positive concordance in all the precordial leads. It could be a basal tachycardia originating from the basal LV. It could be a pre-excitation from a of course, a transannular classical pre-excited tachycardia through the mitral annulus cannot be SVT with aberrancy. Look at the baseline ECG after cardioversion. It shows a pre-excitation pattern, and this is after ablation. So baseline ECG is important. Even atrial pacing can induce some of this pre-excitation pattern. Two wide complex tachycardia, two different morphologies. These two are also very characteristic. They are not seen with SVT with aberrancy. The right one is RBUP with left axis deviation, classical or posterior fascicle. Unless you have a baseline which is not there in the aberrancy pattern, it cannot be SVT with aberrancy. Similarly, on the left side, you have got a LBUP with inferior axis. Again, that shows it is primarily a RV, outflow RV. There is no mitral annulus there. So it cannot be a pre-excitation pattern. Both of them are very characteristics of VT, and only rarely you can have SVT there. Again, reverse transition. When you have more A than B, again there is no confusion. It is atrial tachycardia or SVT with aberrancy. Here, a 30-year-old male with tachycardia, wide complex tachycardia, HV is negative, so it should be pre-excited tachycardia or a VT. APC pulls down the next V, and the VA interval remains the same, so it is resetting. So that shows it is a pre-excited tachycardia, ventricular extra stimulus, and atrial burst spacing also shows acceleration to the tachycardia to the spacer cycle length with the same morphology. This cannot be VT again. So these manuals can show clearly whether it is a VT or a pre-excited tachycardia in these cases. Another ECG, you have a wide complex tachycardia. The same patient, earliest activation is in the RV apex. So this is a Mannheim fiber, wide complex tachycardia, VH sequence, one-to-one AV relationship, early stay at his bundle. So it is VT antidromic tachycardia through right-sided accessory pathway. Here HV sequence is positive, it's a normal H followed by the V, and we know wide complex again, ECG fits into LLBB pattern, HV sequence, one-to-one AV relationship, early stay at HRA. So it is atrial tachycardia or orthodromic re-entry through a right-sided accessory pathway. A narrow complex tachycardia, relatively wide, but you can have a peculiar pattern here. HV is plus 6, not negative. Still it is lesser than a normal. That shows it cannot be SVT with aberrancy and VA dissociation. So this should be VT. And wide complex tachycardia, we'll just show. Here, they also look at the atrial activation pattern. This is a wide complex tachycardia. Clearly, we know the previous, like the previous case, positive concordance, non-pre-excitation pattern, and the earliest A in this case is in the HRA. It was a duodromic tachycardia, the retrograde conduction through an accessory pathway. There are certain interesting cases like a tachycardia with the 2 to 1 VA in this case. Not always it is simple. RR alternates and QRS alternates. QRS morphology LV with the left axis. Transition, it's alternating it's between V1 and V2. HV interval negative. This was actually a antidromic nodoventricular pathway with a retrograde 2 to 1 conduction. So this tachycardia could be very, uncommonly seen, but generally the differential diagnosis, the first one is VT, and always look at the QRS morphology, HV activation sequence, and third one retrograde or the atrial activation pattern and AV relationship in all these cases. That could make the, these are the clues to make a clear diagnosis in the EP lab. Thank you.
I think we are all sufficiently confused. I thought I knew the topic.
I now indeed the Lord and completely.
Very.
10 minutes is sufficient enough to confuse anybody.
Thank you, Dr. Nambudiri, for that excellent overview of the three common varieties of supraventricular tachycardia. The broad QRS tachycardia, one is SVT with aberrancy, pre-excited supraventricular tachycardia, as well as ventricular tachycardia. And you went through the steps. In the short time, it is not possible to cover this topic in great detail. You also stressed upon the importance of looking at the HV interval towards diagnosing SVT with aberrancy if it is either the same as in sinus rhythm or longer, as you said. Just one question. If you have a patient coming to the outpatient department with a wide QRS tachycardia, how do you differentiate ventricular tachycardia versus an antidromic AVRT if you were blinded to the ECG in sinus rhythm?
Okay. If, as I mentioned, if you have a classical pre-excitation pattern that is likely to be pre-excited, in the absence of a classical pre-excitation pattern, a pre-excited tachycardia is very, very unlikely.
What do you
and
mean,
also,
what
like,
do you mean by the classic pre-excitation?
You have a pre-excited tachycardia with which follows the left-sided pathway or a right-sided pathway, R dominant in the, predominantly R rather than S dominant in the precordium. And if it doesn't, if you have a negative concordance in all the ECG, or negative precordial concordance, you know it cannot be activation of the ventricle is not basal to the apex. So that is very clear. And also other factors like a patient's age, coronary artery disease, LV function, and all these factors, unless it is proven, always you manage it as a VT, because chances of that being a pre-excited tachycardia is much lower. VT is much common, like 85% compared to 5%. So it is almost 17 times more common.
So in olden days, they used to say, no, rabbit ear pattern and triphasic pattern and all that. That is not that useful nowadays, I think.
That is to differentiate between SVT with aberrancy versus ventricular tachycardia.
Then one
Those
more
things are basically when you have a pre-excited tachycardia, it almost behaves like a ventricular tachycardia because early activation of the ventricle is side to side rather than linear, and all those manifestations may not make. That's the most difficult tachycardia to differentiate in between.
No, so can we say that if you get a deep S in V6, it's more likely to be a VT?
Yeah, deep S in V6 can occur in VT and also in a pre-excited tachycardia with a coronary sinus diverticulum, because there the earliest activation is actually somewhere into the mid ventricle, and the last part of the ventricle to get activated is the RV, which is right anterior and superior. So S in V6 would happen in that.
So actually both of them we can treat with a DC shock.
Yeah.
And then take a baseline ECG and then decide what it was.
I think
Can
that's
it be
what
like that?
I showed that. What is rose? Even if you call it by different names, ultimately it smells the same.
Thank you, Dr. Nambudiri, for that excellent presentation. Now that we have gone through the importance of clinical evaluation of a patient with supraventricular tachycardia, from narrow we graduated from narrow QRS to wide QRS supraventricular tachycardia. So we'll now postgraduate. So Dr. Bhim Shankar will speak on. There are the two common supraventricular tachycardias, which is bread and butter for the electrophysiologist, is PSVT, either AV nodal reentry or an AVRT mediated by an accessory pathway. So it's worthwhile understanding how we ablate these tachycardias, what are the practical difficulties, how do you diagnose, what are the tips, tricks, how do you make it easy, simple to understand. So AVNRT, we'll start with AVNRT. Dr. Beam Shankar will speak on tips and tricks of how to ablate AV nodal re-entry ablation. Yeah, over to you, Dr. Beam.
Thank you, sir. Good evening, everybody. My task is specific. It's specific on tips and tricks in AV and RT ablation. So what I've done is in the next 10 minutes, structured it this way. We'll look into the goal of ablation in AV and RT, some relevant anatomy and the circuit construct, the choice of catheters, the choice of sheets, the ablation settings, and how do we troubleshoot when unusual situations occur, and does atypical AV/RT ablation differ from typical AV/RT? The goal in AV/RT ablation is either slow pathway modification or elimination of 1:1 conduction over the slow pathway. And this is applying to all forms of AV/RT. Given at the tip, it's similar for typical and atypical AV/RT. So the acute success rate in most series is about 97 to 100%, and the recurrence rate is 0.7 to 5.2%. The incidence of AV block is about 0 to 3.4%, and the need for pacing is 1%. So I think this will be by far the most commonest arrhythmia that most Indian EPs at least will encounter in their career. It may be imperative to at least reach these standards in our practice. This schema gives us a stance of what the anatomy, the area that we're going to ablate is. The Cox triangle, the apex of the Cox triangle has the compact AV node, and it receives at least 3 well-defined atrionodal inputs and also other infront atrionodal inputs that could actually cause the atypicality in AV/RT. The superior input actually connects to both the atriums. The right inferior input is a target for slow pathway ablation. The first target has connect again to both the atrias and through the CS musculature. The left inferior input, the atrionodal input, is connected mostly to the left atrium through the CS musculature and the mitral annulus. Most accepted, the old concept of longitudinal division is gone, and the most accepted construct for the circuit in typical AV/RT is that the antegrade pathway, antegrade circuit is the slow pathway, the infranodal right inferior extension of the compact AV node or the inferior extension, and the retrograde path is the superior atrionodal extensions. So the target is the inferior extension, that is the isthmus, the narrow isthmus between the CS ostium and the tricuspid annulus. Looking at this, you can imagine the structure of the anatomy where the compact AV node would be, and then that's the left inferior extension and the right inferior extension. And that will be the antegrade pathway for the circuit, and the fast pathway, which will be the retrograde part of the circuit, is at the superior extension. So the target is a narrow margin between the CS ostium and the tricuspid annulus. The Cox triangle can be actually depicted on the fluoroscopy in the lab, and we can use the shafts of the CS catheter, which is placed in CS, and the his catheter after its place. So the tricuspid annulus would actually border the CS catheter, and the red line corresponds to that. The tendon of Todaro would be at the shaft. You can imagine it to be at the shaft of the his catheter, proximal his catheter, and that will be the green line. And we reverse it in LAO, that will get us to the base of the Cox triangle, where we would be the target for slow pathway modification. Predominant EGM based ablation is practiced in few labs, and what is targeted is the slow pathway potentials for the typical AV/RT, and for the atypical AV/RT, both the slow and the fast slow AV/RT. What is targeted is the retrograde slow pathway activation. However, by far world over, what is practiced is a combination of both electric EGM based and anatomy based, and you can call it electroanatomic approach. The first target is the tissue between, like we've been alluded to, the tissue between the CS ostium and the tricuspid annulus at the level of the CS ostium. When you fail, when this area is futile, the next step is to look for the left-sided extension, but there are centers or some labs who would actually ablate within the CS, which probably increases the risk of AV blocks. And the desired AV ratio at the site of ablation is anywhere between 1:3 to 1:10. A word on how we do it in the lab is to advance the ablation catheter preferably in the RAV view along the His catheter and deflect it down to the imaginary portion of the Cox triangle's base, and then withdraw it gradually, progressively back, and the marker could be between the two dipoles of His catheter, and then in LAV view, a gentle clockwise torque would probably land the tip of the catheter at the slow pathway area. So that's again marked in this anatomy where you can target the slow pathway area. Generally, non-irrigated 4 mm tip catheters are used. The workhorse catheter is usually a medium curve catheter, but you can choose a F curve catheter, large catheter, in case the atrium is large. And people who are familiar with both Biasens Webster and therapies, what is used in our country, either the Celsius group of catheters or the therapy catheters. Like we've been, if access, or if there is a scenarios where you can have a Eustachian ridge that is prominent, it'll push the catheter away from the slow pathway area, and therefore using a sheath for stability, preferably the SR0 sheath, would actually make your procedure easy. This is again was shown in the previous talks. The AV signal ratio that is desired is usually less than 1. What is desired is more than 1:3. And a multi-component atrial signal at the ablation site is again desired. One of these multi-component could be slow pathway potential, but that's difficult to validate. And another desired signal would be that the atrial signal should be at least 30 milliseconds in comparison to the atrial signal at the his location. The typical temperature settings are the target temperature is 50 to 55 degrees centigrade, and this is achieved with a delivery of 50 watts. Some centers do start with lower watts, and probably that's a safe way of doing it. RF ablation is performed for 10 seconds, and if you don't get junction rhythm, it's not elicited, it's preferable to stop and further fine-tune your mapping. And if a junction rhythm is elicited, you continue it for 60 seconds and carefully watching for VA block and AV block. And although junction rhythm is not a specific marker, it's sensitive, and most series have shown that successful sites have always had junctional beats. There are scenarios when you have tried several times, 10-second burns, and then after a minute or so, if you look for induction, the slow pathway may not be there, and this is scenarios that can occasionally happen in the lab. The duration of the junction rhythm also has shown a positive association with more favorable outcomes. And we should vary that development, having fast junction is a sign of impending AV block, and therefore you need to stop. A cycle length of less than 350 milliseconds, it's preferable to stop and then again remap. How do we ensure safety in the lab? If you keep the catheter below the ostium of the coronary, practically that eliminates the risk of AV block. When you don't get junction there, we tend to move up slightly, and the maximum limit to which we can move up is probably the CS roof, and moving beyond that would be with the risk of developing AV block. Once got 2 minutes. Once we don't get junction, these safe locations, the approach is variable. Some centers do ablate within the CS, looking for the left-sided inputs, or move up further, and with this is with the risk of increased risk of AV blocks. So there are scenarios that we may have to troubleshoot. One is poor catheter stability. SR0 sheath is a good sheath which comes in handy. When you have no junction rhythm, we just discussed there are two approaches, either within the CS or going to the left side. Sometimes there's a tachy induction immediately after delivering energy, and this can be circumvented by doing ablation during atrial pacing. This particular issues can occasionally happen. You can have a distorted Cox triangle. Two scenarios that can happen is one in an elderly octogenarians where the Cox triangle is flattened and longitudinal, and therefore it's a compressed, the distance, the margin between the compact AV node and the CS ostium is narrow. So you need to be more careful and use sheaths and for stability. And similarly, a patient who having persistent LSVC LSVC with a large coronary sinus would again compress the compact AV node, and therefore the distance between the compact AV node and the slow pathway area will become narrow. Patients having pre-existing long PR, there's data to say that these patients do have a higher risk in long run, but at least the acute success is similar. This is just a scenario when you have when the common safe location is futile, move on to the left side and target the inferior mitral annulus area. This is just what I alluded to in large coronary sinus, and in a flat Cox triangle, you will have issues. You need to use sheets and consider. So I'll finish off with what do we do in atypical AVNRT. Now it's clear that atypical AVNRT is circuits, the constructs between both the inferior extensions, and it is fine if you just define atypical AVNRT, unlike instead of using the AH and HA ratio, it's just if the HA is more than 70, it becomes atypical AVNRT. And predominantly all of these circuits is between both the inferior extensions, and the antegrade pathway would be the right inferior extension, and the retrograde pathway circuit would be the left inferior extension. Eventually, the target is again the same location between the CS and the tricuspid annulus. So I'll give away some takeaways and stop. Electroanatomic approach to slow pathway modification is widely practiced. It's combination. Confining to the safe zone almost eliminates risk of AV block. Left-sided inputs may have to be targeted in rare instances. We should be wary of some distorted anatomy and use sheets and other techniques to avoid AV blocks. Atypical AVNRT ablation target is similar area, slow pathway area. Thank you. I'll stop there.
Yeah, that was a very good topic. Meera is also the chair, so I give her a chance.
Beam, what I would like to ask is how frequently do you go to the left side?
Well, I can even give my numbers because very rare. So 3-4 cases when I was in my earlier center in Chennai, I actually done in the last 10 years only once. In Kerala. My denominators will be less. So
Not us doing it, but we have seen Ullas Pandurangi coming and doing for us when we just started doing EP.
Beam, I have seen that in several times when we are doing AVNRT, the CS os is very patulous. The CS os. So the ablation keeps going into the CS.
So you have to counter.
I know that, but what is the mechanism of this patulous CS os? Is there any cause?
Yeah, I think this I seen most elderly patients. When you start clockwise and place it and then jumps into the CS.
I think everything jumps into the CS. That's what you see. So once everything jumps into the CS, I think it is a AVNRT. That's what we have seen. Pardon me? LSPC. So it is large. Now, how frequent is LSPC in AVNRT? I'm not
Very
sure.
less, but even then it can jump in, even if the CS is that you have to counter.
No, but this is very common. We have seen it several times happening. Anyway.
One comment regarding whether how to approach to a CS when you apply towards CS. See, if when during the AVNRT, if the earliest day is in the coronary sinus, then yes, then I think you should aim for or what we used to earlier call as posterior AVJRT. If the earliest day is in the CS os, then you aim towards posteriorly. Not necessarily slow. It's just basically more than 70 milliseconds. But the earliest day will be towards the CS os, as compared to a standard AVNRT where it will be in the his bun.
Excellent talk, Dr. Beam. Few things I wanted to ask which is practically relevant. If you did not use isoprenaline to induce the tachycardia at baseline, do you use isoprenaline post-ablation?
It's recommended and I use.
Because I have seen many centers saying that if AVNRT was inducible without isoprenaline provocation, after successful ablation, you don't have to actually use isoprenaline. I do not know the practice in, for example, in SCT, what do you do, Dr. Nambudri? Quick answer. In milliseconds. Pardon?
In the beginning.
That's correct. That is one thing I wanted to ask you. The other thing was sometimes we don't get junctionals at all. So can you, and we have seen that after a good signal, And without junctional, we have seen that we have eliminated slow pathway conduction for totally, or we have modified it and AVNRT is not inducible. In such cases, probably isoprolol can be given. Any take-home points?
I was just saying this. There are scenarios when we keep giving this 10-15 second, keep don't getting junctions. And when the cumulative number of lesions have crossed 2 minutes, you check and sometimes they are gone. We tend to again use isoprolol in these cases and see if you have eliminated the path.
Okay. So thank you, Dr. Beam. That is an excellent talk on a very common arrhythmia that we ablate. Thank you very much for sticking to time. And we move on to the next common PSVT, that is again bread and butter and a very interesting arrhythmia, because unlike AV-NRT, which is more anatomy-based ablation, here it is more signal-based approach. And we move on to accessory pathway ablation. And to talk to this, we have eminent electrophysiologist in our country, Dr. Ajit. Over to you for your 10-minute presentation on a very complex subject.
Thank you, Dr. Natarajan. I understand you finished 50 out of your 100 slides. I'll try to finish 25 out of my 50 slides if I'm lucky. So I don't care if the screen is going to start, I'm going to start. Okay. I can't make it easy in 10 minutes, but I can give a few tips. One, the part of the difficulty is regarding anatomy. The other part of the difficulty is regarding electrograms. So the general principle is identify the annulus in right anterior oblique view and then go to left anterior oblique view to navigate the annulus. So like Beam alluded to, the tricuspid annulus will be anterior to the plane of the CS catheter in the right anterior oblique view. But sometimes you get perfect A and V signals and the pathway doesn't go. And this often happens in the inferior part of the tricuspid annulus. What is happening here? If this happens, look for this. This often happens because you're stuck in a subeustachian pouch. Some people have a large subeustachian pouch. It may be seen by direct injection or it may be seen by just the contrast coming down. Now, this often happens when you try to get posteroseptal. Catheters here, you don't get good VA or good AV, and then you move here and you get good AV. So what I'm trying to say is from the pouch you can get a perfect A and V and nothing will go because you're not on the annulus. So what's the solution? Whenever you ablate in the inferior part of the tricuspid annulus, get a good A and V, move the catheter forward to get a full V, only V, and then pull it back. Then you know that that A and V is the annulus and not the pouch. You cannot push your catheter in the pouch and get a complete V. The second thing which you have to understand is that the CS is only a guide to the annulus. The annulus is made out by high frequency A and V signals. So don't believe that the CS or the right coronary artery is on the annulus. That's only a guide. Third, if you have a superior tricuspid annulus pathway, do not forget the jugular approach. It's actually very stable and much easier to navigate. Here, of course, I'm doing a right posterior pathway through the superior approach. But if you have a superior pathway already localized, put a 7 French neck sheath and keep that option open. And also in a para-Asian axillary pathway, plan for an elective gentle anesthesia with apnea during radiofrequency ablation. Often makes the difference between a successful and unsuccessful ablation. What is not clear in LAO is that the tricuspid annulus is not in one plane, it's inclined. See, the lower part, the inferior part is more posterior and the superior part is more anterior. So this causes a problem when you navigate the catheter. That is, it's easiest to enter in the medial part. If you enter in the medial part with a large V and then you counterclock laterally, you will get a perfect A and B. But if you enter in the medial part with a perfect A and V, when you counterclock laterally, you will have only an A. So if you want a good A and V laterally, enter medially with a large V and a tiny A and simply counterclock. Don't expect the A and V ratio to remain the same. That's because the annulus is inclined. It's not in one straight line in LAO. So this is the line that the catheter will take. This is the line that you want it to take. Otherwise, you keep pushing it down. These sheets are very helpful. They're increasingly difficult to procure, but these SR sheets are very helpful on the lateral tricuspid annulus. I always use the SR3. The other problem is the tricuspid annulus in Epstein's. The annulus stays where it is, the valve goes forward. So you find it difficult to find where is the annulus. So one simple clue is it will correspond roughly to the mitral annulus, where it should be. or it will roughly correspond to the right coronary artery. The problem is, along the real annulus, there will be a huge groove because the atrialized right ventricle will be, big, and it will make the groove very, very prominent. You will have to use a deflectable sheath there. You might have to use an intracardiac echo to ensure that you are touching it. Because the signals will be like this. You can hardly make out A and V. So when you cannot make out A and V, whether abstains or not, always paste is cause VA block or AV block so that you know which is A and which is V. The mitral annulus, this is the area where you don't get a pathway. These are the areas where you get pathways. So again, the mitral annulus may be in the plane of the CS. It may be anterior to the plane of the CS. It may be just posterior to the plane of the CS. So identify it by the A and V signals, not exactly insisting that's on the plane of the CS. Your catheter orientation is very important. Keep your catheter as parallel to the mitral annulus to get perfect AV signals, perfect bipolar signals. With this orientation, if you don't get good signals, it's because your catheter is not oriented parallel to the annulus. To get bipolar signals, you should be parallel to the tissue that you're recording. The retrograde approach is very good for pathways which are very high up, somewhere around 2 o'clock or so. But remember, when you go retrograde, you must enter into the left atrium and be able to deflect very freely like this. So the fluoroscopic correlate is this. You will see the catheter bobbing very easily in RIO and LAO. In this case, you will be able to get very good maneuverability and low impedance and good power delivery. But if your catheter is like this when you enter retrograde, you are under the mitral valve, the ventricular aspect of the mitral leaflet. The maneuverability is poor, the impedance will be high, power delivery will be very poor. So if you get this sort of location, straight away reposition your catheter to get the previous type of location. Rarely, though, you might have to purposefully ablate under the mitral valve, especially if you or somebody else has given unsuccessful lesions on the atrial aspect. Then you might have to actually do this. Go antegradely, go under the mitral valve and come up under the mitral valve deliberately. This has been alluded to. A negative delta merging imperceptibility at the end of the P wave is a very sensitive finding, but not a very specific finding for a epicardial X-ray pathway. But when you see this, be ready with an irrigated catheter. You don't expect good endocardial signals. Now try to look for a diverticula. Sometimes you don't get diverticula. It just means an epicardial pathway go inserting closer to the apex than to the annulus. So in this particular case, actually the pathway was in a posterolateral vein. So it doesn't mean it doesn't mean the diverticulum. It can be anywhere epicardial. So in this case, you might have to be ready with a small catheter, and you will get it in the posterolateral vein. The problem in the posterolateral, so there's a clear pathway potential. The problem in the posterolateral vein is it will go away within a second, less than a second. One beat, it's gone, but it will come right back. Because your impedance will be very high and your power delivery will not be achieved. Try to get an irrigated catheter, but sometimes you cannot get an irrigated catheter. So in that case, what you do is just connect one more patch. Lower the baseline impedance, you will be able to manage it with the same catheter. When you have a coronary sinus diverticulum, almost always the X-ray pathway is in the diverticulum. But what you need to do is look for the EP findings. Unlike the endocardial accessory pathway, where you always look for a pathway potential when you have a diverticulum, because you're trying to ablate the pathway potential, not the earliest V. The earliest V will be very distal down here. So it will be like this. You will get the accessory pathway potential, but unlike endocardial accessory pathway potential, I'll skip this part. So the accessory pathway potential in a CS diverticulum will be, this is the accessory pathway potential here, this one here. It's on the A. It is nowhere near the V, because the V is way down towards the apex. Whereas in an endocardial accessory pathway potential is here. I hope you can make out this tiny slur here. This is the accessory pathway potential. You will get this type of a unipolar. You will get only this type of a unipolar at a successful site in a CS diverticulum. But importantly, the accessory pathway potential is on the V, not on the A, sorry, not near the V. Straight versus oblique pathways. This is the simple thing I do. For manifest pathways, pace A, check the site of the earliest V, and then check the site of the earliest A. If the site of the earliest A and the site of the earliest V is the same, the pathway has to be straight and not oblique. It's a very simple thing you can do. But some pathways are oblique. The simplest thing to understand is most pathways are slanted A to V in the direction of the annulus, meaning it will be A will be here and V will be here. So you pace a wavefront to cause this. So in a left-sided pathway, you just pace from the RVOT. In the right-sided pathway, you pace from the RV free wall, so that you separate the V accessory pathway potential and the A. So this is pacing the base. Lead 2 is negative. This is pacing the RVOT. You can see the tiny pathway potential here. As I'm moving the catheter towards between 5, 6 and 3, 4, you can see the pathway potential is much better here. And here the pathway potential is much better, but you get this, you see, you don't see it when you're pacing from the RV base. You get it only from the RVOT pacing. And then you ablate, and when the gap between the V and the pathway potential increases, the pathway disappears. Importantly, the unipolar 1 and unipolar 2. Remember, you're mapping bipolar, but you're ablating from unipolar 1. So unipolar 1 is very important. Your unipolar 1, the onset of the steepest slope in unipolar 1 is where your activation starts. This is not good enough. There's a huge gap between A and B. And the slope in unipolar 1 is too shallow. You need this. You need a steep slope in unipolar 1, and there should be this PQ unipolar in addition to the fused bipolar. And you can use this unipolar even in the non-fused VA orthodromic AVRT. That's a difficult one. You don't get a fused VA anywhere during orthodromic AVRT. Simply look for the unipolar in unipolar A in your mapping catheter. So here's the mapping catheter. The earliest bipolar A corresponds to a steep negative unipolar A. That's the simple thing to do when you do not get a fused VA during orthodromic AVRT. And here you can see that in about 1.5 seconds it's gone. And finally, AVRT versus AVNRT or concentric versus VA confusion. Do ventricular pacing and his refractory PVCs from the RV and the LV. In this case, a left ventricular his refractory PVC, V1 is positive, has reset the A and advanced the tachycardia, but the same one, V1 negative from the RV, did not enter the circuit. Not bad. I finished my 51 slides. Thank you.
Thank you, Dr. Ajit, for alluding to some of the tips and tricks in more complex than simpler axillary pathways, isn't it? So recently I had a patient from Maldives who had undergone a mitral valve replacement with a bioprosthetic valve, and he had a transapical redo mitral valve procedure, again back in some Cleveland clinic in Abu Dhabi or somewhere. He came with recurrent palpitations, and the sinus rhythm ECG showed what looked like a posterior axillary pathway transition. The QRS was positive all the way from V1 itself was positive to 3AVF was negative. So we thought it could be a posterior axillary pathway. Can there be a left-sided axillary pathway when the valve has been replaced? Is it possible?
Yes.
It's possible, isn't it?
Yes, it has happened. That's one of the worst things to happen.
Luckily, in this particular patient, we could ablate it within the CS. Yeah. So that brings my next question. In which left-sided pathways you will upfront go into the CS other than diverticulum-like situations, where you will finish endocardial mapping, you don't succeed and then go to CS, versus this is an epicardial thing, I better go through the CS itself. What is that distinction?
So what I've seen is sometimes you get a perfect signal in the CS, and you cannot get that type of a perfect signal anywhere in the endocardium.
That means you've already punctured the septum.
Yeah.
I'm telling you, without even transeptal puncture. This is the epicardial pathway, I better do it.
I don't do that.
Unless there is a CS diverticulum.
Unless there is a CS diverticulum, I'll always map the endocardium first.
Yeah. The patient that I alluded to, because of this prosthetic thing and confusion, I went into the CS. It was in the level of CS 5-6 actually. Yeah. Completely fused VA earlier than any other location.
That would be reasonable, because there the endocardial annulus would be unapproachable. But otherwise, I wouldn't, unless there is a diverticulum,
PGRT is epicardial.
Because all we are seeing is fused A and V. We are not seeing the pathway. I would always map the endocardium before going into the CS.
The proportion of getting this within the coronary sinus is much more if the patient had a failed endocardial ablation in the past.
Yes.
This we had encountered in a few where we had actually gone into even CS1-2 and ablated with a single one.
Any precautions you take? Irrigated catheters, I presume?
Yeah, we try to take irrigation, but generally may not take all the curves sometimes. We have to use the non.
Some of your cases you have done transeptally, some you have done retrograde. Any choice, any particular case?
It's very high up, I go retrograde, about 2 o'clock or so. Extremely high up. Transeptally, sometimes the catheter doesn't stay that straight with stability.
Anyway.
This CS, if I had to go, I'd straight away put an Agilis into the CS. If I had to go into the CS. I'd wire the CS and then put an Agilis there and then take the catheter.
Wire through which catheter?
Put an AL. Through the AL, put a exchange length thermo into the
Through
CS.
the jugular axis?
No.
Femoral itself?
Femoral axis, AL, exchange length thermo into the CS. And then over the exchange length thermo, get an Agilis into the CS.
Okay. Sometimes this ampullars from the groin sometimes doesn't engage the CS in some cases. Yeah. Thank you very much, Dr.
I'll just ask one silly question. What about anticoagulation in patients with prosthetic valve and the EP study?
Anticoagulation doesn't really affect the EP study. It's only the femoral puncture. If you can do a good femoral puncture, anticoagulation is not a problem. So what I would do is, nowadays there are interventional radiologists available everywhere. They just come with the ultrasound and give you a puncture. So anticoagulation doesn't matter.
Thank you, Dr. Ajit, for the nice talk. So we come to the end of an exciting session on a common arrhythmia that we come across in EP practice, that is supraventricular tachycardia. So we went through narrow QRS, wide QRS, and the two common ablations, and all speakers, including me, did a good job. Thank you very much for your kind attention.
Thank you, sirs. Now going to the next session. Next session is very interesting. Like as you can see, the topics are also very interesting titles everyone has created. So this is like how I made the diagnosis, challenging arrhythmia cases presented by people from various institutes, experts from various institutes. So our chairperson for the sessions are Dr. Bhimashankar PR, Dr. Narayanan Nambudiri, and Dr. Shiva Prasad K. I invite all of them to stage.
I think we will start the session straight away. This is one of the ways to make it more interesting. EP is made interesting by changing the titles, but don't be fooled away by these titles. It is still likely to be more complex. And we have a great electrophysiologist, Dr. Arun Gobi, starting the show.
So I think, respected chair and friends, I think the most interesting thing of this presentation will be the title alone. So this is a story of a 38-year-old recurrent incessant drug refractory put as represented as narrow QRS tachycardia treated at 2 centers, tried with every form of drug, adenosine, amiodarone, diltiazem, no response to any form of pharmacotherapy, and referred in view of drug refractory incessant tachycardia. And this is the ECG. So on the ECG, you can see that it's basically tachycardia running about at 190 beats per minute. You have right bundle branch block, left axis deviation. I think after Dr. Nambudiri's talk on approach to wide QRS tachycardia, the diagnosis is very clear here. The QRS is seemingly about 120 milliseconds, and you have this red arrow marks proving that there is VA dissociation. So when you have a seemingly wide QRS tachycardia with VA dissociation, that the common differentials are that you are dealing with a conduct system VT. Since it engages the conduct system, you tend to have reasonably narrow QRS, where the commonest one is left posterior vesicular VT. The other differentials are AVNRT with an RBB aberrancy if you have an upper common pathway block, orthotomic AVRT with RBB aberrancy mediated by nodoventricular and nodovesicular axillary pathway, very rare. Dr. Nambudiri sir showed as the last case of his presentation. JET with a rate dependent aberrancy, again very rare. So this is the ongoing tachycardia brought to lab in ongoing tachycardia. We put in the catheters. The catheters again show convinced us that there is VA dissociation. We have more QRS than the A's. These sharp big signals are the A's and the CS. So you have VA dissociation. In some of these conduction system tachycardias or conduct system VTs, we are able to entrain them from the atrium. So we do a rapid atrial pacing, but we are not able to engage the tachycardia. No change in the tachycardia cycle length or QRS morphology. We give adenosine in the lab and see, again, no response to adenosine in this tachycardia. So we put in the catheters and see this is the HV during the tachycardia. So HV during tachycardia is 19 milliseconds and the HV during sinus rhythm is 35 milliseconds. So you have a HV which is narrowing down during tachycardia than the sinus rhythm. So that makes our differentials quite narrow. There is no termination of tachycardia with adenosine, and HV during TAC is less than sinus rhythm. And this clearly puts up as a diagnosis probably a ventricular tachycardia, something originating below the His with retrograde activation of the His, causing a shorter HV during tachycardia than sinus rhythm. The His is activated retrogradely, that's from distal to proximal, so that's why you generally tend to have a narrower HV during TAC than sinus. And then what is the mechanism of VT? We put in fancy colors. This is the 3D electrodynamic mapping. So the earliest activation is guided by the white spot and the late one is purple. So you see some earliest activation in the basal septum. The earliest activity is about 42 milliseconds prior.
And so here it's based on the 3D map. It's either a focal VT from the basal septum or it's a micro re-entry happening there. We start entraining, I think Anis had alluded to. So we are pacing from the right ventricle. So you are accelerating the tachycardia and the tachycardia continues. So we are able to entrain the tachycardia and certain that the mechanism is probably a re-entry. It's probably a micro re-entrant tachycardia. And so once you have ascertained that it's a micro or it's a re-entrant VT, we decide on looking at the response to entrainment and finding where the circuit is. I think this was alluded to earlier. So if you have concealed fusion, you are in the circuit, and if the PPA is less than 30 milliseconds of the tachycycle length, the probably in the isthmus. If not, you are in the adjacent bystander. If you have manifest fusion and if you have a short PPM anesthesia, you're probably in the outer loop. So we start entraining from each part. We entrain from the right side at his. You find that the PPA, there is manifest entrainment. So you can see that the QRS morphology is changed during the pacing capture, but the PPM anesthesial is short, it's 15 milliseconds. So it suggests that we are inside the VT circuit, but probably in an outer loop. We start entraining from the basal septum. Again, you have concealed entrainment. So you have capture of the tachycardia, the QRS just simulating to that of the tachycardia. So that's concealed entrainment with a PPM anesthesial of 60 milliseconds. The stim to QRS and the EGM to stim to QRS is more than the EGM to QRS. There's a potential there. You can see there's a potential there, and potential is preceding the QRS by almost 55 milliseconds. So this indicates that you are pacing inside the VT circuit, but the PPM anesthesial is long, suggesting that it's probably an adjacent bystander. From the mid-septum also, we are finding similar response, suggesting that again it's an adjacent bystander. Here the potential to QRS is about 65 milliseconds. So based on what we did entrainment, we find that we found lower septum, apex, everything out of the circuit. The his was actually having probably looking like an outer loop. So the upper part, the basal septum and mid-septum was actually showing concealed entrainment with PPM anesthesial more than 30 milliseconds, suggestive of an adjacent bystander. So the circuit is somewhere between those two. So this was probably where the circuit is. We start mapping there, and we suddenly bump terminate the tachycardia. For the first time we are seeing sinus rhythm in him, because he was in incessant tachycardia. And when we bump terminate the tachycardia, we start looking at the site where we bumped. We have a very prominent his potential at the site. We have a very prominent potential at that site. Since he was in sinus, we quickly map the his bundle potential and the left bundle potential on the 3D, tag these sites, and then we start mapping near that. We also, when we had sinus rhythm, we start comparing the sinus rhythm QRS and the tachy QRS. We clearly see that the axis is almost same, but there is a right bundle branch block. Probably this is actually collaborating to typically described upper septal VT type 2 pattern. So again, we start mapping the conduct system whenever he was in sinus rhythm. We map and tag the left bundle and his bundle potentials. And then we go at this site, just near the left bundle potential. You can see that this is a site where we had a potential which was almost 42 milliseconds preceding the local EGM. This is a site of bump termination. When the tachy spontaneous reinitiated, it was 42 milliseconds earlier than the local EGM. And the moment we start ablating there, the tachy terminates in 6 seconds. And this is very close to the this is fluoroscopically the position very close to the left side at his and the left bundle. And possibly I'm seeing more, but this is actually the ablation site. You can see sharp potential preceding the local EGM in the ablation signal, and then it terminates. Probably some of them might be presumptions as the P1 and P2, and the P1 goes after the QRS in sinus rhythm. And then during the continued ablation, we monitor the PR and HV interval, ensuring that there is no AV block, because that's what we are concerned, because the ablation site is just 5 millimeter away from the left bundle side and 6 millimeter from the his bundle. And this is possibly the circuit that we are alluding to. It's an upper septal VT. The difference from the common ILVT is the way of activation of the left posterior vesicle. In the upper septal VT, there's antegrade activation of the left posterior vesicle, and in the common left posterior vesicular VT, there's retrograde activation of the left posterior vesicle. Although these circuits are still debated about. And these are the type 1 and type 2 that I alluded to. And typically, this is the site where we are alluding to the upper slow common area, which is our target of site of ablation. And you see that this is the activation pattern of the conduct system here. It's just the reverse of what we see in typical ILVT. And you find that there's a left bundle potential in the proximal electrode, but no left bundle potential in sinus rhythm after the site of ablation. And no tachy after ablation. And this is the post-ablation ECG. So to conclude, upper septal VT is a rarely encountered arrhythmia among most of the wide QRS tachycardias that you see. Most of the time it presents as incessant tachycardia. Sometimes it is seen after a previous attempt of RFA for a posterior vesicular VT. It may indeed mimic an SVT because of seemingly narrow QRS rhythm, because the QRS would roughly be between about 100 to 120 milliseconds. And some of them are responsive to verapamil and adenosine. The type 1 variant has almost similar QRS morphology and acts as a sinus. That's why it usually gets missed as a SVT. Entrainment mapping is useful for defining the isthmus circuit and probably alluding to and getting into a site where you can avoid the conduction system and deliver the therapy without damaging the conduction system. Ablation in the upper septal region again has high risk of AV block. So during ablation, go at slightly, we started at 30 watts and then went up to 35 watts, monitoring the AV conduction slowly.
Great case, Dr. Aaron. Lot of learning points. Many times we get calls for patients with incessant tachycardia, often narrow or wide or in between, and they don't respond to adenosine, don't respond to amiodarone or even to cardioversion. And it's more than 50% of these cases turn out to be a posterior fascicular VT. And clear demonstration of this entrainment patterns. I also thought in the beginning itself it is likely to be proximal, because when you do an entrainment in this posterior fascicular VT, it's nearly impossible to get a concealed entrainment. So most often we look into the post-pacing interval only. So if you capture the perifascicular tissue also, you lose the concealed fusion. There will be some manifest fusion, but often we look at the post-pacing interval only. And there you had the lowest plus 15 milliseconds.
Concealed entrainment on the right side it is.
Great case. Thank you.
Question, Dr. Arun. Suppose the hypothetical.
You suspect this?
So typically there are two patterns, as I said, type 1 and type 2. Type 1 will have exactly similar QRS morphology as sinus rhythm and exactly same axis. It's actually having an upper turnaround, and that will have even an HV during TAC, which is slightly longer. So it will exactly mimic sinus rhythm QRS, and only thing you need to look for VA dissociation. The type 2 pattern has a slightly lower turnaround point. That's when you get RBB morphology with normal or slightly right axis.
Dr. Arun, I just wanted to ask, suppose a hypothesis it didn't bump, how do you map? You look for the earliest P1 or latest P1? No, which is safer? Which location will be safer?
Yeah, so if you go by P1, P2, the earliest P2, there you get the earliest maximum separation from P2, that's where we would ablate. The uppermost part actually. That's the upper turnaround point actually. Because here it's the reverse way of activation. So your P1 will come down like this and P2 will go up. So so when you go upper on, your P2 comes the last actually.
So would it not be safe to?
We had 65, upper part we had 55, and we ablated for 42.
Yeah, thanks. Thank you.
The upper septal VT is usually we map with the usually activation mapping and keeping the signal away from the east bundle or cleft bundle. So entrainment I have not yet got for upper septal VT like this. Can you show that entrainment once again? And will it be possible to entrain from the anterior fascicle region and posterior fascicle region, and not just from the proper upper septal following both?
Yes, the turnaround point is quite superior. So and you're capturing in the circuit the anterior fascicle and posterior fascicle is antegradally activated. So probably you will be able to entrain with concealed entrainment from the upper part only, from the superior part only, not from the anterior fascicle and low. So can we go on slide?
Should we move on, Anis? Because 6 plus 2.
No, see, 2 points. See, one is regarding the ECG. If you don't get a classical left axis, you should suspect whether it is anterior fascicular or an upper septal. You might get a right axis or a indeterminate axis. That's one. Second is, I think it should always be based on entrainment, and if you cannot entrain a posterior fascicular, then you should think of the next possibility.
So in the interest of time, because we have to move forward, we'll move to the next case.
We'll call up Dr. Hashika, something on intricate labor.
Respected teachers, dear colleagues, today I am presenting an interesting case which I would like to name as the intricate labor. My patient is a 28-year-old female patient. She is a homemaker and mother of a 5-year-old child. She presented to us first in October 2022 at 36 weeks of her second pregnancy. She presented with a rupture of her previous CS scar, which led to death of her intrauterine baby, and she underwent a laparotomy for it on the same day. On day 3 postpartum, she developed acute onset dyspnea and cough, which rapidly progressed over a few hours leading to need for ventilation. Her examination was consistent with findings of acute pulmonary edema. Her heart rate was 110 beats per minute and her BP was 160. She was evaluated with an echocardiography that revealed a severely impaired left ventricular systolic function with ejection fraction of 28% and a moderate MR. Her LV was enlarged and globally hypokinetic. Also, an oscillate second of ASD was also duly detected with measuring 1.1 centimeters with a left to right shunt. All her infective workup and evaluation for cause of myocarditis was negative, and a cardiac MRI was suggested but deferred due to patient's financial constraints. She was clinically diagnosed as peripartum cardiomyopathy with severe LV dysfunction and a secondary MR with an oscillate second of ASD of size 1.1 centimeters with a left right shunt. She was commenced on diuretics, AC inhibitors, spironolactone, and SGLT2 inhibitors, and she improved symptomatically and could be weaned off the ventilator by 7 days. She was then hospitalized for 24 days and discharged. At discharge, her ejection fraction was still 28%. 2 months later, in January 2023, she was detected with renal impairment. Her creatinine was 2.3 and she was referred to the nephrologist. She underwent a kidney biopsy, but the tissue was inadequate, but the obtained tissue suggested chronic glomerulonephritis. Again, the continued tissue workup and vasculitis workup was negative, and the findings of tubular atrophy and an interstitial fibrosis correlated with the biopsy findings of cardiorenal syndrome type 2. Her drugs were modified according to the EGFR, and she was kept on a close follow-up. 5 months later, after her first admission, that's in March 2023, she presented to the emergency with complaints of acute onset palpitation and dyspnea. This was her ECG presentation, which showed a monomorphic BT of right bundle branch morphology. The leads 1, 3, and AVL were negative, suggesting a left infralateral origin. And a DC of 200 joules was given thrice, which failed to revert the VT. And then a chemical cardioversion was attempted, initially with amiodarone, which also failed to revert the VT. With a single dose of lignocaine, the VT subsided transiently, but it recurred again in short runs. She was put on IV lignocaine infusion for 24 hours, during which the VT subsided, and she was then put on oral beta blockers and amiodarone post-reversion. This was her ECG post-reversion, which showed a sinus rhythm with a heart rate of 75 beats per minute, and the QRS showed a left bundle branch block morphology with a duration of 80 milliseconds. She was discharged after 1 week with a plan for ICD. 3 weeks later, she presented to a local hospital with symptoms of sudden onset loss of consciousness with posturing, and she was diagnosed with polymorphic BT there and reverted with DC shock. As per their records, the post-reversion ECG showed a prolonged QT interval of 580 milliseconds, and amiodarone had to be withheld fearing complication of drug-induced QT prolongation causing polymorphic VT. The beta blocker dose was optimized and she was discharged from there. In October 2023, she underwent ICD. She was observed in the hospital for 7 days and she underwent ICD implantation. After ICD placement, in the past 7 months, she has had recurrent admissions in hospitals for ICD shock. And interrogation of the ICD in February revealed that she had 95 episodes of VT in 4 months, of which 16 had to be shocked. The remaining subsided with anti-tachycardia pacing. The beta blocker dose was optimized to maximum daily dose, and amiodarone could not be restarted due to prior history of life-threatening polymorphic VT, secondary to QT prolongation. In a background of worsening cardiomyopathy, renal impairment, and recurrent arrhythmia, a cardiac MRI was suggested again to note treatable underlying cause, but she was hesitant due to risk of contrast-induced complications. A repeat renal biopsy and FDG PET scanning with myocardial perfusion imaging was planned in consensus with the nephrology department. The renal biopsy repeated shows non-Chiari granuloma in a background of interstitial nephritis. With this background, the FDG was the FDG with the myocardial perfusion imaging showed moderate hypoperfusion in the anterior segment and severe hypoperfusion of the inferior segments with corresponding segmental uptake of FDG, which was consistent with progressive disease stage of cardiac sarcoidosis or a hibernating myocardium. And a severe hypoperfusion was noted in the lateral segments with no corresponding segmental FDG uptake. That was consistent with the fibrous disease stage of cardiac sarcoidosis or a scarred myocardium. There was normal perfusion and metabolism in the rest of the myocardial segments. This was the SPECT image obtained, showing hypoperfusion of the anterior, inferior, and lateral segments. She was then advised a coronary angiogram, but was unwilling due to risk of contrast-induced nephropathy. So she's a young female with no risk factors like diabetes, hypertension, and a negative prothrombotic workup, and hence the possibility of coronary disease was unlikely. With a clinical history of recurrent arrhythmia in a background of cardiomyopathy and imaging evidence, along with the presence of non-Chiari granuloma in renal biopsy, she is currently diagnosed as cardiac sarcoidosis and started on oral steroids. So her current status is she has had 2 admissions with heart failure in the past 1 month, and her dyspnea is class 3 now, and creatinine is 3 with EGFR of 18.6. It's the latest echo showing global LV hypokinesia with a low EF. and she has a moderate severe MR with an ASD of 1.1 centimeters with left-right shunt. This is the latest ECG available, which shows a sinus rhythm with LB morphology and frequent VPCs. The morphology of the VPC is similar to that of the monomorphic BT she had, suggesting a similar origin. And currently she is on oral steroids, and we plan to intensify the medical therapy if there is no response. Also, if she presents with recurrent BT, we have a plan to consider RF ablation after mapping. And anticipating a resolution with medical therapy, a stellate ganglion block is also being considered for transiently reducing her BT episodes. Though mexiletine is a drug of choice here, she could not be started as the patient could not afford it. And also, metaclip is being considered for severe MR for symptom alleviation. Thank you, sir.
Yeah, then Dr. Ashika, that's a good case. Tough for her having a stormy post-labor period. So initial diagnosis of sarcoidosis was missed, if I would think. But it must have been
because she had financial constraints, and we could not go for any MRI at the time, and even renal function was also deteriorating. So we made a provision about common as a pregnant lady who had acute onset breathlessness. First diagnosis naturally was jumped to peripartum cardiomyopathy with mitral regurgitation, and he was started on drugs for peripartum cardiomyopathy, but then came with all the sequence of events which he has elaborated.
No, I agree. I also thought it was peripartum cardiomyopathy until the renal biopsy kind of turned the events. So she should be responding to steroids, and that's good for her.
Yes,
Good
Recently started.
Because manifest
It could still be a peripartum cardiomyopathy or a dilated cardiomyopathy, because we also used to get these funny reports from one of the labs nearby. Actually, this perfusion mismatch can occur if the patient is not adequately prepared with a glucose-free diet for 2 to 3 days. This is one of the commonest false positive tests for pointer for cardiac sarcoidosis. She doesn't have any other features. Sarcoidosis doesn't affect kidney like this, and that is not a common. Glomerulonephritis is not a common feature of sarcoidosis. The other, it looks like a dilated cardiomyopathy or myocarditis. MRI should be done. Genetic screening also can be done. Of course, sarcoidosis can be considered because it is one of the potentially treatable conditions for the time being, because we also had gone through the same sequence in many cases actually, and now we had alerted them about the ways to prepare the patient well, and Amrita, Dr. Natarajan can probably highlight. They all prepare. Dr. Mukund, we used to get these reports, no? Yeah, you know well actually. That doesn't matter actually. Only some local artifacts will happen, and some of the tissue characteristics could still be delineated based upon.
You see, one of the mistakes that you often do is that in patients with suspected peripartum cardiomyopathy, you don't do an MRI. You should do an MRI within 30 days, at least to pick up a myocarditis, and the patient might be having just myocarditis and not a peripartum cardiomyopathy. So MRI is, if you have done it right in the beginning, then you would not have missed the entire story.
Thank you, Dr. Ashika. We'll call up Dr. Javid for his talk, Between the Cheese and...
Good afternoon, everyone. For the sake of brevity of time, let me quickly run you through the case. So this is a case of rheumatic atrial flutter, and I will try to highlight that these cases, we can do a lot, we can help them a lot prodigiously, by ablation. So our patient was a 36 years old male who was a rheumatic heart disease patient with DVR, which was done at the age of 26 years, so 10 years back. So he presented to us with relentless episodes of palpitations for last 6 months. So he was given the maximal dose of AV nodal blocking agents, digoxin, diltiazem, and metoprolol. And echo had recently showed that there was a worsening of LV function with mild LV dysfunction with normal prosthetic valve functions. So this was the ECG. 1 second, I'll just... This is the ECG on the right, showing that there was a flutter going at a very high rate, at a very high ventricular rate, And if you see the ECG that we later on took in EP lab, So if you see the morphology of the flutter waves, I know this morphology basically it is applicable to focal atrial tachycardias, but roughly we get some idea about the origin of these flutters. So you can see in a lead V1, this is positive. In fact, all the chest leads show positive flutter waves. So indicating that the flutter circuit is probably somewhere in the left. So then you see the lead 2. Lead 2 is lead 1 and lead 2. So both are showing positive. So probably coming to, in fact, 3 is also isoelectric. So indicating probably the, normally we'll localize it to right upper pulmonary vein kind of, that sort of an area will localize with this kind of morphology. So this is, we put the usual catheters, duodoca and CS catheters, his catheter. This is the flutter that was going on. As you can quickly from a distance, you can say, yeah, this is not in the left. So you can see, you know, all is coming in one line almost. So, and you can see that this chevron pattern in the duodoca catheter. So indicating that it's not a typical flutter. And we know that right atria is actually occupying just 20 to 30% of the tachycardia cycle length. So we quickly shifted to left side. We did transseptal punctures. These were our usual catheters. Went to the left side. So the left side, we did this substrate mapping. So there was a large scar area on the posterior LA. And there was one island of normal conducting tissue between this inferior pulmonary vein and the posterior wall. So this is these are the signals from the same area. You can see nicely the double potentials. If you focus here quickly, see how well separated these double potentials are here. As you move down towards this area, they sort of come you know, closer by, indicating that there's a leak somewhere in between. So, and then they separate here again. So plus there is a large fraction, this large fractionation here. So we did entrainment from the same area. So you can see that there's a concealment of concealed fusion with entrainment. So post-pacing interval is 325, as again is the tachycardia cycle length of 317. So we know that we are most probably in the tachycardia. And if you also see this stim to EGM versus stim to P wave, we cannot, it's not that well seen, but it's almost the same. So indicating somewhere we are in the slower zone. So this is the same slide, you know, just giving you an idea that this was concealed fusion. So this is the activation mapping we did. You can see here, you can see that there is early meets late activation happening over here. So you can very well see that how slow this activation is in this region. So this was most probably this was the slowest zone. Another important finding here was that, see, we can see this is most likely the isthmus, and you can see the activation going on like this and activation going inferior like this. So this was most likely the dual loop re-entry. So ideally we should have done entrainment from here also and from these two different loops, so that we could have proved that this was indeed a dual loop re-entry happening over here. But unfortunately we didn't do the entrainment from both these sides. So we saw a very nice isthmus, and we saw the fractionation there, we saw concealed fusion, everything were there. We just went there, and just few burns only, the tachycardia terminated, and it was a very clean termination. So after that we connected this isthmus to right inferior pulmonary vein. We created this line of block, and subsequent the ECG after termination of the flutter was sinus rhythm. Sinus rhythm also we can see very tall P waves. So the idea of presenting this case was to highlight that young patients with scar-related atrial arrhythmias, particularly in rheumatic heart diseases, should not be condemned on rate control. Rheumatic atrial arrhythmias are not prognostically the same as that of atrial arrhythmias in older population, and ablation should definitely take a precedence in young patients for better symptom control. Thank you.
Thank you, Dr. Javed. I agree with you that young patients should not be condemned, but then should be aware that rheumatic subset is very different from the rest of the atrial flutter. They're extensively scarred, and
true, sir.
are going to be.
Yeah, true, sir. But if we see, these are the subset of patients who are very symptomatic with this flutter. they are very as we can see, this patient, he had developed LV dysfunction, so he was going in heart failure, so we had to do something for him.
Yeah,
So
I'm
he
in
was already on
agreement with you.
maximal dose.
I was in agreement with you that in such cases, it's okay to attempt even in rheumatic heart disease.
Yeah, sure.
That's a great case, yes.
Dr. Mukunda has published a series.
Your
Dr. has published a series on this rheumatic atrial flutters.
Case series of 4 or 5 patients. Where, just ablation outcome and around median 4-year-old duration follow-up showed excellent results comparable to such a normal heart.
But there was an older series, I think, which came in circulation also, where chronic atrial fibrillation in rheumatic heart disease was converted to atrial flutter by giving amiodarone. That was by Dr. Mohan Nair, who's no more. And then finally, he had to abandon that approach because in most of the atrium, the voltages were very low. Maybe Narayan sir can comment on that. I always used to find it
that
fascinating.
was actually cardioversion reinitiation of atrial fibrillation is from the coronary sinus ostia. That was the publication in the circulation by Dr. Mohan Nair. This regular atrial tachycardia and rheumatic substrate, as he mentioned, many of them would be very refractory to medication, significantly symptomatic, and paradoxically they could be having very minimal scar, very localized re-entry or a focal re-entry in the left atrium. We have published that series in PACE 5-6 years back. Can we have the next speaker on stage? Dr. Naini on All Roads Lead to Rome.
So I'm going to present a slightly unusual accessory pathway mediated tachycardia, and I'm thankful to my teachers at Sri Chitra for the opportunity. So my patient is a 44-year-old lady. She has a history of recurrent episodes of tachycardia, some of which were adenosine responsive. She had undergone ablation twice previously, once at an outside center, once at Sri Chitra, failed both times. And she was continuing to have persistent symptoms on flecainide and beta blockers. She was not, amiodarone had previously induced drug-induced thyrotoxicosis and was not being given. This was her baseline ECG, which showed manifest pre-excitation. So we see a prominent negative delta wave in lead 2, along with some notching. The delta starts immediately after the P wave, and there appears to be a progression-regression kind of a pattern in V2 and V3. All features that are consistent with the right posteroseptal pathway, but one that could possibly be related to a coronary sinus diverticulum. This is her adenosine responsive tachycardia, which is a regular NCT with a short RP. This is the other morphology of tachycardia she was having. This appears to be a regular wide complex tachycardia with a pre-excitation morphology comparable to her baseline ECG. Again, we see prominent S waves in V6, again suggesting a coronary sinus accessory pathway. This was hemodynamically unstable and she was DC-verted for this rhythm twice while on drugs. So she underwent a CT of the heart since she had had 2 prior failed ablations, which showed a large coronary sinus diverticulum arising just proximal to the middle cardiac vein. And subsequently, we took her for a EP study and a radiofrequency ablation. This is a basal ECG that is again similar to the prior records. At baseline, she had a sinus cycle length of around 660 with an AH interval of 108 and short HV interval of 14 milliseconds. This is the morphology at maximal pre-excitation, which again is similar to the antidromic or the pre-excited tachycardia ECG. In lab, so while we were performing baseline maneuvers, we actually could not perform any maneuvers because she was incessantly in tachycardia through the duration of her study. This was the first tachycardia to be induced. This was a wide complex tachycardia with a 1-to-1 VA relationship. And atrial activation was earliest in the His bundle electrodes. The tachycardia has a cycle length of 300 milliseconds. During this tachycardia, atrial premature complex delivered when the septal atrium was refractory advanced the next ventricular activation and reset the tachycardia, suggesting a likely antidromic AVRT as a likely mechanism. Again, atrial entrainment showed entrainment from the CS910 managed to entrain the tachycardia with the AVA response at the termination of pacing, which ruled against ventricular tachycardia. Now, this tachycardia spontaneously in EP lab converted to a narrow complex tachycardia. But the narrow complex tachycardia wasn't truly a narrow complex tachycardia in that it had some alternance on the surface ECG as well. The QRS morphology, if we see, for instance, lead V1, half of the QRS are in RBB morphology and some of them have a morphology that is akin to the pre-excitation that we were encountering previously. These are the corresponding EGMs during this tachycardia. So if we measure the HV interval, there were two HV intervals. One was in the RBB morphology beats, which was longer, and the other was in the pre-excited beats, which was shorter, comparable to that in sinus rhythm with pre-excitation, but much longer than that at maximal pre-excitation. Again, there were two HH intervals during this tachycardia, with a shorter HH interval in the pre-excited beats. Furthermore, there were two cycle lengths. If I measure the A to A intervals, there was a longer A cycle length during the RBB morphology and a shorter A cycle length during pre-excitation. This change in the cycle length is completely explained by differences in the AH interval as well as the VA interval. So I'll just try to address it in my subsequent slide. There were two predominant differential diagnoses. The first was an ORT with intermittent pre-excitation. So the retrograde limb is likely by a right-sided accessory pathway, and the change in VA time is could be explained by an RBB beat. So the RBB beats have a longer VA. The AH interval is likely changing because of decrement in the node itself in the shorter cycle lengths. The other possibility would be an AVNRT with intermittent pre-excitation. In this case, the variable HH interval would have to be explained by decremental conduction at the site of the lower common pathway. A third possibility, but this is relatively much less likely, would be a nodofascicular or nodoventricular pathway with intermittent pre-excitation. So his refractory VPC actually did not advance the subsequent ventricular activity. Since the pathway was clearly involved in the other tachycardias, a decision was made to ablate the accessory pathway first and then proceed with ablation of any other mechanism if it was present. The pathway was mapped to the neck of that diverticulum that we had previously seen on CT. This was the signal at the RF at the ablation site, which showed a good pathway potential. This ablation at this site terminated antegrade conduction during atrial pacing within less than 4 seconds. Subsequent to this ablation, no other tachycardia could be induced. There was no feature of dual navy nodal physiology, and there was no feature of any retrograde, any additional concealed bypass tract conducting retrogradely only. So the likely diagnosis is an ORT with intermittent pre-excitation. The earliest activation during tachycardia was at the His bundle, but this is likely secondary to multiple atrial insertions. It is key to note that twice prior ablation had been attempted, likely with multiple burns each time. So this intermittent pre-excitation could have been mediated by an anatomically distinct pathway that was so close to a culprit pathway that we ended up ablating it, or a pathway that had been physiologically separated. I'm not certain if a CS diverticulum associated pathway with multiple atrial and ventricular insertions could also mediate such a physiology.
Can it be an atrial tachycardia with 2:1 pre-excitation?
A interval is varying.
A interval was varying, so that rules out. That was an interesting tracing anyway. So this VA interval also varied. Can it happen, Dr. Anis? And
Not sure about what was the finding when you gave the late atrial extra septum.
So it advanced, that was an anterhythmic tachycardia. It advanced the subsequent ventricular activation and reset the tachycardia, a late ATC.
Yeah. And is there any evidence of an additional pathway before you operated?
So the tachycardia was incessant. We could not do a detailed study prior to ablation. But
there is no way to explain the change in cycle length and morphology otherwise, because there is an additional pathway.
Yes.
This happened during ablation. Suddenly that became alternately pre-exciting and RBB otherwise. And it's that HV was varying in both. HV for that RBB was clearly suggestive of an orthodromic re-entry, but alternate beats were pre-excited. But the pre-excitation went off with a single burn. So whether the patient had two ablations in the past, multiple lesions, the bifurcating, the physiological bifurcation of the pathway and alternate, that is one possibility, because we had looked into that tracing in detail. We didn't have any. It's an interesting tracing. It should have been discussed more in detail. The limited time, probably. It was a coronary sinus diverticulum related.
What about post-ablation?
VA dissociation single burn. Normal, sir. No. Actually, we had a large coronary sinus diverticulum and we did a fusion with the diverticulum and the CT, and that facilitated the ablation. This time the ablation was much simpler. and the patient is asymptomatic, no pre-excitation. Had 2 ablations, one in our center only in the past. Large diverticulum.
A tale of pacing on the tail, Sudipta Mandal.
Good evening, respected teachers, my seniors, respected chairperson, and dear colleagues. Today I shall present 3 ECGs, interesting ECGs of pacing on the tail of QRS complex. So this is the first ECG. An adult with CHB who underwent dual chamber pacemaker, which was Medtronic. So this ECG showed a R1T phenomena, and that one pacing spike has been seen here, and followed by R1T phenomena, and that in a couplet fashion it was there. So all parameters, pacing parameters were standard Medtronic parameters, especially mentioning there was AV hysteresis on, with the 320 millisecond was the maximum AV delay, and post-atrial ventricular blanking period was 28 millisecond. This is the second ECG, a patient of known symptomatic sick sinus syndrome who underwent dual chamber pacemaker with Boston Scientific, and as you can see, the first complex, there is a pacing spike on the QRS, followed by 2 pacing spikes on the T wave. Here also all pacing parameters were similar to the last case. The third ECG, which this patient was also of known CHB who underwent dual chamber pacemaker with biotronic device, and as you can see, all QRS paced QRS complex is followed by 1 pacing spike. So all parameters were almost similar, with post-atrial ventricular blanking of 28 millisecond, and crosstalk sensing window was 100 millisecond. So these are the 3 problems. All ECG, the first ECG had 1 pacing spike, followed by another pacing spike on the T wave, which captured and created 1 couplet. In the second ECG, 1 pacing spike on the upper limb of the QRS, and 2 consecutive 2 pacing spikes on the T wave, and the third pacing spike, 1 pacing spike followed by QRS, and on that QRS another pacing spike. So all ECGs are having 1 or 2 extra spikes, pacing spikes on the tail of the QRS. So on detailing of the ECG, we could found out that this atrial pacing spike, when this atrial spike happened, the same time 1 VPC came. So this VPC fell under post-atrial ventricular blanking period, to which the ventricular channel was blanked. So ventricular channel could not find any activity. So after the set AV delay, because of the search hysteresis on, the AV delay was 320 millisecond at that point. So after this atrial pacing spike, which after 320 millisecond, another pacing spike fell on the previous VPC, which was in the blanking period of the ventricular channel. So this, the ventricular spike fell on the previous VPC's T wave out of refractory period. So it captured the ventricle and it created a couplet. So this may potentially cause a ventricular tachycardia, but it ended here itself. Coming to the second ECG, similarly 1 VPC came in the same during the atrial pacing spike in the post-atrial ventricular blanking period. So ventricular channel missed the VPC. After the set AV delay, another pacing spike fell, but this time it did not capture the ventricle because of the refractory period. As it did not capture the ventricle, so there is a confirmed loss of capture, and 1 backup pulse was given by the pacemaker. This backup pulse concept was initially initiated by St. Jude Medical, and then other devices also included the same. So this backup pulse created the double pacing on the T wave, but it did not capture because the ventricle was refractory in this case. The third case, So atrial, actually the third case, when we interrogated, we saw that the atrial pacing spike is actually capturing the ventricle. As the atrial lead dislodged into the ventricle, so it actually atrial pacing spike capturing the ventricle, and ventricular channel was sensing, over sensing. So this stimulated the ventricular safety pacing, and it exactly after the safety pacing window, it paced on the QRS complex. So it is before the AV delay, set AV delay, that is for biotronic it is 100 millisecond, and the AV delay was set was 120 millisecond. So this safety pacing spike was 100 millisecond before the actual set AV delay, paced AV delay. So I wanted to show the differential diagnosis of this ventricular channel atrial lead dislodgement into the ventricle. So this scenario I have already explained. Another scenario can happen when ventricular lead dislodgement occurs into the atrium, the opposite. So in that case, atrium pacing spike will capture the atrium normally, but the ventricular lead, as it is in the atrium, it will oversense in the cross-check sensing window, and exactly after the cross-check sensing window, it will give the pacing pulse. That will be before the set AV delay, and that will not capture the ventricle. So first A pacing will capture the atrium, and next will be after the cross-check sensing window, that will not capture the ventricle. This already I have explained. VPC coming into the post-atrial ventricular blanking period, which will be missed, and after the set AV delay, it will pace on the T wave. And third, lead reversal can cause this problem, but in this case, the atrial pace will capture the ventricle, but it will not pace after the cross-check sensing window, because cross-check sensing is not happening here. It will pace after the exact set AV delay, paced AV delay, that is 120 millisecond in usual pacemaker. So it will come after the cross-check sensing window. But as we saw in the third case, that it was coming at the cross-check sensing window because the atrial lead dislodged into the ventricle. So this is the differentiating point. So the X-ray was done to confirm this finding, and the lead was repositioned. So these three problems were there. So first problem was because of post-atrial ventricular blanking period, missing the VPC and pacing on the QRS. Because of the surge AV plus, after 320 millisecond, it captured the ventricle in the beyond the refractory period. So we gave the beta blocker to suppress the VPC and theoretically reduce the chances of any R1T phenomena leading to ventricular fibrillation or ventricular tachycardia. In second case, the mechanism of is because of post-atrial ventricular blanking period related VPC related extra pacing, and that is because of RV auto capture mechanism, which caused two pacing spike on the T wave. Similarly, we gave beta blocker, and RV auto capture mechanism we kept off. In the third case, the lead dislodgement and ventricular safety pacing was the mechanism, and we repositioned the ventricle. So take home point will be inappropriate pacing on ECG is not equals to pacemaker malfunction. So pacemaker is doing whatever we have already made it to do. So inappropriate pacing might not be equal to pacemaker malfunction. Symptoms may not be proportional to the pacemaker malfunction, as we saw that all atrial pacing captured the ventricle and did not create any problem to the patient. But in all three cases, all patients were asymptomatic. Knowledge of advanced algorithm is important to analyze all those intricate details of the ECGs, and critical evaluation of ECG can be life-saving, as in the third case, atrial dislodgement can induce ventricular tachycardia and other complications. So thank you.
All were good pickups. Just the first case, yes. I would also stop the search AV hysteresis.
Yes, sir.
In addition to stopping increasing beta blockers.
Correct, sir. We have done that, so that even if it occurs, it will be in the refractory period.
And in the second case, is it not because the ectopic happened in the safety pacing window, or in the AV window where you got that safety pacing? Or is by switching off the RV capture management, how will you avoid this FT pacing mechanism?
No, sir. By switching off the RV auto capture, we have avoided the second pacing, and by giving the beta blocker, we tried to suppress the VPCs. And as you mentioned that it might be because of safety pacing, but we measured the interval from the first pacing spike to the second pacing spike. That is not in crosstalks on sensing window. That is paced after the paced AV delay window. That was not in the after the exact crosstalk sensing window. Yes.
Confused about the first case.
Yes.
Can you explain what happened in the first case again? VPC happened.
Yes, sir.
Isn't it? There was AP, V sense to start with.
Yes, sir.
And the VPC happened. Right?
Yes, no, sir. A paste happened, but the simultaneously one VPC came.
You mean there is a P followed by a VPC?
Not simultaneous, sir. Not followed by, sir.
Then what happened?
So this VPC, as A paste happened, so ventricular channel will be blanked, 28 millisecond. Post atrial, no, sir. Post atrial ventricular blanking period.
Very short period.
Yes, 28 millisecond.
In that period, VPC happened.
VPC happened, so it did not see that VPC. So after the set paced AV delay, it has given the ventricular pacing, but unfortunately it fell on the previous VPC's T wave.
Very untimely VPC.
Yes, sir, yes. And yes.
I think.
It can induce, sir. Actually, one case has been reported RONT inducing VPC inducing RONT and leading to ventricular fibrillation and death. But that ECG is not documented. Only the device interrogation showed that phenomena. But it is the first time that
we may need at least a couple of hours to make it very clear to everyone. But probably in the interest of time, we need to move forward. He has already published in circulation, one of them. yeah.
Pace.
Another one of them, some other article. Yeah, it's already.
Thank you.
Very prolific insights into, very. Okay, thank you. Very interesting sessions. We will move to the next one. Thank you.
Moving forward to the next session, high voltage session on decoding ICD. We welcome chairpersons Dr. Ajit Tachil, Dr. Arshad M, and Dr. Suresh K to the stage.
Good evening, everybody. Nice to be here. Thanks to the organizers and all the usual opening remarks. Already we are late by around 15 to 20 minutes, so let us start the proceedings. High voltage session. We will have Professor Shivaprasad to set the ball rolling.
Good evening to all, respected chairpersons. Let me first express my thanks to Narayan Namputri and Jyoti Vijay for giving me this opportunity. I thought the meeting is demystified, but the last five cases, we got actually mystified. I'll take some simple programming lessons when you implant the ICD. ICD is used as a life-saving device in a SCD survivor where it is secondary prophylaxis and in those who are at high risk for VT or VF to save their lives in case one happens. This is for primary prevention. With this, it was introduced and we found that in MADID 1, 2 and SCD HEF trial, there are a large number of shocks or that outnumbered the sudden cardiac arrest in the control group. Control group, either conventional medical therapy with or without amiodarone. This is almost 2 to 3 times. This indicates that some of the shocks are inappropriate in this subset of patients. Initially, we were fascinated by the deeds of the ICD, that they are saving lives. Then we started understanding that inappropriate shocks, which are given when it's not warranted, are really harmful. So, ICD therapy was probably delivered for non-life-threatening ventricular tachyarrhythmias which are hemodynamically stable or maybe non-sustained VTs. But to give the maximum benefit, you should treat the required VT or VF with a shock, thereby, but at the same time, you should avoid unwanted shocks. We all understand that unwanted shocks will lead to adverse outcomes, increases of mortality, worsening of heart failure, and the patient, a lot of psychosocial impact to the patient. Newer technology evolves, and they have suggested several improved programming characteristics which can prevent the unwanted shocks happening to the patients who receive an ICD. The programmable features of the ICD are: one, the ability to detect the arrhythmia. It could be based on the duration, that is, the arrhythmia must be of sufficient length to be significant. Or it can be based on a rate criteria. Arrhythmia must exceed a programmed rate cutoff where it is considered as above which it is considered as significant. That is, to summarize, the arrhythmia should be sufficiently long and rapid to trigger the therapy. We should not program the machine to act the sooner it sees the rhythm abnormality. Thereby, you can avoid unwanted shocks. Recent enhanced ICD trial, which was published in 2016, showed that if you give time to detect 60 events, 60 numbered events, you can and delay till the 60 events are analyzed and then come to a conclusion. Either you will not give a shock or just give a shock at that time. It has been proved to be safe that patient can be given a shock, patient will receive a shock if it is required, and sometimes it is aborted. So thereby unwanted shocks are reduced in that trial by 10%. Then we have a program to identify supraventricular tachycardias. If that is not recognized, you will get unwanted shocks there also. Then there should be an algorithm to identify noises which can be interpreted as a ventricular tachycardia. These noises could be physiological or non-physiological, which I will allude to later. Then you should have certain arrhythmia discrimination programs which can distinguish arrhythmias requiring ICD therapy from those which are not requiring that. This is for appropriate ICD function. Basic intention is to identify the VT. The algorithm which is used is based on the heart rate, suddenness of onset of the arrhythmia, atrioventricular association or dissociation, interval stability, whether the QRS is occurring irregularly, QRS templates while the patient is having a basic rhythm, and so based on certain other parameters as well. These are analyzed by the ICD, and then they can come to a conclusion that the arrhythmia is whether it's supraventricular or ventricular tachycardia. I said earlier about noise discrimination. Two types of physiological noise or non-physiological noise can happen to the patient who receive an ICD. Physiological noise which is interpreted as an arrhythmia is a T-wave oversensing or dual QRS sensing or a P-wave sensing. Non-physiological noises are electromagnetic interferences, particularly lead failures or lead fractures. Multiple available tachycardia therapies are also incorporated in programming modalities. Now we know, previously we thought there is only cardioversion was considered as the treatment modality for any tachycardia which is being detected. But now we understand that most important is an anti-tachycardia pacing, which can abort many of the shocks. They can convert the rhythm to, if you listen to the topic which was presented by Ashika, you can see that nearly 80 episodes of VT was there, but 60 of them were reverted by ATP. Then if you have a rhythm which requires a intervention, you can either cardiovert if it is a stable VT rhythm, or if it is a ventricular fibrillation rhythm, you can defibrillate. ATP is further have certain programmable characters like it can be varying in number. You can give 8, you can give 15, you can increase the rate or depending upon the VT, you can increase the duration of the ATP cycles as well. Defibrillation, there is a programmability to adjust the delivered energy. Another important feature should be to re-evaluate rhythm after delivery of the treatment. One more facility which is given in our ICD system is that multiple zones of tachycardia detections are available for treatment initiation. Basically, there are 3 heart rate zones are described: lower heart rate, middle heart rate, and very fast heart rate. Of course, the very fast heart rate above 250 are unstable and they are poorly tolerated and require high energy defibrillation. Most likely they are VF, and if it is delayed, it may be difficult to terminate. So most successful approach such fast ventricular tachycardia is high energy defibrillation. But it is also known now that 1 ATP which is given during the period when the system is getting charged can terminate some of the tachycardias. But we are always concerned, if you delay the process of defibrillation, will we get into a syncope or an event? This is not of a big concern now. And similarly, if you have a low heart rate, that is a slow ventricular tachyarrhythmias, may not lead to loss of consciousness or other unstable symptoms for at least several minutes. And often they can be terminated with an anti-tachycardia pacing, which is really painless, which can be activated rapidly, and which is energy saving to the ICD. This is one such example where you can see that there is a spontaneous onset of ventricular tachycardia, which was there for 30 numbers. After that, it spontaneously terminated. If you have programmed it that we should act immediately after the onset of the tachycardia, we would have been giving one shock which was unnecessary. Most of the time, this is recognized and given a shock. Even if you have not given the shock, it would have terminated after 9 seconds or so. So this is an appropriate shock, but could have been avoided. So that is what the new terminology is. There should be this should be having a facility for avoidable therapy. A shock is appropriate if it is given for a VT, but for a self-limiting VT, this shock is not really required. So this is an avoidable shock. Then there are certain inappropriate shocks which are given for SVT or noise, which is interpreted as a VT. Now, this is based on the premises that there is many number of arrhythmias are self-terminating. So you give adequate time for the system to analyze and give some time so that it will terminate. Instead, if you program it for a slower heart rate or for a short duration, you may be over-treating the arrhythmias. Then tachycardia detection programs, which I said, are now in all the vendors have given certain specifications and they have given criteria, and duration criteria is usually 6 to 12 seconds or 30 intervals out of 40. They wait till this is completed and then the system analyzes the rhythm and then decide whether there's some measures to be taken or not. Then 3 limits of rates I have said: slowest tachycardia zone, that is around 185 to 200 or 199, then 200 to 249, and then about 250. Some says about 200. So if the heart rate is above 250, then most often the systems interpret this as a definitely high risk tachycardia, and they respond by giving an ATP followed by, if not terminated, followed by a shock. If the VT rate is already known, you can program it to a level that is 10 beats per minute below the documented tachycardia, so that if the tachycardia occurs, the system can analyze it and react. Multiple tachycardia detection zones and SVT discriminators are incorporated in the program. Discrimination algorithms distinguish SVT from VT basically based on rate, first thing. But most of them are between 200 beats to 230 is the range in which discrimination programs are mostly of use. If you take the evidence, you can have MADIT, RIT trial, advanced 3 trial, and provide trial, and prepare trial, and relevant trial. The last 2 trials are non-randomized, and the first 3 is randomized trials, which has proved that delayed detection of an arrhythmia and delayed reaction to that arrhythmia results in less inappropriate or total shocks and reduced mortality and syncope in patients. MADIT study have reduced by 76%, advanced 3 has reduced by 44% unwanted shocks, and in provide it is 36% reduction, which has happened if you are willing to wait for some time. Similarly, faster rate, as I told you earlier, the faster the rate of a tachycardia, likely to be a tachycardia which is of significance. In MADIT rate trial again, a high rate therapy programming, that is, no therapy at rates between 177 to 199 versus 2.5 second delay at rate 200 beats per minute or above, was compared with a conventional strategy of 2.5 milliseconds for any type of tachycardia which occurs. They found that in the conventional arm, there is 20% inappropriate shock compared to 4% shock at the high rate therapy group at 1.4 years of follow-up. ICD shocks are 4% versus 2%. And all-cause mortality was 2 times higher in the conventional group compared to the high-rate group, where you were able to reduce the number of shocks delivered to the patient. Then comes the important discrimination between SVT and VT. SVT is incorrectly diagnosed as VT in nearly 1/4 of the cases. Usually, the rate is between 180 to 213. In programming, once the duration rate criteria for VT or VF is satisfied, the system goes into an algorithm which is to analyze the SVT. These are the points which are taken into account. Is there an AV dissociation? Is the atrial rate faster than the ventricular rate? QRS templates in basic rhythm is analyzed and compared with the rhythm, the templates in the tachycardia. Tachycardia interval stability criteria. Onset criteria, there is abrupt onset and fast rhythm. Then there is a program timeout. So at certain period this is analyzed. After that the time, this is declared timeout and a shock is being delivered. Another important feature now incorporated is second look feature before delivering the shock, whether the rhythm abnormality exists at the end of the analysis. Dual chamber ICD, there is facility for mode switching to prevent inappropriate tracking of the atrial arrhythmias and pace termination of atrial arrhythmias. There is facility for physiological noise identification, that is T-wave oversensing or double counting of the QRS or P-wave oversensing using high band pass filters or altering sensing bipole or reducing the sensitivity. And by this method, you can also reduce the T-wave oversensing by changing the sensitivity thresholds. And this can be corrected. Non-physiological noise are ICD lead fracture failures, which can be recognized by rhythm intervals which are very short and transient and repetitive, and if noise is present on the distal bipole but not present on the wide bipole or shock coil electrocardiogram, we can assume that there is a noise disturbance caused by a lead failure. Many algorithms are generated by different companies, and a change in the lead impedance sensing or threshold will give an idea about the impending lead failure. Another most important modality which I told earlier is anti-tachycardia pacing. This should be the initial intervention and the role of modern ICD programming. This has been...
Can you please come to the final conclusion?
Yeah, this is, I think, 2 more slides. High rates of successful VT termination and successful after ATP. Underlying rhythm is VF. 1 or more defibrillatory shocks are given. ATP should be active or all ventricular tachyarrhythmia detection zones include arrhythmias up to 230 beats per minute, except when ATP is documented to be ineffective or pro-arrhythmic. What is given is usually 8 stimuli in a run, and you can repeat for 2. Actually, the 2015 HRS recommends at least 1 attempt at ATP, but the practice now recommended is 2 attempts at ATP to terminate tachycardia with an 8 pulse. And burst pacing is what is being recommended for ATP to terminate the tachycardia. For VT, synchronized cardioversion, maximum 30 to 40 joules are given, and VF defibrillation, which is non-synchronized. Bradycardia algorithms are also available, but I'm not going into the details of bradycardia management. For subcutaneous ICD, programming is simpler than this, but is limited to 4 factors: detection of the rate between 18 of 24, that is fixed, and 1 or 2 zones, and post-shock pacing and therapy options are 80 joules. No bradycardia facilities available, management facilities available with the subcutaneous ICD. There are 2 zones I described, that is single zone configuration and dual zone configuration, where there is a conditional shock zone similar to SVT algorithm in the transvenous ICD. Then you can think of adjuvants to reduce the shock, which we do when we fail to control the tachycardias completely. And to summarize, optimal ICD programming seeks to emphasize that much of the risk-benefit ratio of these devices are determined by the way they are programmed. Modern ICD programs utilizes higher arrhythmic detection rates, longer detection durations, and algorithms that discriminate between SVT and VT. Similarly, treatment of arrhythmias utilize ATP as the initial therapy for many patients with VT, given the high rates of successful termination. Thank you.
Excellent review of the subject. I agree that 10 minutes is too short a time. Dr. Ajit, you would like to add any points?
It's a massive topic to talk about in 10 minutes. Just one thing that Sir told, which I want to emphasize, is the most important thing in preventing an inappropriate shock is to let the VT run for some time. There is a corollary to that also. Now, the other thing is we must understand that even though these recommendations have come in 2015, the default programming of none of the ICDs have changed. All the companies still market, and all the company reps, almost all of them program the ICD to 130. So we must step in and check what have they programmed it to. Have they programmed it to the recommended 170 or not? Second is, it is only a guideline. It doesn't apply to all the patients. If you have a patient with class 3, nearly class 4 heart failure, he will not tolerate a VT at 170, 180. There are instances of patients who have collapsed. So it's only a guideline. If you think that the patient is really sick, don't be hesitant to bring down that number from 170 to less than 150. If it is a patient who's really robust, 50% EF, don't be hesitant to increase that number from 170 to 180 and increase the detection duration. That is one thing. Second is, review the programming every time the patient comes. When we first put the ICD, the EF may be 35% or 30%. 5 years later, the EF would be 20%. You will have to bring down that number after 5 years. So I'd just like to add these 2 points. Thank you.
Ajit, sir, is there any difference in the programming for the primary prevention and the secondary prevention patient, obviously?
Actually, you have more instances of shocks occur with the secondary prevention. Primary prevention, number of events are less, but there is no difference between the programming in these 2.
Yeah, the only difference is, like sir already mentioned, the in secondary prevention you set it 10 beats per minute less than the detected VT zone.
That if you know
if you know the rate of the clinical VT.
Can you avoid ATP? The patient is unstable and sick.
Yes, it is better to do that because it consumes time. Unless it is ATP during charging. If it is a sick, unstable patient, it's better to have only ATP during charging.
But one more important point is, as time goes on, the battery gets weakened and it takes a longer time to charge for shocking, and all these things are not considered in these guideline recommendations. So we have to consider that fact also. And regarding the charging, while the machine gets charged up for the shock, you can give 1 ATP. And you don't repeat it and wait for longer time in a sicker patient.
Thank you, sir. Now, I think Abhilash is going to enlighten us further regarding ICDs using a case. Abhilash.
Good evening, respected chairpersons, my teachers, dear friends. Suresh sir is my first HOD in cardiology. Sir is here as the chairperson. ASCD case-based troubleshooting is my topic. We need to know a few key words before getting into the topic. as such, but essentially these key words are the what we are going to tell to the device, and essentially that is the topic about sensing, detection. The device has to detect the arrhythmia, then the duration, because that is important, because we don't want to treat any 3 beats, 2 beats tachycardia. So it should last sufficient duration. At the same time, it should not miss that arrhythmia as well. So we need a balance point between these two. Then SVT, we are not supposed, the ICD is not supposed to give a therapy there. So ICD should discriminate between them. And it has to confirm that, again, we need other morphological criteria, stability criteria to confirm the therapy. Then again, therapy is activated, but again, it has to reconfirm it. And finally, termination, the device has to assess that whether it is terminated also. So this many steps are there in the ICD in workflow. So analysis of ICD shock, the patient comes with an ICD only. He may not have old records, he may not have an X-ray, he may not have a previous ECG. If it is there, look at it. That's the first step. You can, if there is an X-ray, we immediately know it's a dual chamber or a single chamber pacemaker. If previous records are there, well, fine, we can see it. But if there is a tachyarrhythmia, again we have to distinguish it between an SVT or which is an inappropriate detection, or a VTVF, which is an appropriate detection. But if there is no tachyarrhythmia documented, we are either dealing with an intracardiac signal, which is usually a noise, or an extracardiac. It could be noise from outside, could be an interference. Then single chamber ICD, most of our ICDs which come across are single chamber due to cost reasons or whatever, they are the common practice. But unless the patient has a pacing indication. So we need to just these three, how it was the onset, what is the morphology compared to the original template in sinus rhythm, and interval stability, they are regular or irregular. These are the 3 aspects we'll be focusing on for a single chamber ICD. Then dual chamber, even though it is slightly more complex, but it is easier to distinguish between an SVT and VT with a dual chamber ICD. We have in addition to the previous 3 aspects, we have atrial and ventricular rates. Then it is simple. If the ventricular rate exceeds the atrial rate, the diagnosis is VT. If tachycardia rate, atrial rate is more, usually it's an SVT, or you have an ABT in addition to it, a double tachycardia going on. Then tachycardia with 1:1 AV relationship that we will see in later. Again, you have to add other parameters. Then we'll see some of the tracings. Just like Suresh sir, I was telling about a teacher. My teacher for this section is also sitting here. Some of the slides actually I collected, tracings I collected from Mr. Shabriwas and from St. Jude. I saw him sitting here, not now. So this slide I got it from him previously, many years back. I learned from him. You can see, when you see a tracing like this, if you see A and B, say AS and VS, you know that it's a dual chamber pacemaker, dual chamber ICD. In this each annotation we should learn, this says the atrial channel is sensed. This says the ventricular channel is sensed. But F, you know, it's fast for the fibrillation zone, very fast. T is not there. T is usually the tachycardia zone, depending on which zone it is. It can be slightly different from manufacturers. Here you can see this is the atrial channel, this is the ventricular channel. This is how the machine interpreted it, then annotated it. This is how the cycle lengths are. Here these green ones are the charging signals. So we know it's very easy to distinguish. This is AF going on. It's very irregular and it's much faster than this channel. And this again, but the problem is, it was sensing normally, then it interpreted it as a fast ventricular rate, it's interpreted as fibrillary here for the ventricular channel. The problem with tachycardia zone identification is, if you keep in zone 1, zone 2, all our parameters, morphological parameters will work. But if we put, see, 340 millisecond is the cycle length, we put it as, device senses as fibrillation, none of the other parameters will work. It will only look at the rate and it will trigger a therapy. This we need to remember while programming it. Device has already charged. Since time is less, I think I will explain faster. You can see this is another patient's tracing. You can see the rate is slower here. We can see there is a tachycardia. A and V are seen. So it's again we are dealing with a dual chamber pacemaker. ASVS, the sequence you can see. Suddenly you can see it's abrupt onset. The sequence has reversed. It is VS and AS. So what drives the arrhythmia there? It's the ventricular channel. So the machine assumes that there is a tachycardia. It's going to sense after a few interval, depending on what we have kept. Then the sequence has changed. So it appropriately detects the us at fast VT. Then this X means it does not correlate with the stored template. That also you can look at. It may be different from different manufacturers, but look at this cross sign. Cross sign means the template did not match with the original template during sinus rhythm. Then tachycardia is terminated with an ATP. This properly working ICD tracing. See another tracing where you are not seeing AS and BS. So it essentially means it is a single chamber ICD. You have two channels since one is a near channel and a far channel. You can see that it's again a sudden onset here. Morphology is different. It's a single chamber. So you are looking at the QRS morphology. The axis is changed. It is again falls into the fast ventricular zone. There the morphology criteria may not work. But the problem is the tachycardia continues, but then suddenly it senses again BS only. It's no more senses as fast fibrillation. This you need to identify in the tracing. The therapy was not given because machine thought that the tachycardia terminated prior. Tachycardia anyway terminated later. So you need to adjust when you see this, you need to adjust the cycle length which is given to the ICD so that it falls in the tachycardia. It's a good practice to work with the technicians, but they do not know the clinical indication of the patient. They do not know other details. They don't know the drug taken. So it's always better idea be interrogated. Of course, we can get help from them. Then this is another case. You can see it. Similar to it, only V channel is there. So it's a single chamber ICD. V senses normally. Suddenly, the axis has become different. The QRS has become different. It does not match with the template. So it's a VT. But after some time, you can see an irregular. It's similar to the sinus beat. It matches with the template. Here it is tick mark. Here it is cross mark. That means it is not a VT anymore. But the problem is here the rate is again faster. So this algorithm will not work. Whether it matches with the template, it assumes the rate is so fast, so it triggered a therapy. So that is the importance of setting up the rate, each zones, and identifying what was the original tachyarrhythmia rate. It's the just continuation of the same tracing. It is the atrial fibrillation going on, and again VT also going on. I have 2 minutes left. We'll go faster. So this is another tracing which shows, you can see single chamber, V-sense, again two double V-sensing, correspondingly it is T-wave oversense. This is from a Medtronic device. I got it from Mr. Govind. And it's a T-wave oversensing, an algorithm going on. This is the tracing of a T-wave oversensing. There you can not only the tracings like this, we get graphs, similar pictures, a lot of things from the ICD device. You look for this tram tracking, tram road appearance here. These dark spots are the ventricular, the square boxes are the atrial. These dark boxes are parallel. This is a simple pictogram to identify the T-wave oversensing. Here this channel has noise. This is from a patient who is dependent with a single chamber ICD. The noise has inhibited the pacing and it has resulted in a shock instead. This another pictogram shows this is the tachycardia rate around normal sinus rhythm rate, not tachycardia, 1000 milliseconds. This is the fast VT zone 400 and fast VT 200, fibrillation 200 and VT at around 400. Then what happened is the entire sinus rhythm suddenly accelerated to a tachycardia, but it did not fall into our set rate. Only when the VF happened, the device recognized and given a therapy. So all these graphs help us. I will quickly sum up. I have 30 seconds left. So single chamber, uniform and identical to sinus morphology, it is SVT. Quite clear. Uniform and distinctly different from sinus morphology is VT. Variable or minimal difference from sinus morphology, you look at the abrupt onset, it's VT. Irregularly irregular, it's AFib. Symbol for us is to look at the regularity in a single chamber. If it is irregular, it's more likely going to be AF. Regular, we need to see, it could be anything, but since the indication was a tachycardia, ventricular tachycardia, we assume it as VT. If it is dual chamber, analyze atrial and ventricular rate, V more than A is VT. A more than V, ventricular morphology, ventricular interval stability, AV dissociation. You look at other criteria. Conducted AFib is one diagnosis, or VT plus AFib going on the other diagnosis. A is equal to V is again difficult. Look at other criteria. It could be SVT with 1:1. Their AS will be the sequence, or VT, VA. Its VS will be the sequence. Thank you.
Thank you, Abhilash. It's actually fairly complicated. I just have one comment to say. See, the best way to learn an ECG is to look at as many ECGs as possible. Similarly, the best way to learn to interpret an ICD tracing is to look at as many ICD tracings as possible. The problem is it is difficult in general practice to immediately get help to interpret an ICD tracing. So I would urge all of you, there's a very simple thing. All Biotronic and St. Jude ICDs, when you interrogate it, everything is stored in the programmer by default. You reopen the programmer at your leisure any day, everything with the patient's name will be there. Please reopen it, transfer it to a pen drive, and then discuss it with somebody. All Boston ICDs programmers have an option to save it to the programmer. So if you interrogate a Boston ICD, please press save. You press save, it will be saved to the programmer. You can then please go back and take it out. It can be exported as a PDF by just putting a pen drive. Medtronic, it will be manually saved to a programmer. So this is the one thing that I'd want to say. It's too complicated to teach in 10 minutes. But please do this. If you do it for 10 tracings, you would have understood everything. You'd have understood most of the stuff, but please do this. Every time you interrogate an ICD, for St. Jude and Biotronic, just go back and look at the program. It's auto-saved. For Boston, just press save. For Medtronic, please save it onto a pen drive. And then give it to the corresponding company rep. They will come back and explain it to you. You do it for 10 ICD tracings, you would have learned most of the basics. Please start doing that.
Yes, sir. We save a template while the ICD is implanted. ICD will save its template during sinus rhythm. When it is widened or when the axis shifts, that's how it's going to compare with the baseline. So the device can identify if when it widens. Depending on the near field as well as the comparison with the far field, the device is supposed to do it. Yes, that machine can look for the regularity versus irregularity. And essentially each set the rate, we need to really look at what was the original arrhythmia and the rate of it and how it is modified by the medications also. As Ajit sir was telling, a patient with LV dysfunction, we may not keep the VF setting at 220 or 230. We may have to reduce it to say 190 or 200. Similarly, each individual, we have to individualize the patient settings. Thank you, sir.
Thank you, Dr. Abhilash. As usual, it was a pleasure listening to you. Wonderful presentation. Thank you very much. In the interest of time, let us have the next speaker quickly on to the dais, Dr. Arun Govi. He will be talking to us on newer advances in ICD technology.
Yeah, respected Chair friends. So moving on to the newer advances, slides on, yeah. So 50% of all cardiovascular deaths are sudden cardiac death. And ICD, as you all know, is the gold standard for preventing sudden cardiac death. The Achilles heel in ICD continues to be the transvenous lead, which has a lead survival rate of 90% at 2 years, 85% at 5 years, at 60% at 8 years. So the weak link is the transvenous lead. And in addition to that, there are many issues that we have with the venous access issues, the lead-induced issues like pericardial effusion, cardiac tamponade, perforations, pneumothorax, lead failure risk on the long term, leading on to inappropriate shocks, and the issue with extraction of these leads leading on to venous damage. So to circumvent this, in addition, we have more and more physicians implanting device. With this more and more increase in the device implantation, there comes the increased risk of CID infections. To circum this has come in the last decade or so, the subcutaneous ICD, where there's nothing transvenous. Everything is actually entirely subcutaneous without transvenous leads. Does not require you don't need to touch the vasculature. It's placed purely on anatomical landmarks, reducing the need of fluoroscopy. They have sophisticated algorithms to differentiate between SVT and VT. There's a screening tool which you need to look at the patient, whether the patient fits in for an SICD implant. The ECG should fit into the screening tool. And the implant procedure does not require venous access, no fluoroscopy required, average about 1 hour procedure time, very predictable, and it's a straightforward implant. And this is how it's implanted. In the axillary plane is the PG, and the lead is in the parasternal area. And the newer device in this, the emblem SICD, has a thickness less than about reduced by 20%, and the longevity increased by 40% with the ability of remote monitoring as well. The advantage of SICD looks at the rhythm like a surface ECG, and compared to intracardiac ECG, with the surface ECG you have better discrimination. In addition, there are 4 double detection algorithms to determine the heart rate as well as differentiate SVT and VT. In addition, it can deliver up to about 5 shocks for about 80 joules. It also has the ability to pace from transthoracically, but up to about 30 seconds after the first shock. SICD currently is recommended in patients as a class 1 recommendation for all patients who require an ICD who have inadequate venous access, who are at high risk of infection. So when you define patients at high risk of infection, that means prior device infections, patients with ESRD, patients with diabetes, patients who are chronically immunosuppressed. These are patients who have a class 1 indication for an SICD. And the latest on this is a randomized control trial head-on-head between SICD and transvenous ICD. It was the ATLAS study, and the ATLAS answer as a praetorian was very clear. There's a 92% lead-related complication reduction with SICD and a 79% reduction of lead complication in the praetorian trial with SICD compared to the transvenous ICD. The issue always earlier was inappropriate shocks, but with the recent current algorithms, there is actually equivalent inappropriate shock with the SICD as with the transvenous ICD, so inappropriate shocks are not increased. And the other concern was about longevity. The current SICD gives about 8.7 years of longevity. So currently, SICD is the preferred device in patients who don't have venous access, like an occluded brachiocephalic or an occluded upper venous system. People who have high risk of complications of transvenous system, like patients on dialysis, pediatric patients, immunocompromised patients, patients who have channelopathy who just need a shocking box, people who have previous device infections or lead failures, people who have history of endocarditis. It should be strongly considered in patients who are young, patients who have life expectancy more than 10 years, primarily for primary prevention ICD patients with prosthetic valves, women if they are women, and for people who have secondary prevention, especially who do not have any monomorphic VT recorded. It should not be used in patients who require resynchronization therapy, who have symptomatic bradycardia requiring pacing, or who have more sustained monomorphic VT in whom ATP would work. Because the major disadvantage of SICD is it's just a shocking box, it does not pace. So if you read pacing in either in the form of CRT, brady pacing, or ATP for monomorphic VT, you can't use SICD. Now, the other advances has been on the generator size. The Boston has come with a mini ICD, which is slimmer, sleeker, 20% reduction in the volume of ICD to about 26 cc and a thickness of about 9.9. Even in the slimmer mini ICD, it has still capability of giving a 41 joule shock, has additional algorithm for prediction of apnea, that is AP scan, and the right algorithm for chronotropic incompetence, also retaining the ability for remote monitoring. So smaller size device, but all the capabilities still there. You have smarter algorithms which are come in ICD. This is called the intrinsic ATP algorithm or the smart ATP algorithm, which is there in the Medtronic Cobalt ICD, which actually looks at why an ATP failed to terminate a VT. So essentially, it has to be just programmed on and off. You don't have to think much. It's fully automated smart ventricular anti-tachycardia pacing algorithm, which actually individualizes the ATP for each patient. And you have a real-time response detection, and based on the response, it actually adjusts the next ATP sequence. And with this intrinsic ATP, it is actually shown that the termination of VT has increased by 17% higher than the traditional ATP. So what it does, it designs ATP for each VT. It looks at 2 criteria for the ATP success, whether it has been able to reach the VT circuit and is able to deliver an appropriately timed extra stimulus. It assesses the post-pacing interval and looks again whether it has been able to reach the VT circuit or if the extra stimulus was properly timed. And then based on the input from the post-pacing interval, it adjusts the next ATP so that it improves the success rate. So it looks at primarily what you look at the entrainment phenomenon. It looks at the post-pacing interval after an anti-tachycardia pacing. You have 3 scenarios. Sometimes ATP fail because the S2 has not reached. In that scenario, you put more of S1s. In the second scenario is where the ATP has failed because the S2 was not able to reset the VT. There you put an earlier S2. In the third scenario is if the ATP has failed because the S2 has not captured. In that scenario, you make a later S2 and add an S3. So based on the post-pacing interval, it's all automatic. You don't have to think much, just have to put it on. Based on the post-pacing interval, it looks at whether it has been failed to reset. In that, it adds another S1. If it has failed to reset, it has reset actually, then it shortens the S2. And the third scenario is where it lost capture, then it actually lengthens the S2 and adds an S3. The other algorithm is TrueAF in Visia Medtronic devices, where it uses the Lorentz plot to look at the RR variability and predicts AF And it's the single chamber device. It has good AF prediction. And the next algorithm, which is an Abbott algorithm, has been VF therapy assurance. It is primarily to prevent VF undersensing, that is to identify and treat rhythms which are inherently likely to be hemodynamically unstable. Primarily looks at poor far-field sensing on the discrimination channel at strategic times, and then applies newer detection parameters whenever the criteria is met. So it primarily looks at signal drop. You look at the second picture, you can see poor far-field sensing. Some VF signals are actually undersensed, and that can actually trigger the VFTA. And it looks at two independent counters, where in the far-field algorithm, it looks at whether you have low amplitude signals, which is 0.3 to 0.6 amplitude, and then it's set on, or if you have a pause in the far-field signal for more than 2 seconds, again the VFTA algorithm is set on. And once the VFTA is triggered, it actually it shifts the detection to a single therapy zone, that's a VF only. The newer VF detection rate is decreased, the lowest program active therapy plus 100 milliseconds. The number needed to detect is decreased to 6. The end of episode or return to sinus is actually increased to 7 intervals, and permanently programmed VF zone therapies are used actually. The advancements as the lead has been an takeaway from the select secure lead or the conduct system pacing lead, which is 4.5 French. 4.1 French. So they have been a lot of work on this to make this Omnia secure lead, which is actually a hybrid of the select secure lead and the conventional 8.6 French ICD lead. Now we have this Omnia secure lead, which is a 4.7 French lead, which has shown to have at least 97% defibrillation success rate, and in the leader trial has shown to be quite effective. The DX lead from Biotronic is there with us for a longer time. It has better diagnostic accuracy on the atrial channel. It reduces the procedural complications because you don't need to implant an atrial lead, and it is CRT capable. So it's currently a single chamber lead which gives better AF detection, better SVT discrimination, lesser implant complications. Only disadvantage is no atrial based pacing, and it can also be used for using a 2-lead CRT. So this with the Biotronic newer generations have at least 14 years of longevity. It has auto-detect MRI as well as remote monitoring. And the newer advancement has been trying to place the ICD lead in the left bundle branch area pacing lead. We use the traditional EP sheets, that the Schwartz sheath or the Lamb sheath, and we manually pre-shape and then drill these ICD leads into the left bundle branch area pacing. And the latest one has been extravascular ICD from Medtronic, which has a substernal lead. So the major disadvantage with the subcutaneous ICD has been that it does not has the ability to pace. So this extravascular ICD, this has actually a substernal lead which is actually implanted. So this is an animation of how it is implanted. It's not available with us, but it's in the US, it's already there. So this is how the substernal lead is placed. The earlier transvenous lead has failed. So this is how the substernal lead is placed. It has the ability to pace. It can give brady pacing. It can give anti-tachycardia pacing. And then the remaining part is just like how you place a subcutaneous ICD. You place the PG in the axillary pocket and then get the lead out from there. And this is the implant, and there's actually some amount of evidence which says that this has good amount of sensitivity, good safety margins for defibrillation, ability to pace, good sensing thresholds, and there's a data in New England Journal about 300 patients showing its safety and efficacy. So the last one is actually a hybrid device, which is actually a combination of SICD and a leadless pacemaker, which is actually called the modular therapy, this is for the future. There's a theoretical concept of combining a leadless pacemaker inside the heart and a subcutaneous ICD in the subcutaneous plane, wherein which the ATP needed for monomorphic VT is actually delivered via the leadless pacing. So this is the modular therapy from Boston. So to conclude, a lot of advances have happened in the ICD technology at almost every level for better delivery of therapy. We have newer devices, the SICD, for taking away the issues with the transvenous lead, and now in future we will be having the extravascular ICD, the substernal lead, which also has the capability to pace. We have newer leads, the DX lead already with us. Omnia secure lead will be available with us in the future, a lower French lead, which will reduce the complications further. The mini ICD is there, which has miniaturized and has retained all the capabilities. We have newer pacing sites, so we are trying to put these ICD leads into the conventional left bundle area pacing area, and probably the Omnia secure is also being tried to place into the left bundle area pacing. And we have newer algorithms like True AF, intrinsic ATP, and VF therapy assurance, which improves the diagnostics of ICD. And probably in future, we'll have this hybrid device, which is SICD plus a leadless pacemaker, which is called the modular system, which would have a totally device in the subcutaneous plane and the capability of overdrive pacing the monomorphic VT through a leadless pacemaker. So before I conclude, I'll thank my team. This is my team actually who has helped not only making the slides, but a special thanks to Amira, who has helped me in making the slides. So thank you.
Thank you, Arun, for giving us a great glimpse of a lot of exciting things which are coming up. Do you think it's more likely that we'll start implanting more dual chamber ICDs once we have the Omnia Secure?
Yeah, it should be actually that's what Omnia Secure primarily is going to reduce the lead related issues, and the defibrillation thresholds are going to be good actually. So the venous access issues are going to come down with a 4.7 French lead. So, but you'll have to look at how many patients who require atrial pacing. Primarily, the intention of a dual chamber ICD is to just
What I mean is the downside of the dual chamber ICD is ventricular pacing. If we can get the lead into the left bundle branch area, then it could then just about every ICD would by default would become a dual chamber left bundle area pacing ICD, unless there's a septal
Omnia
scar.
Secure is being worked in that line. The what I showed was the conventional defibrillator leads placed in with the EP sheets. Omnia Secure, once it comes in and once it has the capability, if you add an atrial port also with it, it's going to have a single chamber CRT device or single chamber resynchronization device. You have an atrial port also with it. You put a DXICD through this DXICD lead, and that's going to be the end of it.
Probably. I hope it'll go in that direction so that multiple implants.
Yeah, so one lead can actually resynchronize.
Pacing will reduce.
How can the subcutaneous ICDs will have the same accuracy to differentiate between an SVT and VT?
Actually, reverse way. It has better accuracy. See, what does a subcutaneous ICD look? It looks at what you detect from the surface. So what the signals that subcutaneous ICD gets is similar to ECG. On the other hand, what does ICD look? A transvenous ICD looks at local bipolar signals, which is much more inferior in detecting a rhythm. So that is why subcutaneous ICDs are better, because you are getting actually the ECG, and there are there's a smart pass actually algorithm, which is actually more sophisticated than the algorithm that is used in the transvenous ICD. That's why the latest, if you look at the trials, the Atlas trial clearly shows that the inappropriate shocks due to SVTs is actually lower with subcutaneous ICD, almost lower with subcutaneous ICD compared to even the latest transvenous ICD. You're looking at ECG rather than EGMs.
So let me just explain what Arun said. So in a conventional ICD, the sensing is from here to here. It only detects the electricity from here to here. Imagine detecting the electrical bipole from here to here and telling is this VT or SVT. Very difficult. Whereas subcutaneous ICD detects the electricity from here to here, here to here, and here to here. It's like having 3 ECG leads. So the subcutaneous ICD has a much bigger, much better chance of discriminating than the intracardiac leads.
Typically, even for a wide QRS tachy, your local bipole will be actually a strict and narrow QRS. It will be a sleek EGM actually. But on the subcutaneous ICD, it will be different.
Yeah. So it's a great discussion, but unfortunately, it needs to come to an end so that we can start the next session. Thank you, Arun, and thank you, Shiv Prasad sir and Abhilash. Thank you.
We would like to invite the chairperson for the next session. The session is New Frontiers in EP. We'd like to invite Dr. Anis Tajuddin, Dr. Harikrishnan S, and Dr. Narayan Nambudiri on the stage.
Good evening, teachers and colleagues and friends. This is an important session on new frontiers in EP. We have 2 invited lectures, both from US. The first will be utility of intracardiac echocardiography in EP lab, the basics by Dr. Mansoor Rasminia from Illinois. So the both talks are recorded.
The talks are recorded, but these prominent speakers, very well-known international faculty in the field of electrophysiology, they are available online for the discussion immediately afterwards. Dr. Mansoor Rasmania has contributed a lot to the understanding of eyes in electrophysiology, and is a very seasoned teacher for many of the famous electrophysiologists as well. We are very fortunate to have him as a speaker. He immediately accepted our request, and we are really grateful for that. Can we have the presentation online? Recorded one?
Hello, my name is Mansoor Azminia, and I would like to thank KHRS for this kind invitation. I will be speaking on utility of eyes in the EP lab, and we're going to talk about the basics. So this is an intracardiac echo. You can see the A is for anterior, P posterior, R for the right turn, and L for the left turn. So those three indicator knobs, all the time, they have to be aligned, which means we are neutral. So whenever they are aligned, means we are neutral. We have to remember that. So always put those three indicators on the same line. So here we are performing anterior tilt. Try to use your thumb and index finger to do that. Just the right hand. Here is the posterior tilt, which goes to the P, right tilt. And here we are going to go to the perform left tilt. There are other movements, of course. After we come back, we would be able to make sure that, first of all three indicator knobs are aligned, so we are neutral. So what are the other movements? We are going to perform clockwise rotation, then we are going to perform counterclockwise rotation, we are going to advance the catheter, and we are going to withdraw the catheter. So I really think that if these 8 maneuvers that we have with the eyes, if we give them like musical notes, we can really play a symphony with the eyes and makes our life much easier. And it's a beautiful symphony that as if you have gone to an orchestra and you will enjoy it. How do we advance the eyes? It's going to be through a 10 French sheet on the left side. As we are advancing, we have to remember that we always want to make sure that we have a black horizontal on the top. So imagine that this is my eyes catheter. As I'm advancing towards the heart, you always want to make sure that there is a free space at the leading edge. That means there is blood. So black here is blood. White is the tissue. So you always want to make sure that in front of the eyes is black. So here you can appreciate that's the IVC. I'm trying to advance it towards the heart. So as we are advancing it, you see that we went to the right atrium. Here you can appreciate as we are advancing it, as opposed to this being a horizontal, you see that, let's say we are going from iliac to the IVC and it is slanted. So when it is slanted, that means that we are going to perform anterior tilt to dive into that structure. Each time you do anterior tilt, you dive into a structure which then make that structure become horizontal. And we're going to talk about it, why this structure become horizontal momentarily. So then as soon as you advance it inside that structure, you go ahead and remove the anterior tilt. Let's take a look at it. You see that this is IVC slanted. We perform anterior tilt. We made it become horizontal. And I'm just advancing it towards the heart. Remember, as soon as you perform anterior tilt, you make that structure become horizontal. And when you go to that structure, you remove the anterior tilt, make it neutral. And we go ahead and advance the eyes from the IVC to the right atrium. Here is the home view. We can see the right atrium, right ventricle as we go into the right atrium. So let's see what structure we see in the home view on eyes. So on eyes, this is a CTI that we perform our flooded line, region of the His, RV, RVOT, and that is on the top left is the IVC. So the first thing we always want to perform would be to advance the eyes inside the right ventricle. How do we go about it? You see that I'm advancing it from IVC. We see the tricuspid valve. We are going to perform anterior tilt, which means that we are going to be advancing it, dive into the right ventricle. So when we dive into the right ventricle, we make the right ventricle become horizontal. And let's take a look at it, what I mean by that. So here you can appreciate that this is an orifice of the tricuspid valve. And we want to go through that orifice. So you always want to make sure that it opens up so nicely. So those 2 dots that you can see on top of the screen would be your transducer. That's the distal end of the transducer. And this is the proximal end of the transducer. So let's take a look at it again. That is my transducer. And it is looking down like this. And remember, those two dots would never move on the screen. So the heart is going to move. Those two dots, even though you're moving the catheter inside the structure, those two dots are not going to move, are going to be always horizontal on the top. That's why you see the structure moves, comes up and become horizontal. So let's take a look at this. This is the tip of the transducer. And I want to advance the tip of the transducer through the tricuspid valve into the right ventricle. So let's talk about it like this. It is as if I'm going to go through a French door. So where is the French door? French door here is the tricuspid valve. We are going to go from the right atrium through the tricuspid valve through the right ventricle. So that is very crucial that if I'm going to go from room number 1 through a French door, which is opening and closing, to room number 2, I have to be able to see all 3 structures in front of me. So if I go through the room number 1, I have to see the tricuspid valve, which is a French door, and then I have to see the room number 2. So that's very crucial that whatever structure is in front of you, if you don't see it, you should not advance it. Let's take a look at it. So this is the ice is going to go through the tricuspid valve. From room number 1, we are going to go through the French door to room number 2, correct? So that is very crucial. And you have to be able to see all these 3 structures at every moment as you are performing anterior tilt and diving. If you don't see any of these structures as you are advancing your catheter, there's going to be a problem. You're going to have complication because you are not going to the structure of your choice. You are not going through the tricuspid valve into the right ventricle. So remember, we are going to go down like that, but in reality, that dot is not going to move on the screen. So in reality, the French door, the tricuspid valve is going to come up and become horizontal around that structure. You see now that that structure became horizontal because those 2 dots would never move on the screen. So it is very important to remember that. That is my ICE catheter. So right now I advanced the ICE catheter a little bit. And what do we have in front of that dot? We do have a tissue which is white, which means there is no blood in front of it. Now it is a tissue, and that is the time that you should not advance your catheter anymore. So what we are going to do, we are going to undo the anterior tilt, perform a clockwise rotation to be able to see the left ventricle. It is very important. Why? Because we want to see if there is any baseline pericardial effusion or not. Because we want to see if we have caused this. If the patient comes to the lab and the first catheter I put is the ICE catheter, this is a baseline pericardial effusion. I haven't caused that. But if we don't know about it and we see it during the procedure, we get, oh, panic. Did we cause that? And sometimes Murphy's Law wants the blood pressure immediately drops. And unfortunately, you want to do a tap, which is not a good thing to do there because patient came with it. So let's take a look at the coronary sinus. Here, from the home view, if you perform clockwise rotation, you're going to see the coronary sinus. But when you see the coronary sinus, if you perform minimal left tilt, remember left tilt starts with letter L, and this causes the longitudinal, which is also starting with letter L. And we can see the longitudinal CS, and here you can appreciate the TBCN valve. Here you can appreciate again, I have performed left tilt and clock, and I can see the left atrium, coronary sinus, and we are now doing the catheter ablation of coronary sinus epicardially. Let's take a look to see how we visualize the left atrial appendage from RVOT. Again, remember, we are going to advance this ICE into the right ventricle. We have a ICD lead right here. We perform anterior tilt. Went to the right ventricle. We are going to remove the anterior tilt and clock to see the left ventricle. Here you can see the left ventricle. If we perform a little bit further clockwise rotation, we are going to be able to see the appendage. In this view, actually, interestingly, we have a nice left atrial appendage view that is a ridge, that's the left superior pulmonary vein, but we are really not always lucky as such to be able to see the appendage as good, because majority of time, the appendage from the RVOT, unfortunately, you cannot see it as good because you have a distance from your eyes to the left atrial appendage. That distance would cause problem because the waves have to be deflected, so you cannot penetrate through that LV, LA, a little bit of, aortic valve to be able to see. So here, another case, let's take a look at that. You can appreciate that that's a left atrial appendage. And again, it is not getting a very high definition view of the left atrial appendage. So what should we do? We have to look at the left atrial appendage from the pulmonary artery. How do we do that? The first thing first, we go to the RV, release the anterior tilt, perform clockwise rotation. We see the left ventricle. We perform further clockwise rotation. Now we are going to see the RVOT, pulmonary valve, and pulmonary trunk. And that is my left atrial appendage, which to me, this is not acceptable to rule out left atrial appendage thrombus. Then if we perform further clockwise rotation, now we are going to see the RVOT. We are going to see the pulmonary trunk. We are going to go to the right and the left pulmonary artery. So here, again, the analogy of the French door comes. So you're going to perform, again, anterior tilt to go through the pulmonic valve into the pulmonary artery. So again, let's take a look at it. I'm going to perform anterior tilt, and imagine this is, again, room number 1, another French door, which is the pulmonic valve, and this is the room number 2, correct? So I have to be able to see these 3 structures at every moment. Room number 1, French door, room number 2. If I don't see them in front of me, I'm going to perforate. So you want to see French door completely opening. Take a look at it. So I can see now the French door in front of me, and I can see the pulmonary artery. Safe, no issue. Keep performing anterior tilt. Now we are inside that pulmonary artery because those 2 dots that we cannot see it very well here is parallel, and it is inside the pulmonary artery. Again, let's take a look at it. I'm performing anterior tilt, advancing it, and I keep looking at the pulmonary artery, make sure I can see it. And as soon as I get to the main pulmonary artery, here, if I go and perform counterclockwise, I would be able to see the left atrial appendage. Remember, this is one of the only areas inside the heart that you should not release the anterior tilt. Here you can see left superior pulmonary vein and bridge as well. And if you perform a little bit clock and counterclockwise rotation, you would be able to see very nicely the left atrial appendage. So if you take a look at that, those 2 dots, remember, those 2 dots are going to be my ICE catheter, correct? And see the tip of the transducer, how close the tip of the transducer is to the apex of the left atrial appendage. So that is when I say, let's rule out left atrial appendage thrombus from pulmonary artery. If you're not comfortable, you have to use TEE. Never do it from the RVOT. Why? That is the difference. The other one on the right, the view, you can see that we were trying to rule it out from RVOT, and that is that much distance to the left atrial appendage. And otherwise, here you can see the left atrial appendage much better from the pulmonary artery, and we would be able to safely rule out left atrial appendage thrombus. And you can see the ridge and left superior pulmonary vein as well. And let me show you this. Imagine this is a patient. I'm inside the RVOT. That is the left atrial appendage. And I say, oh, yeah, that is nice. There is nothing inside the left atrial appendage. Let me go ahead and perform transeptal puncture and proceed. But you should never trust this view from the RVOT. This is the same patient. You can see I can advance it. I just do perform clockwise rotation, advance it inside the pulmonary artery, keep the anterior tilt, and perform counterclockwise rotation. And this is the very same patient I just showed you from RVOT, which didn't show anything. And you can see this patient has a large thrombus, and we had to abort the procedure. Otherwise, if we didn't know about it, we would have caused a stroke, unfortunately. Let's talk about the transeptal puncture. So we are going to prepare for the transeptal puncture. This is a home view. Again, right atrium, region of the His, right ventricle. We are going to see the RVOT, and that's the ascending aorta and aortic valve. From this view, if I go and perform a little bit clockwise rotation, let's see what we are going to see. Just a little bit clockwise rotation with the eyes, we are going to see a little bit towards the left atrium. So that's a septum, left atrium, left atrial appendage. That's the mitral valve, left ventricle, and coronary sinus. So here, if I go and perform a little bit further clockwise rotation, I shouldn't see the left atrial appendage or coronary sinus anymore. Let's see what I'm going to be able to see. Here you can appreciate that this is septum, that is the left atrium, that is the left superior and left inferior pulmonary vein, and that is SVC. So if I perform very minimal posterior tilt, I would be able to advance this eyes into the superior vena cava. So let's take a look at it. You can appreciate that is the superior vena cava. I always advance the eyes inside the SVC for transeptal. It makes really your life much easier. So now we are going to advance the wire inside the SVC. You can appreciate this wire is going inside the SVC. This is a regular wire that we are advancing it. We saw it in the RV. Now we are seeing RA. Now we are seeing it in the SVC. Here the wire is going inside the SVC. And you can appreciate, you need to make sure you see the wire moving. Otherwise, that could be a pacemaker lead, and your wire could be in the liver. So you got to make sure that you see the wire in and out of the SVC. That is very, very crucial. Now we are going to go ahead and advance the sheath and dilator over this very wire into the SVC. Now, if you appreciate here in this view, I have the left atrium, SVC, that is the wire, and I'm advancing the sheath and dilator over the wire inside the SVC. Here you can appreciate the wire. That is the sheath and dilator. I just go ahead and remove the wire, and I'm doing a slow motion. You can see it here. We are going to remove the wire. We are going to leave the sheath and dilator inside the SVC. Here you can appreciate the wire is coming back, so coming out of the body, and we are going to keep the sheath and dilator inside the SVC. So if I'm going to use a Baylis needle, this is what I would do. So you are going to first do some measurement outside of the body, which is going to be unique for the same for every case. If the Baylis needle is this much out, means the needle is not exposed on the other side. So that is very important to know. So what I want to do, I want to pull back the sheath and dilator to expose the Baylis needle. I do not want to advance the Baylis needle inside the SVC. I want to keep my right hand steady, pull back the sheath and dilator over to expose the needle. So this way I would be able to see the needle inside the SVC. And because Baylis needle is atraumatic, you would be able to show it on your map. And by dragging it down, you would be able to see it on your map. And you can appreciate that now the needle is coming down towards the fossa ovalis. And we would be, of course, able to see it also on the eyes. And here you can appreciate we perform RF, and you can see that that dot went to the left atrium. But of course, the main visualization of this would be through the eyes. So I'm pulling it back right there. You can see that I'm performing radio frequency. The tip of the needle is in the middle of the left atrium. You do not need to give any dye or, of course, any saline or anything, because you would be able to see the tip of the needle. You can see it very here. You can appreciate again that was the tip of the needle. This is descending aorta, left inferior and left superior pulmonary vein, and that's the tip of the needle. Advance the sheath and dilator over the needle and remove the dilator as well as the needle. Let's talk about one catheter ablation. This is a PVC from endocardial aspect of the LV summit. You can appreciate that is my PVC, which is positive in V1 to V6. So here you can appreciate that is from the home view. If I perform a little bit clockwise rotation, this is the view I'm going to be able to get, okay? So that is the view that I'm going to be comparing it here to this McAlpine view, and you can appreciate left ventricle. You would be able to see the aortic valve, aorta, pulmonary artery, and that is the thickness between the endo to epicardial aspect of the LV summit. In this view, if I go and perform a little bit clockwise rotation, I would be able to see the left main, and you can appreciate now there is a color Doppler that I would be able to see that left main color Doppler. If the PVC is coming from that area, you can see that my ablation catheter is going in. I perform a candy cane and just advance and make a U curve and place it right in that LV summit endocardially, which is, again, you can compare it to this McAlpine view. So here you can perform catheter ablation, which is majority of time. This view is going to show you exactly at the juncture of right and left coronary cusp. Under that, you would be able to see it in the short axis view. Here, let's take a look at the short axis view. And when I perform a little bit clockwise rotation, going inside the RV, I would be able to see the short axis view, and that is a left and right coronary cusp. And you can appreciate that that is the ablation catheter right in between the left and right coronary cusp. And that is the region that many times you would be able to perform endocardial aspect of the LV summit PVC ablation. And here, as we started radio frequency on, we see that very early we were able to eliminate that PVC. But again, sometimes you're not as lucky and you have to stay there for a couple of minutes to be able to perform a good elimination of this PVC. This is a case that I want to show you how much ice can help us. This is a left atrium. This is a transeptal sheet. And this was an air which was trapped inside the left atrium. So the problem is that we had a problem with that sheet. So what am I going to do right now? You can appreciate I have a mapping catheter inside my sheet. I go then pull back this mapping catheter outside of the sheet and keep the sheet right there. And then what I'm going to do next, I'm going to advance the transeptal sheet towards this air pocket. And then right there, I'm very close to the air pocket. We are going to grab a 20 cc syringe, and we are going to have this empty syringe and start aspirating this air out of the left atrium rather than waiting for this air to get resolved. So that would save the patient, of course. At the same time, we can proceed with the rest of the procedure. And with that, I would like to thank you very much for your attention.
Thank you, Dr. Rasmani. It was a great talk. Are you online? Can we have the...
Do you hear me?
Yeah, yes. Yeah, it's a great talk. We have some queries like, do you take this ICE catheter into the left atrium transeptally and for better delineation of the pulmonary vein, or do it from the right atrium itself?
The ICE catheter should always be where your ablation catheter is. So if your ablation catheter is inside the right ventricle, you place the ICE catheter inside the right ventricle because you want to know exactly where your ICE catheter is located. So whenever I'm doing ablation of the left atrium, not for just, pulmonary vein isolation, also for a, sorry, I don't know if I'm going to, okay. Also for the PVI or left lateral axillary patio. So always place the ICE adjacent to that very same wire and place that inside the left atrium. You always need to place the ICE very close to your ablation catheter. And by just finding the wire on that, ICE, when you see where the wire is through the transeptal, find it, advance it across the, adjacent to the wire into the left atrium. Also, if you are going to do any Watchman or any other left atrial appendage closure, I always do it with ICE in the left atrium.
Any queries from the floor?
Is it always possible to see the left atrial appendage on ICE, or you have some cases where you are unable to? You have to use. I think you mentioned you have to resort to a transesophageal echo in certain cases to confirm left atrial thrombus.
Sure.
And the other thing I
Yeah.
want to know, how do you ablate, how is it useful in patients with Wolff-Parkinson-White syndrome?
Yes. So basically, the movie that I just showed you, it is on my computer here. It is about 5.5-hour movie I have. I may have done that movie on my software on the computer. So for the left lateral axillary pathway, when you advance the ice inside the left atrium, there is certain location which is going to be right at the lateral aspect of the mitral valve. It is very unique. The moment you see that, you place your ablation catheter, make sure that a tip of it is inside the ventricle, proximal part of it is inside the left atrium, and it makes your life much easier. Literally, you can sometimes do a left lateral axillary pathway much easier by just looking at the ice and not even needing. I haven't used X-ray for 14 years, but many times I don't even use mapping. I just purely use ice for entire procedure. The first question was the left atrial appendage. 99% you would be able to see it from pulmonary artery. Sometimes if you have difficulty, you can place your eyes inside the coronary sinus and look at it there. When you go to the coronary sinus, you perform clockwise rotation to a V shape, like it become really V-shaped appendage, which is going to be the tip of the appendage is going to be here, the apex, or two cases very rarely. I have done very gentle transeptal, very carefully advance the eyes just a little bit inside the left atrium, and two cases I was able to see the thrombus inside the left atrial appendage. But I haven't used T for close to probably 2 decades now.
Thank you, Dr. Mansoor. Dr. Ajit, any?
Thank you.
One more comment.
Sure.
Thank you for that very clear presentation. Could you tell a little bit about the ice catheter manipulation to visualize the anterior and posterior papillary muscles of the left ventricle?
Sure. If you guys have, I have the software on my computer. I can show it to you. But I know that you guys are running behind. So hopefully in another session, I would be able to do that. But what you do, the moment you place the ice inside the right ventricle, perform clockwise rotation. When you do the clockwise rotation, first you see the septum, then you are going to see the left ventricle. So the moment you see the septum, the first pap muscle is going to be posterior medial pap muscle because it is medial. This is closer to the septum. Then when you perform further clockwise rotation of your eyes, you will see the anterolateral pap muscle. So when you see the anterolateral pap muscle, if you counterclock it a little bit, you will see the posterior medial pap muscle. When you see the posterior medial pap muscle, when you clock it, you will see the anterolateral pap muscle.
Thank you, Dr. Mansoor, for that wonderful presentation and the
Thank
discussion. We'll move to the
next
talk on cardio neuroablation, which is an emerging thing which is coming up. The emerging role in electrophysiology. The speaker will be Dr. Ragesh Gopinathan Nair. I request Dr. Anis to introduce the speaker.
So Dr. Ragesh is our own alumni from Medical College. He was 1 year junior to me. He's now in Kansas EP Heart Rhythm Center. He's an EP lab director there. He's into AF. He's in various writing groups for Heart Rhythm Society, and is also into newer technologies like wearables for arrhythmia and also cardio neuroablation. So he notes, probably he doesn't require much introduction to our EP crowd. Anyway, welcome, Dr. Ragesh. Can you start the presentation?
Good evening, everyone. Thank you for the opportunity to present at the Kerala Heart Rhythm Society meeting. Thanks to Dr. Nambudri and the organizing team. The topic of my discussion would be cardio neuroablation as an emerging role in cardiac electrophysiology. And these are my disclosures. We'll start with the case. It's a 28-year-old healthy female with recurrent syncopal episodes with standing with no structural heart disease. Had 8 episodes last year, and these were reproduced by tilt table testing with 20-second systole and with no improvement with conservative as well as medical therapy, and she's been referred for a pacemaker implantation. Is there an alternative option to this young woman with rather than doing permanent pacing? So this is her tilt table. As you can see, long asystolic pause here. We'll do a second case for a different patient, 39-year-old male with recurrent syncope and dizziness. Also has dyspnea at the beginning of exercise that resolves in a few minutes. He has had frequent syncopal episodes in his teenage years occurring with standing and light exercise. Again, no prior cardiac history or signs of heart failure. Baseline EKG shows sinus with high degree AV block and a narrow QRS like shown in the panel on the left. And also you can see some on the right side as well. So what would be the differential diagnosis in this particular patient? How do you, figure this out basically? So for our 39-year-old, we gave him atropine, and with 2 milligrams of atropine, the heart rate increased from 75 to 103 beats per minute, and one-to-one conduction resumed with a PR interval of 240 milliseconds. He had a tilt table test, showed typical cardioinhibitory response with an asystolic pause of 22 seconds that resulted in syncope. EP study showed an HV interval in the normal range of 46 milliseconds. AV block was above the level of the His boundary. With atrial pacing during EP study, at 600, he had one-to-one conduction with PR interval of 271 milliseconds. With faster atrial pacing, still had one-to-one conduction, but the PR kept prolonged to 351 milliseconds at 500 milliseconds pacing cycle length. So both these, the first patient has cardioinhibitory vasovagal syncope, and the second patient likely has a functional AV block or vaguely mediated AV block with AV nodal level of block. So what is cardioneuroablation? It's a procedure where autonomic nervous system modification is done using ganglionic plexi ablation, and it's an emerging strategy for cardioinhibitory VVS as well as vaguely mediated bradyarrhythmias, which include functional AV block, as well as those with slow sinus rate that's symptomatic, where especially in younger people who do not otherwise have a known sinus node dysfunction. CNA or cardioneuroablation predominantly results in parasympathetic denervation when used in patients with vaguely mediated bradyarrhythmias. It can also potentially have an impact on sympathetic denervation as well, as I will show in some of the data. So how do you identify this ganglia? For the longest time, extracardiac vagal nerve stimulation was a technique used, which is still very feasible to use, but it requires special setup and dedicated equipment. The other sort of easier way to identify is to use fractioned electrograms during sinus rhythm. So in some of the studies predominantly done by Tolga Aksu's group in Turkey, they've identified two different types of fractioned electrograms. These are low amplitude fractioned electrograms as well as high amplitude, meaning like low amplitude is 0.7, less than 0.7 millivolt. High amplitude is greater than 0.7 millivolt, and each of them should have at least 4 deflections. And these electrograms at the putative sites for ganglia, which are shown here, there is in the posterior aspect of the left atrium here, in the you have the left superior ganglia. There is a left inferior one. There is one called Marshall tract one, which is actually between the antrum, between the left superior and left inferior pulmonary veins, and at corresponding to the ligament of Marshall region. There's the right superior GP at the antrum between the right superior and right inferior, with an extension on the right atrial side into the SVC. And all these ganglia are epicardial, and we are ablating them from endocardium to modulate them. So this next image shows some of the ablation lesions. As you can see, these are focal ablations, usually use about sort of 30 watts or so for about 30 seconds at each GP site, which shows fractional electrograms. Usually for the sinus node innervation, the most important ganglia is the right superior ganglionic plexi. And most of the time you can ablate this from the left side. And if there is no significant response, you can move to the right atrium and ablate from the opposite side to have the desired effect. And for the AV nodal innervation, the most important ganglia is the one shown here and called the posteromedial left GP. It's on the posterior aspect of the coronary sinus, it can be it's likely best ablated from the left atrium, and you can use intracardiac echo to guide the location where you need to go. It usually corresponds to the sort of the inferior limbus region of the interatrial septum, and the Marshall tract. So both the left-sided GPs as well as the Marshall tract GP should cause you to have significant heart rate slowing corresponding to the parasympathetic effect. So the ablation is usually performed using an open irrigated catheter. Endpoint is near complete elimination of atrial electrograms in targeted regions with no new vagal response during radiofrequency application at a previously ablated site or previously positive site. Clinical endpoint for cardioinhibitory vasovagal syncope would be achievement of 75% of a post-atropine heart rate. You can give atropine to these patients at baseline, get a maximal rate, and then try to get closer to the 75% post-atropine heart rate. And usually with right superior GP, you'd start to see at least 20, 30 beats, 15, 20 beats increase in heart rate in this case. For functional AV block, you want to look at reduction in PR interval, and at least 25% will be ideal. Follow-up endpoints would be, reduction in recurrent syncope, asystole, lack of asystole in tilt table test, and loss, no evidence of second or third degree AV block or any, and sometimes you can see changes in QT interval, especially shortening, which we think is likely an effect on the sympathetic system. Studies have shown that biatrial, meaning predominantly left atrial with any additional ablation needed in the RA, is better than right atrial ablation alone. And the two studies have shown that to be the case. So you need to consider ablating in the LA and if needed RA rather than the other way around. So these are examples of here the ablation catheter is on the left superior ganglionic plexus, which is kind of on the roof outside the left superior pulmonary vein. As you can see that there is significant vagal response as the ablation proceeds. You can see sinus rhythms slowing here, and that's a classic effect seen in the left superior ganglionic plexus. And this is ablation of the right superior GP, which is again on the antrum, on anterior part of the antrum of the right superior and right inferior GP. So right inferior pulmonary vein, sorry. So here you can start to see increase in sinus rate as you go do the ablation. That's a common effect that you see. And here the same thing, this is the ablating the aorto SVC GP, which is the other extension of the right superior GP. You're ablating sort of the septal posterior part of the SVC, and here also ablation will result in increase in heart rate. So this ablation is only needed if you do not get the desired effects in terms of the right superior GP. And lastly, this is a patient who has functional AV block, and see the location of the ablation catheter for ablating so you can see that patient has AV block at the beginning, and as the ablation proceeds, there is one-to-one conduction resumes. And so this is very important in the AV block patients, and has a significant role in AV nodal conduction. So what about the literature? So we have one randomized trial of 48 patients that compared CNA with conservative therapy. The rest of them are all observational data. And overall, as you can see, that there is a significant improvement in syncope burden. And so let's look at the RCT. 48 patients randomized to CNA versus conservative therapy. All had cardioinhibitory VVS, and over a follow-up of 2 years, about significant improvement in syncopal episodes compared to conservative therapy. Also significant improvement in quality of life compared to conservative therapy. And one of the main potential side effects is inappropriate sinus tachycardia, because we are parasympathetic denervating, and so one has to be careful with how much ablation you want to do to achieve the ideal heart rate without going too much in that case. This is again the outcomes here and quality of life data. So what about more longer term outcomes? So this is a study that we did. It's a 65 patient study with vagally mediated bradycardia, vasovagal syncope, functional AV block, and sinus node dysfunction. And out of these, 58 of them underwent biatrial CNA. 7 had only right atrial, followed more for about almost 2 years. And acute success was achieved in 98%, and almost all patients in the biatrial group. And over a long-term follow-up, as you can see, the event-free rate was roughly about 90%, and about 4% of patients, around 2 people, I believe, 2 or 3 patients had inappropriate sinus tachycardia that needed medical therapy. And we also noted significant improvement in QT interval in this particular patient, suggestive of sympathetic denervation. And so this study shows that CNA appears to be an effective and safe strategy with excellent medium-term results and in patients with BVS and vagally mediated bradyarrhythmias, and also shows a significant reduction in QTc. This is another study from a Polish group looking at medium-term outcomes. Again, prospective single-arm study, no control group. And they found about, again, 95 of 115 patients had long-term outcomes, about 80 to 83%. And 27% had symptomatic sinus tachycardia. In this case, about 7% needed long-term medications. In this study, their baseline, the heart rate increased from about 60 at baseline to 90 beats per minute, which is somewhat higher than the other studies have shown. What about AV block? This is the first paper on AV block treatment, and we looked at about 28 patients and significant improvement in AV block, and complete reversal was achieved in about 96% of patients, and there was recurrence only observed in about 2%, 6.7% of cases, and about 3 patients required pacemaker implantation. So again, very successful in this particular group as well, and the posteromedial GP is very important. This is a patient that I showed in case 2, and that actually had ablation, and you can see 1-to-1 conduction with a slightly prolonged PR interval is here. And so we also did a case control study to use a control group who underwent medical and pharmacological therapy, and similar outcomes were noted with CNA far superior. We also did a propensity matching analysis in this group, and that also showed that the effect of CNA was superior compared to conservative and medical therapy, and this is over a 4-year follow-up. And we also did another study comparing permanent pacing versus cardioneuroablation for cardioinhibitory vasovagal syncope, comparing a group of patients who underwent either leadless or CLS or rate drop response pacemakers compared to CNA. It showed that CNA was as effective as permanent pacing, and over long-term follow-up with no significant difference in success rate or significant safety signals in either of them. So you can see this is a patient group, some baseline differences, and overall, if you look at the outcomes here, very similar over the course of longer term, at least a 1-year follow-up here. So where does CNA stand in this case? I think we talk about recurrent and refractory vasovagal syncope after conservative and pharmacological therapies. So it's either you can diagnose using ILR, you can also diagnose using head-up tilt table test, and with long pauses or asystole. When it's a younger patient and who clearly has cardioinhibitory vasovagal syncope, it's challenging to place a pacemaker because they have to have it lifelong, lead-related issues, infection, all those kind of things. And that particular patient should ideally be considered for CNA. And even in the slightly older patient who has recurrent syncope or that doesn't get better, you can still consider CNA if the patient does not want a pacemaker. And I mean, if you're using pacemaker, likely CLS has better data, but I think a younger patient with refractory cardioinhibitory vasovagal syncope would likely benefit from CNA in these cases. So selected patients with refractory cardioinhibitory VVS and selected patients with confirmed functional AV block would be the best candidates in these cases. Also some patients with very slow sinus rates with symptoms can also benefit. So in conclusion, ladies and gentlemen, cardioneuroablation is an effective and safe strategy with favorable longer-term results in well-selected patients with vagally mediated bradyarrhythmias such as cardioinhibitory VVS and AV block. For cardioinhibitory VVS, observational data and one randomized controlled trial shows CNA to be superior to conservative therapy and have equivalent outcomes to those who received permanent pacemakers. CNA can also significantly shorten QTC and increase resting heart rate. The most likely mechanism of action is parasympathetic denervation, but the impact on QTC suggests potential effect on sympathetic system as well. There are several knowledge gaps that exist regarding patient selection, ganglia identification methods, procedural endpoints, as well as long-term outcomes. And what we really need is a pivotal sort of a sham control randomized trial with long-term follow-up to clearly eliminate the placebo effect and show that CNA is an effective and safe therapy that can, be a game changer in patients with these debilitating conditions. And thank you for your attention. Happy to answer any questions.
Thank you, Dr. Ragesh, for that wonderful presentation as an upcoming modality of therapy. One question is that these patients, do they have reduced exercise capacity or feel fatigued when they, especially these young patients, because you suggest it is more suitable for patients who are younger. So is that a concern or?
As far as I know, we haven't really seen reduced exercise capacity. One of the challenges is to be careful about how much heart rate increase they get, and that sometimes they can get a little inappropriate sinus tachycardia with which they will be symptomatic. And I had a few people who needed like a beta blocker or like ivabradine sometimes for a little while to treat that. And some degree of re-innervation happens over long-term follow-up. So it tends to ameliorate as time goes. But again, that's usually the most common issue. And there is a small proportion who can have recurrence and, and mostly they are much better, like compared to their syncope frequency is much better, and very rarely may have they may need a second ablation in that regard. But I think for the most part, we haven't seen a whole lot of issues other than that.
One question, if I may ask, like you mentioned a case about AV node conduction improving. So where did you ablate was it in the coronary sinus or like where did you ablate?
I typically ablate in the left atrium, like using intracardiac echo, as Dr. Asmini has a wonderful talk that. So you can go transeptal, kind of curve the ablation catheter and kind of stuck it in a home view, like in a view where you see the pulmonary veins, and you basically place the ablation catheter at the inferior limbus of the intraatrial septum on the left atrial side, and that's the kind of the typical location you ablate. You can also go under the CS and ablate more posteriorly on and the right atrial side. But the left atrial ablation usually does the trick and doesn't cause any issues with the AV conduction or anything like that.
And these signals in these ganglia sites, in these highly symptomatic patients, are they significantly different from normal people? The kind of
No,
signals?
we do see them in normal people too. Actually, it's very we all have it. Just it's there, and the modality of mapping determines the density of it. I think we are currently doing a study to kind of compare like a regular like a multipolar catheter like a DECA versus like how it looks with like something like HD grid, and we're still trying to figure out how to parse them out because the HD grid being very dense, and we see a larger area of fractional electrograms compared to it. Usually these are very small areas, and 2 or 3 ablation lesions should be more than enough to get rid of them. And we mapped a bunch of people who came for paroxysmal atrial fibrillation with no scar, and just looking at the GP distribution and trying to understand and looking at different mapping modalities, as well as to see if there is any age or gender related differences. This is like an ongoing project that we are doing.
Dr. Rakesh, wonderful talk. In fact, what we understood by this thing, the initial approach is to look at the ganglionoplexy one that is on close to that RSPV, then that coronary sinus ostium on the from left side as well as from the right side. And beyond that, in those cases where you have vagal response is not completely taken off, which all you go for the right medial side of the SVC, and which all cases you go for that warfare ridge, because that is primarily in cases of AV block, as we understand, rather than vasovagal syncope or a sinus node dysfunction.
Correct. So, great question. I typically start on the left superior GP, which is kind of on the LA roof between the left superior pulmonary vein and the appendage ostium, and that's where you usually find it, or like a high posterior wall on the left side, and you should see vagal response there. Typically, we also ablate the Marshall tract, which is kind of the anterior ridge between the left superior and left inferior pulmonary veins. You should typically see vagal response here as well. And then then I move on to the right superior GP, which is antral area between the right RSPV and RIPV. And sometimes it can kind of go a little higher into the anterior portion of the RSPV. And here is where you start to see heart rate increase. But if you ablate everything there and there is no heart rate increase, then you go right atrium, go to the sort of the septal posterior aspect of the right atrium higher up, and it should be directly opposite the where we ablated in the RSPV. And either you can look confirm it using 3D mapping or using ICE to, and then you deliver energy there to get more heart rate increase. The posteromedial GP, I do not use it for vasovagal syncope patients, but for AV block patients, typically, and the AV block patients are a small proportion of what we see, like they're rare, and these are mostly functional AV block, and associated with symptoms, and those are where that posteromedial GP becomes more important, and they usually need it for those kind of patients. Usually you don't need that for the VVS patients.
Ajit, you have any questions?
Thank you, Dr. Rakesh. A couple of questions. One, what filter settings do you use when you map for these GPs?
So great question. So I think once sorry. So in terms of we set between 200 to I believe 400 for the setting, and then we usually I can send it to you. There is a setting that we use in the mapping system, the parameters that we use for the fractionation thresholds for mapping the GPs actually, and I don't remember all of the settings right on the top of my head, but I'm happy to share with the group afterwards. So the specific filter settings and the specific fractionation settings in EnSite system that we use for the GP mapping perspective. And that allows us to get the deflections very clearly.
The second question is, if you went to the area where you expected the GPs, the GP type of signals, do you always get them? And if you don't get them, would you still give a particular duration of lesion in that area?
So no, answer is probably no, but I think you carefully map, you may find some fractionation may not be sometimes it may not be as classic as we like it to be. Sometimes you have to if the usual location doesn't have the signal, you map a little bit above and below and see it can vary a little bit, and but most of the time, I would say 95% of the time, you'll find some fractional electrograms. This is really true for left superior GP and the right sided GP, you almost always find it. And the one location where it may be a little tricky is the Marshall tract and like the sort of the ligament of Marshall region. So if you don't see anything, we don't ablate because there is, we don't know if it's a ganglion site or not. Or you can give a test lesion to see if there is significant vagal response on the left side. And if that's the case, then we can continue to do that.
Thank you.
Thank you, Dr. Rakesh. And because of we are running short of time, we will close the session. Thank you, everyone. And thank you, Nambudiri and Vijay, for the opportunity to chair the session. Thank you.
Thank you.
In the next session, we have the selected abstracts for the Young Investigator Award. To chair the session, I invite Dr. Ajit Kumar sir, Dr. Natarajan KU sir, and Dr. Mukund Prabhu.
So the next session will be Young Investigator and selected abstracts. So you have exactly 6 minutes and 2 minutes of questioning time. So the first talk and discussion is by outcomes of LOT CRT versus biventricular CRT by echocardiography and strain imaging at 6-month follow-up study by Dr. Pooja Prasad. Pooja, yes.
Good evening. I'm here to present my study, which is outcomes of a left bundle optimized CRT in comparison to biventricular CRT by echocardiography and strain imaging, which is 6-month follow-up.
Yes. Just somebody needs to keep time at 6 minutes. Okay.
So coming to the introduction, that is, as we all know, heart failure is a huge burden on our society and estimated to affect about 26 million individuals. And we know that cardiac dyssynchrony, that is both electrical and mechanical dyssynchrony, are implicated in heart failure. And particularly when we come to left bundle branch block, this leads to electrical dyssynchrony, delayed activation of the posterolateral wall of the left ventricle, which in turn leads to ineffective ventricular contraction and reduced ejection fraction, particularly in patients who have left bundle with a wide QRS. And the concept of cardiac resynchronization therapy was initially aimed at addressing electrical dyssynchrony by near simultaneous activation of both ventricular walls using a lead in the CS to activate the left ventricle and a right ventricular pacing lead. So the concept is that CRT leads to further improvement not only by improving electrical dyssynchrony, but over long term, there is the benefit on ventricular remodeling, which is seen 3 to 12 months following the procedure, which also helps in improving the overall outcomes of patients who undergo these procedures. So conduction system pacing is another form of pacing where we have left bundle branch pacing and left bundle optimized CRT, that is the use of a pacing lead to the left bundle, as well as a CS lead, that is the left bundle optimized CRT, can be used instead of biventricular CRT, and this was what we aim to study. So what we already know is that biventricular CRT paces from the right ventricle, and this can have a desynchronizing impact on myocardial pacing because it is pacing from the RV as well as from the LV. When we use a left bundle CRT, we can have physiological pacing of the LV as well, along with the CS lead, which gives a non-physiological LV epicardial pacing. And we also know that the LOT CRT, when the RV is paced, there is a certain latency, and we can have suboptimal lead positions, that is in paraseptal or apical positions, due to unfavorable anatomy of veins, which can make biventricular CRT potentially difficult and may reduce the efficacy in these subsets. So the rationale for the study was that left bundle area pacing has better outcome when combined with the CS lead on clinical parameters and improves ventricular dysynchrony, leading to clinical improvement, as well as has a beneficial effect at the end of 6 months. So the methods that we used, all consecutive patients who came fitting our criteria, that is, we specifically included non-ischemic dilated cardiomyopathy with left bundle branch block and the absence of ischemic heart disease, and those who were eligible for CRT were included. Total of 40 patients were included who were non-randomized, that is, based on the operator preference, they were divided into either the conventional biventricular CRT arm or the LOT CRT arm. So we collected the parameters, including strain imaging, which was done at baseline, that is prior to the procedure, and at the end of 6 months when the procedure was completed. So the aims of our study was to compare the efficacy of left bundle optimized CRT with conventional biventricular CRT for improvement of LV function as the primary outcome, to assess the change in mechanical dysynchrony as assessed by echocardiography, and to evaluate the clinical outcomes with strain imaging. So the baseline demographics, as we can see, we had both patients. We had primary age group was about 51 to 60 and 61 to 70. Most patients came within the age group of 51 to 70. Most patients had dyspnea and exertion as their symptom. We had recurrent heart failure in about 15% and 10% of patients respectively. And function class at baseline, most patients after optimizing with GDMT were in function class 2 at the time of enrollment. We had only 2 patients in the left bundle arm who came with overt heart failure who was stabilized and then taken up for the CRT procedure in hospital. So the medication use pre-procedure, that is the GDMT use pre-procedure, we had a majority of patients, that is nearly 95% of patients were on beta blockers, SGLT2 inhibitors in about 75 to 80% of patients, and ACE inhibitors and ARNI were used in 70 to 75% of patients who came for the procedure pre-procedure. Baseline demographics were comparable across both groups. As we can see that the age was nearly comparable. 2 patients in LOT CRT arm had atrial fibrillation associated, whereas only 1 patient in the biventricular CRT arm. The intrinsic QRS duration was 165 mean across both groups, and ejection fraction was also comparable, being 30% in the LOT CRT group and 29% in the biventricular CRT group. Coming to the echocardiographic characteristics, that is the end-diastolic dimensions and the ejection fraction as well as the volumes, these were also seen to be comparable across both groups pre-procedure. And coming to the parameters of dysynchrony as well as the strain parameters, these were also similar across both groups pre-procedure, with the mean septal to posterior wall delay being about 199 in LOT CRT and about 189 in the CRT. Coming to post-procedure parameters, these parameters are assessed at the end of 6 months. So we can see that the intrinsic QRS duration after adequate optimization on follow-ups, at the end of 6 months when we evaluated, we found that the QRS duration was significantly narrower in patients who underwent a LOT CRT as compared to patients who underwent a biventricular CRT. Ejection fraction also improved across both groups, and this improvement was seen more in patients who had LOT CRT, although this was not found to be statistically significant with a p-value of 0.1. And significant improvement in function class, with most patients coming to NYHA function class 1. Coming to the strain, I'll just take 1 minute. Coming to the strain parameters, so as we can see that comparison of strain parameters across both the groups, GLS improvement was not statistically significant, but it was seen more improvement in the patients who underwent LOT CRT, with the peak endocardial strain time to peak endocardial strain having more improvement in patients who underwent LOT CRT as compared to patients who underwent biventricular CRT. So to conclude, LOT CRT resulted in a narrower QRS duration and had comparable effects as compared to biventricular CRT on the overall outcomes, including strain patterns. But we saw better improvement in LV ejection fraction and global longitudinal strain over a period of 6 months, which has the potential advantage showing better outcomes on cardiac remodeling, likely due to the more physiological pacing offered by the left bundle pacing.
You made some sweeping statements saying that there are a lot of problems with the conventional BIV pacing in one of your introductory slides. You said that it's pretty bad, not a good option at all, kind of thing. Then why did you do lot? You could have done conventional BIV CRT versus only a lead in the left bundle. If you're so very upset about posterolateral vein CRT at all, lot of negative things you wrote in one of the slides, justifying. I'm not criticizing you. I'm just thought I will ask the question. What is your why not only left bundle area pacing as against BIV pacing? Why did you want an extra RV lead when you said it's very, very bad?
There is a certain concern that the left bundle lead can have increasing thresholds and may on follow-up. So
it's
we
not
would
that
like to
bad.
have a CS lead. Also, the other thing is
it's a friend to have. Why more females in the lot group? I thought there is a substantial gender discrepancy in the lot arm versus the BIV arm.
That may be
9, some very
almost,
significant
yes,
difference.
70% were females.
And one of the echo parameters, though it was statistically significant, 0.04, the number was something like minus 12.79 versus minus 12.76 or something.
Yes.
That made such a huge statistical difference.
The apical 3-chamber strain, that was the one that was giving us a statistically
But
significant.
numerically, the difference was 0.03 or something. But the p-value was 0.04. Something.
Apical 3-chamber strain, that was the only one that gave us a statistically significant value across the strain parameter.
What was your second result? That second line of the result?
Second line.
Narrow
first line
QRS,
was
I
narrow
agree.
QRS.
You said it's.
That we
because
had an
of-
improvement. We had, although it was not statistically significant, there was improvement in strain parameters. So we suggested that it could have a better outcome on LV remodeling at the end of 6 months, which can translate to better efficacy with lots.
Could potentially translate into. Yeah.
See, you said there's a significant difference in the QRS duration
Yes.
with CRT, but between 117 and 134 milliseconds, is there, apart from the statistical significance, is there any significant difference? One you have already achieved by CRT itself.
From the baseline, that is about 165 means. So from there, both have significantly improved. But the improvement was more in patients who underwent left bundle optimized CRT.
Yeah, no, but my scientific question is that does it make a difference whether you reduce it from 134 to 120 and 117? It is all you have already achieved.
Already less than the cutoff. So this is just a statistical number that it was more significant, sir.
And
but both were significantly.
And for ventricular remodeling, have you looked at LV volume changes
Volume-
and dimensional changes?
Yes, sir. Volume changes, that is based on the cutoff for responders. So among our entire 40 group of patients, we had only 2 patients who were non-responders. Remaining all were responders, sir, across both the groups.
So what was the criteria you applied for significant LV?
That 5% reduction in left ventricular ejection fraction improvement and the left ventricular end-diastolic volumes coming down by about.
See, how did you choose the sample size?
Sample size was based on the number of cases that we are doing in our centers. It
One
was a single
limitation in
center
the study, isn't
yes,
it?
small samples.
So you did not show a difference in EF statistically.
Statistically, no difference in EFs.
So do you think in this subset of patients there'll be change in hard outcomes, even if you choose the right sample size and long-term follow-up?
Over long-term follow-up, this left ventricular remodeling may be beneficial. Even though all of them are responders, the left ventricular remodeling might have a better improvement over longer times. So since we've done this study only for 6 months, maybe over longer time we might get a better result.
Maybe, so that falters your hypothesis.
Yes.
So the third question is, why did you choose this group? If at all, if there's going to be a difference, would it not be ischemic cardiomyopathy group?
Ischemic cardiomyopathy, the problems come with again having a scar. Sir. So the selection of patients for left bundle pacing may be difficult with a scar in the septum or other areas which may not allow us to put a left bundle lead.
And what are the other studies shown between LOT versus
There are
CRT?
other studies, that is that left bundle area pacing collaborative study groups. They did not compare strain parameters, but they have shown a better QRS narrowing with the
Better than
CRT
CRT.
compared to biventricular.
Okay. All right. Thank you.
Thank you.
So we invite Dr. Mohammad Rameez for his second presentation on predict value of strain, echo, ECG and other variables to predict ventricular arrhythmias in the context of post-MI severe LV dysfunction.
Good evening, CS. Good evening, all. The title of my study is Predictive Value of Strain Echocardiogram, ECG, and Treatment Variables to Predict Ventricular Tachyarrhythmias in Post-MI Patients with Severe LV Dysfunction. Coming to the background of the study, as we know, the coronary artery disease still continues to be the disease with maximum case fatality rate. The sudden cardiac death is one of the major mechanism of death in more than 60% of cases of coronary artery disease, as we know. And ischemic heart disease, if we are following up for patients for more than 2 years, we can see around 10% of the patient is developing sudden cardiac death. But we know that there had introduction of newer treatment for heart failures like SGLT2 inhibitors and ARNIs. If you are using, this has significant improvement in patients with the low ejection fraction. But our ICD for primary prophylaxis criteria still continues to be only the low ejection fraction, that is less than 35%. In some studies it is less than 30%. So this is an attempt to find out some predictors of ventricular tachyarrhythmias in patients with post-MI with severe LV dysfunction. The materials and methods, this is a prospective observational study for a period of 1 year in Medical College Kozhikode. The study sample was 45. And the inclusion criteria were STEMI and STEMI patients more than 18 years with ejection fraction less than 35% and after 40 days of MI or 90 days of post-revasc. The exclusion criteria, those who did not give consent, not on follow-up, and poor echo window for a proper strain imaging, those who already developed VTVF were excluded from the study, and those with AF and post-EABG patients were excluded from the study. Moderate to severe valvular heart diseases, structural heart diseases which can affect the strain imaging also were excluded from the study. And those already put on ICD were also excluded from the study. And patients with chemo and infiltrative cardiomyopathy already diagnosed were excluded because that also can vary some strain imagings. All those who are in inclusion criteria will undergo 2D strain imaging and ECG will be taken. The data of ECG and treatment variables will be collected. Those with ejection fraction more than 35 and more than mild valvular heart diseases will be excluded from the study. All the strain imaging was done in the same machine, that is Philips Epic 7 machine, and intra-observer variation was considered. And the follow-up of developing ventricular tachyarrhythmia was telephonic follow-up. Those with a history of palpitation and syncope or pre-syncope were underwent Holter monitoring. Out of 45 patients in the study, subjects 5 developed ventricular arrhythmia over a period of 1 year follow-up. 2 documented ventricular tachycardia and hospital admissions. 1 was sudden cardiac death. 2 were Holter proven non-sustained ventricular tachycardia. This is the baseline variables. The average age was 64 plus or minus 8 standard deviation. Male to female ratio was 70 to 28. 64% were STEMI and 35% of the patients were in STEMI group. The management side, 31% were medically managed, 26% of patients were lysed at some point of time. And POVA PTCA group, it was 42%. The ECG variables we studied were QRS duration. In ventricular arrhythmia group, the average QRS duration was 121 millisecond, and no ventricular arrhythmia group, it was 115 millisecond. And fractured QRS in ventricular arrhythmia group, it was out of 5, 4 had fractured QRS. No ventricular arrhythmia group, out of 40, there had 24 patients with fractured QRS. About corrected QT, average corrected QT in ventricular arrhythmia group was 455 and in non-ventricular arrhythmia group it was 444. The QT dispersion had significant differences in ventricular arrhythmia and non-ventricular arrhythmia group. It was 96 and 70 respectively. Coming to the treatment variables, those on AC inhibitor and ARNI, around 50% were in AC inhibitor and 26% in ARNI group. Those with SGLT2 inhibitors, 80%, more than 80% SGLT2 inhibitors, more than 95% were in beta blockers, and half dose mineralocorticoid receptor agonist 73% and full dose in 20%. Those on all 4 pillars of heart failure in ventricular arrhythmia group, it was 2, and the non-ventricular arrhythmia, it was 27. This was a strain echo variables. Average GLS in ventricular arrhythmia group, it was 6.9, and no ventricular arrhythmia group, it was minus 7.99. There had a significant differences in mechanical dispersion calculated by 2D echo imaging. That was strain imaging. It was 150 plus or minus 46 in ventricular arrhythmia group and 75 in no ventricular arrhythmia group. This is the average strain value, segmental analysis average strain value in patients with ventricular arrhythmia and without ventricular arrhythmia. Here we can see the average strain value in basal infralateral segment, basal inferior septum, and mid inferior septum and apical inferior septum. There is a significant difference in patients with ventricular arrhythmia group and no ventricular arrhythmia group. But in statistical analysis, this was not found to be a statistical association parameter. But we need a larger study. This was a univariate analysis. For chi-square test and independent titers were used for univariate analysis. Diabetes mellitus, ejection fraction, QT dispersion, and mechanical dispersion were found to be statistically significant associated with the development of ventricular arrhythmia. And for predicting as a predictor, we moved on to multivariate analysis with binary logistic regression. After binary logistic regression by multivariate analysis, we found that QT dispersion and mechanical dispersion was having statistically significant association for developing ventricular tachyarrhythmia in post-MI patients with severe LV dysfunction. So the conclusion of my study is QT dispersion by 12-lead ECG and mechanical dispersion calculated by 2D longitudinal strain imaging can predict ventricular arrhythmias in post-MI patients with ejection fraction less than 35%. Of course, the limitations of the study is very small sample size. All patients did not undergo Holter monitoring to detect an arrhythmia. It was a single point observation study. The follow-up was with telephonic follow-up. There will have a lot of recall biases. The suggestion is in patients with EF less than 35%, those with high QT dispersion and mechanical dispersion may actively be counseled for putting a ICD for a primary prophylaxis. Thank you.
What was your hypothesis? I mean, why did you assume that strain will have an effect on arrhythmia load?
Because already there had data, sir, regarding the mechanical dispersion and development of ventricular arrhythmia. The only data which was lacking was the introduction of treatment like SGLT2 inhibitors and ARNI. After that, the data was a little bit lacking.
No, but the factor which is likely to cause a correlation, if at all, would be whether the ejection fraction or the reduced ejection fraction is related to strain, isn't it? I mean, how would the treatment is a totally different aspect together?
So, along with EF, I wanted to find out some other data. The newer method is a strain analysis.
Yeah, but aren't you just looking at finding out what is the actual LV function rather than looking at other parameters by looking at strain?
Yes, sir. Along with the strain parameter, we will get a biplane method EF, machine calculated biplane EF also is included in the study.
Okay. And you see, you haven't done Holter both for inclusion as well as for later evaluation. Isn't that a big flaw?
Actually, sir, for inclusion, all patients with EF less than 35% EF were included. But at that time, Holter was not done, sir. Actually, that is a big limitation of the study, sir.
You said a proportion of your cases had non-ST elevation myocardial infarction, meaning they never had a old ST elevation MI.
Yeah, that's right.
So how do you explain the ejection fraction of 35% in them? That means there must be a significant component of ischemic LV dysfunction.
Yeah, sir.
What is the coronary anatomy in this group? Were they all subjected to coronary angiography? Any info on the coronary anatomy status?
That data also is collected, sir. There are the full data was not included in the study. This is actually an interim analysis of my study, but that also will be included in the final result of the study.
And I was surprised to find that when you gave the criteria on the VA group and the no VA group, in terms of drugs, a substantial number of patients in the VA group were not on RAS inhibition, whether ARNI or ARB or ARNI, ACE inhibitors, nothing. Significant, even the four pillars, it was 60 versus 40.
Yes.
What if I say that it is because of the less drugs that they had ventricular arrhythmia?
Sir, actually, many patients under follow-up were having some kind of complications, like those who were on CKD, they had some low ejection fraction. That was the reason for low adherence to the therapy in many patients. That is also included in the study. That could not be.
Where was ICD offered to these patients, and those who did not opt for ICD were included?
All those patients were given the chance of putting an ICD, and they were actively counseled, but they were not willing to put an ICD without any medicine.
So they were counseled, but they were not willing.
Never, not willing, sir.
So it was kind of a biased population of those who did not want an ICD. Kind of. See, one last comment. You said it is a primary prevention study, isn't it?
Yeah,
this is a primary prevention analysis. In your first slide, you said it's a primary prevention. But in the exclusion, you said no history of old VT and VF was excluded. Then
no,
it is.
Old VT, sir. The patient admitted already with VT and VF were excluded from the study.
That's right. So when it is a primary prophylaxis, the understanding is that they never had VT, VF in the past. So it need not be an exclusion criteria, just a technical point.
Yeah, glad that you accepted the limitations. The issue is one, it's a retrospective study, and then the baseline characters do not match. So that's good enough. The limitations were highlighted, and that's a good thing about it.
See, the only thing that I didn't like in the end, you said they should be recommended with reduced strain, should be recommended primary prophylaxis with ICD. That's a little drastic statement, isn't it?
Not strain, sir. Actually, it's a mechanical dispersion. Those with having
Yeah, even then, even that.
sir, that is showing a significant statistical differences, sir. Even in non-ischemic cardiomyopathy, it was proven to be having.
All right, thank you.
Thanks, sir.
Qualifying patients who are already candidates for primary prevention.
Sorry, sir.
You're actually subselecting patients who are already qualified for primary prevention, isn't it?
Yes, sir.
We'll call up Dr. Sedupati. Clinical correlates of device-detected atrial high rate episodes.
Good evening, everyone. First of all, my sincere thanks to KHRS team for giving this wonderful opportunity to present here. My topic is about clinical correlates of device-detected atrial high rate episodes. This is the definition we have taken as a cutoff to say whether the patient is having atrial high rate episodes or not. Based the rate is more than 175 and it is lasting for more than 5 minutes, and telemetry will be reviewed by the physician in the pacemaker clinic and will be included in the study unless the patient is not having any previous or current AF documented either with ECG or Holter. So the thing is, previously the term AHRE has become popularized because of 2 large-scale trials, certain trends. They showed there is a risk with AHRE also, but the risk is less compared to the AF. That's where the discussion is going about whether to start on NOVAX or there is a risk-benefit ratio, whether it is that much risk to create a stroke. For example, if we compare, this is on the right side is the risk of stroke events percentage per year. If a Chadwick score of 1, AF, the risk will be 1.2, whereas in AHRE it is 0.56. Similarly, for a corresponding score, similarly at the end, score more than 4, it was a 2.75, which is only half compared to the AF, which is around 4. So the thing why it is considered as not equivalent to AF because it is relatively short and regular and told to be it is in the right side of the heart, and there is no temporal association has been demonstrated till now. Just prior to the episode of stroke, demonstration of AHRE is not demonstrated. And also, even after a Novak FNET and RTCR trial, the usage of Novax in the AHRE patients is only 25% based on the recent pacemaker survey. So this is the thing, as we all know, Novak FNET is predeterminated, but also told that there is a benefit but high risk of bleeding compared with aspirin in AHRE group. So this is the incidence. Based on this, I have calculated the sample size which came around 79 patients. So hypothesis will be whether AHRE will progress to clinical AF, whether it is a precursor to the AF, and also whether it is truly associated with the increased risk of stroke and major adverse cardiac events. So it's again the same. Inclusion criteria will be who are the patients visiting our pacemaker and device clinic who had or having atrial high rate episode without documented ECG or Holter documented AF in the past or currently. Before including, we will do a Holter also. Exclusion criteria, if just within 2 months from device implantation, and if life expectancy is less than 1 year, and if there is a AF, previously the patient might add AHRE, but before Jan 2023, if he developed AF, that also we excluded. So we had 184 patients. Out of this, 103 patients were coming under our criteria. 9 developed AF before Jan 2023, so A excluded. And also 14 had prior documented AF even before AHRE. And then the primary idea of the trial is to conduct only on patients aged more than 50. So, but I have also collected simultaneously the patients who aged less than 50, since we have many congenital heart disease patients also in our institute, just to know whether it is having any significance in them. So predominant age group will be this 50 to 75. And then age more than 50, the predominance is among the males. Side by side, I will show the data of age less than 50 also. Here is predominantly female. And also the device is mostly pacemaker related, dual chamber, and AAA pacemaker is also predominating. Whereas in age less than 50, it is predominantly dual chamber pacemaker. Indication is in age more than 50 years, it is predominantly six-sinus syndrome. Whereas in age less than 50 is predominantly AV block, because most of the CCTG and the post-op cases had CHV, that's the indication for a pacemaker in patients and those younger age groups. And also I have just graded whether to know whether it is progressing from one part to other part and then landing up in AF. While inclusion, what is the maximum thing I have put in that grade. So majority is within the 6 hours. So whatever this thing is almost out of 77, 69 patients had at least one episode within the 6 months before Jan 2023. So Chadwick score is predominantly rotating around 3 and 4. Sorry to mention it's 0 at the end. So this is the thing, out of 77 patients, almost 20 patients developed AHRE more than 24 hours, which will be considered equivalent to clinical AF or AF, and 2 patients developed a flutter, which is coming around 25% events per year. So the mean time from the time of device implantation to development of AHRE coming around 67 with a standard deviation of 80. Wide range is there because some patients getting implanted the device early, but they are developing AHRE very late. The mean time to develop AF is 23 months. It's again the same. So this is a stroke. If we include TIA also, actually I got a 2 stroke and 3 TIA episodes. Out of the 2 patients had a prior episode of stroke, but they have evaluated and found to not have any AF with a Holter and ECG. So this is the MACE incidence coming around 11.68. Comorbidity is predominantly the hypertension. So these are the other procedure patient who underwent. So coming to the Novak patient, almost 56.25% of our patients, Chadwick score more than 2 are already on Novak. Not only the indication being the AHRE, also some patients are post-valve surgery patients are there. So this is patients who are younger than 50 also on Novax, post Fontaine and HCM. So this is a thing I want to show. Actually 5 patients we had a stroke. Out of that 2 patients already had a prior stroke, but they are, out of them one is on SAPT, other one is on oral anticoagulation, but he continued 1 month because of some surgery. During that time he had a stroke. 3 patients had TIA. Chadwick score predominantly around 4 and 5. Only 1 patient with a Chadwick score of 2. So I have compared with the Novak and without Novak, both with score more than 4 and less than 4. Only here the score more than 4.
Your time is up. You can come to the conclusion.
Yes. So this is the thing. The mean time to develop is 23, and the stroke risk is 2.77. The statistical significance coming in when the Chadwick score is more than 4 and not on Novak. Almost 4 patients had a stroke but TIA in our patients. So what we conclude is like, since the mean time to develop a progress to AF is coming around 23, at least once in a year we can do a Holter and rule out there is AF or not. Also, even if patient having prior stroke risk, having Chadwick score of more than 4, rather than continuing on SAPT, we can change over to Novax in case if bleeding risk is less. But however, it's very small sample and single center. Nice. This verbal, no. Conclusion is like Holter we can do once in a year, and Novak can be considered if patient Chadwick score is 4. If prior risk of stroke, we can consider changing over to SAPT to oral anticoagulation, because 2 patients had a stroke and also 2 patients because of CABG they are on antiplatelet despite being that they had a stroke.
Yeah, the presentation was too fast for us to comprehend most of what you said. Can you show the so-called conclusion slide? Stop here. The maze, whatever you showed. No?
The second one is like more than 50 and less than 50, sir.
How many of your patients had AHRE?
Sir, 105, sir.
What is the total population? The total study population is 103. Out of 184 patients, 103 qualified for your analysis.
Yes.
Of the 103, how many had AHRE? How much did not have AHRE?
All had AHRE, sir. All 181 had AHRE.
These are all AHRE patients.
Yeah.
Okay, fine.
Sorry,
So
because
you
of lack of time.
and did you have compared AHRE patients with those who did not have AHRE
No,
in
sir,
your
not-
study?
No, sir, not compared.
There's just AHRE patients followed
Because
up to see
already
how
the
many of them
stroke
developed
risk.
clinically. So what's the new? Can I?
Please go.
What's the new? See, already patients with AHRA and CHADS score 5 are already recommended for Novak. Except
So,
for
sir,
the
still
recent
there is a
study.
hesitation. Only 25%
But
of the
old
patients.
ESC recommendation says if the AHRAs are there, by definition, those two are certain thing, and if the CHADS score is high, it's still okay to go anticoagulate. It's a
Yes, sir. It is only
consensus
based.
statement.
Yes, sir. It is
It's a
there.
it's not a guideline. I agree. It's a consensus statement. Now, what have you added to that information?
Like how, when they are progressing to AF, like how much time it is taking, so that we can frequently monitor. Like in our case, the mean
Because
time.
in your scenario, in 24 months, most of them progress to clinical event. Is that
Yes,
right?
sir.
In 24 months is the time that
Mean
they all
time,
progress. What percentage of these AHRA 104 patients progress to have a clinical event?
Yes, sir. 20 patients are I showed. Yes.
So only 20
Out
patients.
of 77, 20
Only
progressed.
20 patients had a clinical event in 24 months. Is that right?
Yes, sir. From their first documented AHRE.
So you're only suggesting to do a Holter every year.
So that can be.
That's your conclusion.
Yeah, we might miss if we are not doing.
So
And also, there is a stroke risk despite, as we have shown, only 49 patients not on Novak. Out of that, 4 patients had a stroke event.
I get that. Eventually, what are you recommending based on the study that you have done?
There is no need of any hesitancy to starting a Novak. Also, it's considered as a preliminary event to AF. So it is better to monitor frequently, and then and there, in case if the risk is high, we can consider Novak. Even for example, if some patients having AHRE of 8 minutes, one of our stroke patient had AHRE of 8 minutes with a Chadwick score of 2. Definitely, we won't be thinking of starting an oral anticoagulation. But within a 6 months, they are landing in stroke. So that might be one of my points. No, sir, not telling like that, but we should not miss that even on.
So your basic patient load was patients on pacemakers, and they were of a heterogeneous lot, including patients with LV dysfunction.
Yes, sir.
The CHADS score was high, isn't it, in this group?
Yes, sir, few patients.
So you're not actually assessing the role of AHRE by itself. It's.
Yes, sir. It need to be a comparative study rather than it's the same risk factor, same.
And what about your final? What you said in the end is that patients with high CHADS score request NOACs. Oh, that is accepted. We are only concerned about if you have AHRE
Yes,
and
sir.
what percentage develops AF and what percentage develops events. So
Yes, sir,
what is that? What
11
percentage of patients develop AF?
23, sir. In our
Percentage wise.
yes, sir. Percentage events per year.
20% develops AF.
Yes, sir. In our case, out of 77, 20 patients develop, sir. So percentage events per year coming around 20.
Okay. So if patients have a low CHADS score and if you have AHRE documented, would you recommend NOACs?
No, sir. Low Chadwick score, you are not going.
Okay. All right.
Yes, sir. That should be.
Anyway, your study has kind of told that there is a physician inertia in initiating anticoagulation
Yes, sir, that is
despite having a high CHADS score in the presence of AHRE. So you have kind of shed light on the fact that clinical inertia should be shed, right? That's a good point. Thanks. Bye. The last. Yeah. The last presentation is by Swasti S. Kumar. Predictors of failure of electrical cardioversion and incremental benefit of double sequential external defibrillation in atrial fibrillation.
Good evening, everyone. I'm Dr. Swasti, senior resident from Sri Chitra Institute. My study is titled The Predictors of Failure of Electrical Cardioversion and Incremental Benefit of Double Sequential External Defibrillation in AF. So we know electrical cardioversion is a safe and effective method to restore sinus rhythm in atrial fibrillation. It has an initial success rate varying from 70 to 90%, and sinus rhythm at 1 year follow-up has been reported to be 50 to 70% in various studies. So conventionally, electrical cardioversion is done using 2 adhesive pads or 2 paddles which are placed in the anteroposterior or anterolateral positions. So what is double sequential or double simultaneous external defibrillation? In DSED, we use double the number of pads. So 4 adhesive pads are placed both in the antro-posterior as well as the anterolateral positions, and we are giving double the number of shocks. So what are the advantages of DSCD? We are able to deliver more amount of current across a larger surface area and in two different vectors. Because of this, we are able to increase the amount of muscle mass that is getting defibrillated. So we conducted the study to evaluate the failure rate and factors predicting failure of electrical cardioversion in AF, and what is the incremental benefit of DSCD in such failed cases. The primary objectives were the same: to study the failure rate of conventional electrical cardioversion and factors predicting failure, and to study the incremental benefit of DSCD in these failed cases. The secondary objectives were, we would follow up these patients at 1 month and 6 months, and we would study the proportion of patients who were remaining in sinus rhythm in both the groups, and also to study and compare the adverse events of conventional as well as DSCD. So this was a prospective interventional study conducted across 1 year. Since a significant proportion of patients who are admitted in our Institute for Electrical Cardioversion have atrial flutter, I have included atrial flutter patients also. So diagnosed cases of atrial fibrillation or flutter planned for conventional cardioversion, we have excluded pregnant ladies and those who have not given consent. So patients who are admitted for conventional cardioversion, atrial fibrillation patients were conventionally cardioverted with 200 joules, atrial flutter patients were cardioverted with 150 joules. If the conventional cardioversion was successful, we followed them at 1 month and 6 months. If the conventional cardioversion was a failure, we have tried one attempt with DSCD. So DSCD, we have placed the pads in antro-posterior as well as anterolateral position. We have given 200 plus 200, 400 joules. And after this DSCD, whether it was a success or failure, we have followed them up at 1 month and 6 months. So coming to the data, we have recruited 104 patients, 60% had fibrillation, 40% had flutter. The mean duration of arrhythmia was 5 months and 20% of the patients had prior history of cardioversion. The mean age was 57 years, 60% of the study population were males, and the BMI was 25. The study population was overweight. Coming to the etiology of the arrhythmia, majority of the patients had a valvar etiology, followed by ischemic etiology, followed by lone AF or AFL, followed by congenital heart diseases. More than 70% of the patients were on beta blockers and amiodarone. A small proportion were on CCBs and digoxin. 30% was on aspirin. And among the anticoagulants, apixaban, 47% were on apixaban, followed by 37% on vitamin K antagonists. Baseline echocardiography parameters, the mean LA size was 43, which was dilated, and a dilated LA of more than 40 mm was seen in 60% of the study population. The mean LV ejection fraction was 55%. LV dysfunction was seen in 27% of the study population. The mean LA volume was 80 ml and the indexed LA volume was 45 ml per meter square, which is high. Coming to the outcomes of the study, among the 104 patients who underwent conventional electrical cardioversion, the success rate in the first attempt was 80%. The failure rate was 20. So 21% had failure. And this first attempt success rate was comparable in both the atrial fibrillation and atrial flutter group, though it was slightly higher in the flutter group. And in the patients who had a failed conventional cardioversion, we went ahead with DSCD. And after DSCD, it was seen that 47% of the patients who had a failed conventional cardioversion subsequently reverted to sinus rhythm by DSCD. That is, an overall incremental benefit of 9% was seen with DSCD. And we followed the patients at 1 month and 6 months. Patients who underwent conventional cardioversion, 74% remained in sinus rhythm at the end of 1 month and 64% remained in sinus rhythm at the end of 6 months. In the DSCD group, 72% remained in sinus rhythm at 1 month as well as 6 months. So the incremental benefit that was seen with DSCD was sustained at 1 month as well as 6 months follow-up. Coming to the next outcome, which was the predictors of failure of cardioversion, it was seen that the conventional predictors which were reported like age, BMI, BSA were not found to be significant. Height, patients with a higher height was found to have higher rate of failure. There was no difference between the different etiologies of the arrhythmia. Among the echocardiography parameters, indexed LA volume and LA volume were found to be predictors of failed cardioversion. And comparing the adverse events in the two groups, no significant difference was seen. 5% of the patients had arrhythmia, which recovered in the subsequent 2 to 3 days. One patient in the conventional group had a thromboembolic event. 14% had transient hemodynamic instability managed with IV fluids. 8% had transient bradycardia. One patient in the conventional group had persistent bradycardia, and he's asymptomatic on close medical follow-up. No myocardial damage was seen. So the conclusions of my study are that LA volume index, and patient height were predictors of failure of electrical cardioversion. 47% of patients with failed conventional cardioversion reverted to sinus rhythm with DSCD. And this incremental benefit was sustained at 1 month as well as 6 months of follow-up. There was no difference in adverse events between the conventional and DSCD group. So DSCD is an effective strategy in failed electrical cardioversion, which may have future implications. Of course, the limitations being that this is a single center study, and the sample size in the DSCD group was very small. Thank you.
Okay, interesting study. So what is the basic mechanism of DSCD?
Yes, sir. In DSCD, the thing is that we are placing 4 adhesive pads, one in the anteroposterior and one in the anterolateral direction. So one is we are able to give more current. So conventionally with biphasic energy, we go only up to 200 joules usually for.
Yeah. So one is giving additional current.
We are giving more current.
Anything else?
And we are
Any other
giving it over a
mechanism?
larger area. And most important thing is we are giving it in 2 different directions. We are covering 2 different vectors. So we are able to cover both the atria, a larger surface area of the atria we are covering. So
Does one defibrillation reduce the impedance?
yes, sir. That is also a proposed mechanism. It is said that the first shock might lead to a more organized tachycardia, which is easily which gets easily reverted with the second shock. And the first shock,
What was the type of cardioversion that you gave? Monophasic or biphasic in the
biphasic,
first one?
sir. We are using only biphasic.
Okay. So how come the DSCD has got only about 9% benefit? You said additional incremental benefit.
Yes, sir. So of the 21 patients, only 10 succeeded with DSCD. The remaining 11 did not succeed with DSCD. We have not further analyzed why they have not succeeded. That is
So should you be recommending DSCD for all patients, or is it?
sir,
or do you have any threshold?
Sir, at the end of the study, the sample size is very small, but with this data, we can say that it is a safe procedure. So there is no additional adverse event. So if you have a patient with atrial fibrillation who is not reverting with the conventional method, we need not hesitate to try a DSCD. It is a safe method that we can tell.
That is one point very well taken. If a single shock doesn't work, you can use double sequential shock, it works. So the success rate of conversion is definitely better, which is quite understandable. Is it sequential or simultaneous?
Sir, actually, they are one and the same. So even though we call it, they are both the same, sir. Actually, it can be done by one person or it can be done by 2 personnel. So
But it is
even
two,
though we
it is 2
try to-
defibrillators.
Yes, sir. 2 different defibrillators. Either one person can do or 2 different person can do. The idea is to give it simultaneously, but the problem is always a few second gap will be there. So a better term would be double sequential rather than double simultaneous.
Why do you say it is simultaneous? It is sequential.
Absolutely.
Because unless it is sequential, you will not be able to reduce the impedance. The basic
Yes, sir.
mechanism is
The mechanisms like impedance and all will work when we give it sequentially. That point is taken, sir. Correct.
And defibrillation itself is only, what is the duration of a defibrillation? If you give defibrillation for a patient with AF, what is the duration of the defibrillation?
Meaning, sir?
How long does it take for the defibrillation process to be done? The shock is given for how long? What is the duration of a shock?
Maybe 3 or 4 seconds, sir.
3 or 4
Less
seconds.
than 5 seconds.
That is pretty long. So your
less than
simultaneous is very, very unlikely. 2 persons, 2 missions giving at the same time
Yes,
is little far-fetched.
is, yes.
But definitely it improves the... And how many of the conventional defibrillations were done in the AP fashion?
Sir, in our institute, we do almost all by AP fashion. The guidelines also recommend that the success rate is higher with AP when compared to anterolateral. So the guidelines also, they say AP is better than anterolateral, though there are some studies which have shown that anterolateral is giving more success rate. In our institute, we, especially for atrial fibrillation, we follow the anteroposterior because anteroposterior will cover the atrium more. Anterolateral will more cover the ventricle. So maybe for ventricular arrhythmias, anterolateral might be better.
That's right.
The vector for
And what gets a little hazy in the conclusion is the fact that when you have to use two shocks to convert, that means it is a resistant atrial fibrillation, not one of the good ones, the bad ones. And this is a 1-point event. You have converted the rhythm. But what is quite surprising and encouraging and unbelievable is the fact that 6 months down the line, those who got that double shocks did better in terms of maintaining sinus rhythm. How do you explain that?
yes, sir. Though the difference was not statistically significant, it is encouraging. So
how do you explain the encouraging fact that resistant atrial fibrillation, which was a very bad, mischievous atrial fibrillation, that did not go with one shock, needed two shocks. But after receiving two shocks 6 months back, the atrium has remembered the extent of the shocks and has remained in sinus rhythm. I'm just being light-hearted. Don't take it seriously.
No, sir, no, sir.
Just to ask, did it strike a bell? Did you think about it?
Sir, actually, the study is ongoing. We are yet to analyze what is it that led to failure and more success in this patient. So
one thing is very certain: if one fails, two succeed. That's one clear message that you are given. Thank you.
It's an extension of that question. Do you think that DSCD would have caused a 6-month follow-up difference?
No, sir. The difference was not
I know
statistically
there was no difference
significant.
between the
Yes, sir.
two, but do you think just because doing it with DSCD would have a 6-month follow-up long-term effect?
No,
It's
sir. I
difficult to
don't think
hypothesize that.
it
That's
should lead to a unlikely.
So I think you should have answered unlikely.
Yes, sir. It is not.
Second question is, when you do sequentially, I didn't know that in your center it's always AP first for AFib. When you do it sequentially, AP first and second would be the regular patterns. Is that right?
Yes, sir.
So what if it was the regular patterns that did the trick and not DSCD? How would you distinguish that? Get the question?
Yes, sir. The first attempt was with 2 paddles. It was not a success. That is why we had gone ahead with 4. But actually, that mechanism is like that. In double sequential, the first shock, it will reduce the threshold for the second shock. Immediately you give the second
So my
shock.
query here is,
Yes,
was
sir.
it DSCD that did the trick or the second cardioversion that did the trick? How do we know that?
It's hard to say, sir.
These are R2 patches, no?
Yes, sir.
It has to be R2 patches. Otherwise, you cannot have sequential anteroposterior.
Yes.
They were all patches, right?
All pads, sir. It is not paddle.
Jelly-based paddles.
Not
One final question. Were you concerned that this would cause more problems for the patient in terms of you're giving 2 shocks simultaneously or sequentially?
Yes,
So
sir.
did you measure enzymes?
Yes,
You have
sir.
not.
We did measure, sir.
There was
We
no
have-
difference.
We have measured troponins at baseline as well as 6 hours after the procedure. There was no significant elevation in either of the groups. Thank you.
One observation is all of you had to rush through the presentation is because of the fact that you're spending too much time on background, which is already known. Most of the things, not all the 4, some of the people had to rush through the presentations because too much of time, almost 6 minutes is gone by the time the study itself starts. That is one of the reasons. Maybe in future, you should reduce the background to 1 or 2 slides and concentrate more on the study done by you, which will make you more comfortable in presenting. As Dr. Ajit sir said, wonderful presentations, great efforts, really, really commendable performance by all the 4 participants.
Thank you, sir. Next session is Pacing It Right. I invite Dr. Mukundiya Prabhu, Dr. Praveen Srikumar, and Dr. Vivek Pillai to chair the session.
One announcement. Dinner has started outside, so those who want can go have dinner and come.
So I think because we are running short of time, I think we'll rush through the presentations now. So I think we'll go with the first presentation. I think it's Dr. Sharavana Harrison. He's presenting about semi-permanent pacemaker in a CHB in a child.
Good evening. Good evening to one all present here. I'll go to the case presentation. My patient is a 5-year-old boy. He is a firstborn with a normal birth and development history. He is studying in the upper kindergarten. He presented to us with a 3 days history of fever, which was low-grade fever, with which was relieving with antibiotics, and associatedly he had 2 episodes of tonic posturing However, there was no frothing from the mouth, there was no clonic jerks or no involuntary micturition. He was admitted in a local hospital for his complaints, and therein he had a similar episodes of this tonic posturing, and he was suspected to have a seizure obviously, and he was taken for a neuroconsult wherein they planned for an EEG. During evaluation, they did a ECG of the patient, which was showing 2:1 AV block with narrow QRS escape, and the rate was around 50 per minute. So to know the origin of this, whether it's a supraisian or infraisian, they did a atropine challenge, and which showed that after atropine there was a prolongation of the PR interval. There was a first degree AV block, indicating there is likely a supraisian problem. And on further evaluation, we did a echo which was showing mild LV dysfunction with the global LV hypokinesia and a mild mitral regurgitation. So on the background history of fever with a conduction disturbance and mild LV dysfunction, our first differential which came to mind was myocarditis present in the child. So we went ahead with the investigations with cardiac enzymes and pro-BNP. There was elevated troponin T levels with an elevated NT-pro-BNP level of 16,100. And the other workup for myocarditis for biofever, throat swab, and other etiologies like Lyme's disease were all negative. So, but during the course of hospital stay, he had recurrent episodes of those so-called seizure-like episodes, which were retrospectively found out to be the Stokes-Adams attacks. And he was planned for a pacemaker insertion. So during the time of pacemaker insertion in the cath lab, he had cardiac arrest, and for which CPR had to be given. And keeping that, we have put a pacemaker, semi-permanent pacemaker for him with an RV lead. And the pulse generator was kept in the right side of the neck. So, and the RV lead was put through the right internal jugular vein, keeping in mind two things. If he further develops to have a complete heart block in future, which does not recover, we have to protect the subclavian. So we went at the right interjugular vein, and this is the X-ray of the patient showing the pulse generator. The pulse generator in the right side of the neck, and RV lead is seen in situ. So post procedure, he was shifted to the ICU, and he had multiple episodes of a wide complex tachycardia. It was regular, and there was maintained 1:1 relationship with the maintained 1:1 VA relationship. It was likely to be a atrial tachycardia with aberrancy. So we tried giving adenosine to know the response, and post adenosine, what we can see is here is that the tachycardia showed that there were more A episodes compared to the V, so indicating that it's an atrial tachycardia. And further, to confirm the diagnosis, we went ahead with a cardiac MRI. So this is the cardiac MRI of the patient, and what is interesting here is that we had put a pacemaker in this patient, and which did not hinder our diagnosis of myocarditis. We can see that this cardiac MRI is showing elevated T1 values with subepicardial LG enhancement in the LV lateral wall. The noted asterisk marks indicate that there is a pacing artifact there in the RV, and the other one arrow mark which is pointing towards the late gadolinium enhancement in the LV lateral wall. And this is a T1 mapping image of the same. So this MRI was suggestive of myocarditis, and in order to treat, we started him with IVAG infusion for 2 days, and after that he subsequently improved and he was symptomatically better. He did not recur to have any of those arrhythmias after that. So this is the treatment flow of the patient. Initially when he came, he suspected of myocarditis, and then we put him with a semi-permanent pacemaker with a single RV lead through the right internal jugular, and the pulse generator was kept in the right side of the neck. And you can see that the MRI first image, though there is a pacemaker artifact, pulse generator artifact seen there, the cardiac images were clear. And after that treatment of myocarditis, our plan was to go either, if the patient recovered completely, to remove that semi-permanent pacemaker, or if he persists to have this conduction disturbances, go with the permanent pacemaker. So this is the image of the patient showing that mid-myocardial enhancement of the mid-myocardial enhancement suggestive of myocarditis. And this is the pre-discharge echo of the patient. The LV function completely improved with an ejection fraction of 75%, and this is the pre-discharge ECG of the patient. So myocarditis can present with arrhythmias, most common being tachyarrhythmias, and of which sinus tachycardia is the most common, and it is usually a compensating mechanism for heart failure in those patients. So when these patients develop bradyarrhythmias, they can have a florid hemodynamic instability, and AV block is reported in very rarely, and among the patients who are having AV block, 65% of the patients will recover completely within 1 week, and only 22% of the patients will progress to have a persistent AV block and may need permanent pacemaker. So after 1 week of semi-permanent pacemaker, if the patient is continuing to have CHB, so we should put a permanent pacemaker. What are the advantages of a semi-permanent over TPI is that patient need not be resting on the bed always. He can be mobile, and the DVT also chances reduced. There is reduced risk of dislodgement, reduced risk of perforation, reduced risk of infection. So semi-permanent pacemaker is a viable option, and it can be used as a bridge to recovery. And semi-permanent pacemaker will not hinder the diagnosis of myocarditis by modes like MRI. Thank you.
I think for want of time, we'll go to the next. Anything?
Thank you.
Insights into gram-negative bacteria-associated vegetation on pacemaker lead. Dr. Abhilash Nair.
Good evening, everyone. I'm Dr. Abhilash from Amrita Institute of Medical Sciences. I'll be presenting a case report into insights into an unconventional journey of lead removal. So this case report is about a 34-year-old female, a known case of congenital heart disease or top physiology, for which she underwent intracardiac repair at the age of 12 years in the year 2001. Post-operative period, she develops as asymptomatic 2:1 AV block. She was asymptomatic and on regular medical follow-up. Later, in the year 2008, around 7 years later, she develops a complete heart block, for which she underwent a permanent pacemaker implantation, DDR Medtronic Kappa device. 8 years further down the lane, in the year 2016, she has one episode of syncope. The device interrogation at that time shows ERI, the elective replacement indicator, for pulse generator, and subsequently underwent the PG change. Since she had high threshold of the old ventricular lead, a new RV lead was used and was on regular follow-up since then. She had erosion of the PG from the pocket and was evaluated elsewhere in this year, in the January end, where the ECG and echo were reportedly normal, and then she comes to our OPD. She had no complaints of palpitation, syncope, fever, or chills. Her cardiorespiratory examinations were always normal. Pacemaker interrogation was normal. ECG showed 100% A-pace, V-pace rhythm. This is the X-ray which shows one atrial and two ventricular leads in this patient. She was advised for a pacemaker explantation with removal of all the intracardiac leads with the help of a lead extraction tools. However, in view of financial constraints, they were not willing for the same. Hence, she was planned for PG explantation removal under cover of IV antibiotics. So this is the cine view showing the initial one with one atrial and two ventricular leads. And we went ahead with the procedure wherein we were able to remove the atrial lead and the device we were able to remove. However, the other ventricular lead we were not able to remove and it was kept back. Subsequently, she was shifted back to the ward and was on pacemaker support under IV antibiotics. However, 3 days later, she develops fever with chills, and we send a routine investigation which shows an elevated ESR and a CRP. We do an echo, repeat echo, which is found to be normal at that time. We go ahead and do a transesophageal echo, which shows multiple vegetation in the lead tips. Presence of multiple small vegetations in the ventricular lead, the repeat blood culture showing Enterobacter cloacae complex. We go ahead and plan for a removal of both the old ventricular lead extraction under GA. So as you can see in the images, the first image is the literally entrapment of all the leads inside her. We go ahead for the procedure in which we pass the 18 French sheath, pass a wire, and we try to use a needle-eye snare in order to remove the leads. Unfortunately, we are unable to do that. So we pass an Azelis sheath and try to bend this sheath towards the lead with the help of an EP catheter. Next, we pass a Terumo wire around towards the RVOT and goes towards the pulmonary artery, as you can see in the image number 4. Further, use a snare for hooking of the leads and try to externalize one of the leads, which were later successful in removing of one of the leads, which we can see in the picture number 6. We continue with pulling the remaining leads, during which one of the leads unravels. The tip of the one of the leads gets released, which we try to remove. So, in order which we are unable to remove all the leads, what we do is we go ahead with a left side puncture, and we thought to snare the tip after loosening it. So the left side puncture was used and a new through the another venous axis. We use the snare to catch the tip of the ventricular lead, and while doing so, the lead gets unraveled and the anodal part stays back. The remaining of the lead is removed out. We continue with the traction. The snare is used again, and then successfully we are able to remove one atrial as well as one ventricular lead. I'm stuck. As one more lead was still remaining, we push the sheath up towards the lead in order to get a proper traction, and with the adequate traction and counter traction, we are able to remove the remaining lead. And so the final, as you can see in the figure number 17, the only one lead is staying back, rest all the infected leads are removed. Subsequently, 1 week later, she undergoes a permanent pacemaker implantation. She received around 4 weeks of antibiotic therapy and was discharged in a stable state. She has been under regular follow-up since then. So the take-home message being, infected devices ideally warrants the removal of the whole device. Lead extraction tools are useful in these cases with success in majority of them. In our patient, the financial constraints and the non-availability of adequate working lead length in the infected pocket for the use of lead extraction tools was an issue. In this patient, using an improvised method, we were able to remove the infected leads via the femoral axis. In selected cases, femoral approach to lead extraction may be helpful. Thank you.
One thing, the thing is, did you use a LLD from the upper lead? No.
Sir, no, sir. Initially, when she had
only from below.
No,
only
initially was for the financial constant. And first time when we had done the procedure, sir, the atrial was removed. And at that time, there was no infection. So ventricles were left at that time.
Yeah, okay.
So we didn't have that exact length to use. No, sir.
All the leads are removed. You said one atrial, one vent.
That is the second time when we do the procedure, sir.
Okay.
That time we were, because of the infection, that was the indication, so we removed all the leads at that time.
So everything is out.
Yeah, we were able to remove.
Right.
Now, next one is Dr. Jitin S. Panikar. Is presenting on which came first, chicken or egg.
Good evening, respected teachers. This is a case of a 60-year-old female with no prior significant medical or surgical illness, who was taken to a nearby hospital with an episode of syncope. And as per the hospital records available from that center, they documented it as multiple episodes of VT, and she had underwent 4 cycles of DC cardioversion from there. And in view of low GCS, she was intubated and referred to our hospital for further management. And on presentation to our emergency department, she had one more episode of ventricular tachycardia. This was the ECG that was taken with the help of the defib machine, and was showing a polymorphic VT, that the QRS amplitude was changing with each beat and was twisting around an isoelectric line. So again, she underwent one more cycle of DC cardioversion, and post reversion, this was the ECG that was taken. She reverted to sinus rhythm. And the most prominent or significant finding that we found in this ECG was the presence of long QT, and the corrected QT was found to be 503 millisecond. Initially, we thought it was to be a post-resuscitation change, but this continued to exist in the serial ECG examination. So this was the screening echo that was done on the emergency department. A picture was suggestive of a DCM with severe LV dysfunction. The LV dimensions were 63/52 with an ejection fraction of only 32%. We checked in for any correctable causes. The electrolytes and thyroid function came to be normal, and the coronary angiogram was found to be normal. So with the background of Torsades pointus with long QT syndrome, we initiated the patient on propranolol. But unfortunately, while on propranolol, she developed an episode of sinus bradycardia, which worsened to complete heart block, and she threw another VT, which likely a brady-induced VT, and the patient was put on temporary pacemaker. So the concerns that we faced in dealing with this case was like, what came first? Did the DCM cause the VT, But then that scenario, why the patient is having a long QT, that remained unanswered. The other question was like whether the long QT was causing the DCM. It can be explained on the basis of a single gene mutation, a sodium channel mutation, which can simultaneously cause a long QT and a dilated cardiomyopathy. SCN5A is notorious to cause that. So we had to make a plan. So we planned of putting the patient, as the patient is developing complete heart block while on beta blocker, and she needed to be on beta blocker. So there was a pacing indication as well as a ICD indication. So initially, we, with the background of severe early dysfunction, we planned of putting a CRT-D or a dual chamber ICD. But unfortunately, both of these were not covered under the insurance policies that we are having. So by that time, genetic study was sent with special emphasis on the dilated cardiomyopathy part and the long QT part. So what we did in this patient is like, we continued the patient on propranolol and we put a LOD-DX ICD with an atrial sensing function and RV coil as the defibrillator and a left bundle branch pacing. So this was the post-procedure ECG. From this, it is very evident that we were able to selectively pace the left bundle area, as evidenced by the short left ventricular activation time. Just hardly around 60 milliseconds, that is less than 80, suggestive of selective left bundle branch pacing with a very pretty narrow QRS complexes. So by the time the genetic analysis report were available for us, unfortunately the patient had simultaneous occurrence of both RBM20 mutation and KCNQ1 mutation. This RBM20 is notorious to cause this responsible for 5% cases of dilated cardiomyopathy. And these are very prone for developing malignant ventricular arrhythmias, this RBM20. But the patient simultaneously had the presence of an KCNQ1 mutation. This is responsible for the long QT1 syndrome. And both of them are inherited as an autosomal dominant pattern. So after all these modalities, the patient remained asymptomatic. Now she is on maximum tolerated dose of beta blockers and other treatment for heart failure. Luckily, there were no further episodes of ventricular tachycardia. We advised a family screening, but they are not turned up yet. So regarding the mutations in RBM20, the RBM20 mutations responsible for a clinically aggressive form of dilated cardiomyopathy at an increased propensity for malignant ventricular arrhythmias. So this actual mechanism is like loss of RBM20 will disturb the calcium handling, make it more pro-erythromogenic calcium releases from the sarcoplasmic reticulum. So other mutation that one found is a KCNQ1 mutation. This is a potassium channel mutation. This is responsible for long QT1, short QT1 and familial atrial fibrillation. The association of long QT with the DCM is very rare, but has been reported in cases of a SCN5A mutation that is responsible for the long QT syndrome type 3. But there is one case report of a KCNQ1 mutation which is responsible for familial long QT in a child, with the child later developing dilated cardiomyopathy. So similar to sodium channel mutation, potassium channel mutation could also be responsible for simultaneous occurrence of both the myocardial dilatation and a resultant ventricular dysfunction. But that area needs to be further evaluated and researched. So what happened in this patient is like she had RBM20 mutation and KCNQ1 mutation. This RBM20 made her prone for developing DCM and ventricular arrhythmias, and the KCNQ1 was responsible for the background long QT1 syndrome, ultimately resulting in the presence of DCM with VT and a long QT in the patient. So what makes our case special is like this is the first case to report the coexistence of these two mutations in the same patient, and to also emphasize the option of an effective utilization of the available limited resources to give the best of our treatment options. So this is a gist of the story. Thank you.
Nice case. Next case is Dr. Marsha Barreto. We're presenting on effect of flecainide on multifocal ectopic Purkinje ectopics related PVCs in R814 SCN5A carrier.
Good evening to all. Coming to our patient for today, we have a 38-year-old female who presented to us with history of palpitations and class 2 dyspnea on exertion for the last 2 years. She had no history of any syncope or pre-syncope. However, she had a strong family history of sudden cardiac death. On her initial evaluation, she was found to have an irregular heart rate. On probing into her family history, this is her pedigree chart that was drawn up, which shows the red arrow indicating our patient, above which we can see that the patient's father, as well as her paternal aunt, had a known diagnosis of dilated cardiomyopathy. Her father had a sudden cardiac death at 33 years of age and her aunt at 43 years. The father also had another cousin who was also diagnosed as a case of dilated cardiomyopathy with severe LV systolic dysfunction who was recommended an ICD. Another paternal aunt succumbed to sudden cardiac death at 30 years of age. So as we can see, her family history of sudden cardiac death was very significant. Coming to her ECGs, these are two ECGs that were done at subsequent points in time. So as we can see, although the baseline rhythm is a sinus rhythm, there are frequent multiform ventricular premature beats. Some having a LBB type of morphology and some an RBBB type of morphology. It has an inferior axis and all show a swift intrinsicoid deflection. And the QRS is seen to be of a narrow interval, suggesting a possible Purkinje fiber origin. Her echocardiography done showed a dilated left ventricle, global LV hypokinesia, and an EF of 35%. She underwent a 72-hour Holter monitoring, which once again showed multifocal PVCs, runs of NSVT, with a total PVC burden of 31%. The PVCs mostly had an RBBB morphology, narrow QRS, and rapid initial deflection, once again suggestive of a Purkinje fiber origin. She had a normal chronotropic competence with usual diurnal variation and a normal relationship of the PR interval with exercise. Her lab investigations done at this time at the baseline, the RFTs, serum electrolytes and TFTs were normal, and her NT-proBNP was found to be elevated at 1,800 picogram per ml. She subsequently underwent a cardiac MRI. As we can see, there is only a mild hypertrabeculation that is noted in the LV, that in the apical segments, but no LG, no late gadolinium enhancement was noted anywhere in the myocardium. So at this point of time, our differential diagnosis was one of the various subtypes of a genetic arrhythmogenic cardiomyopathy, keeping in mind the pathogenic variants of filaminin C, laminin A or C, phospholamban, and others. So in view of this, our patient underwent a single chamber ICD insertion for primary prevention and subsequently was also started on antiarrhythmic drugs along with guideline-directed medical therapy. She was started on amiodarone and sotalol, which were then optimized, doses were optimized at her regular follow-ups. But our patient continued to have incessant episodes of NSVT during her device interrogations, and her EF remained persistently low at 35%. A Holter was repeated at this time, and this Holter showed persistent of her PVCs at the exact same percentage of about 30% as that of earlier. The PVCs were of the same morphology as of earlier as well. Varying doses of sotalol and amiodarone were tried, however, to no effect. It was at this time, in view of an autosomal dominant pattern of her DCM phenotype in the family, that she underwent further genetic testing. A whole body exome sequencing done then revealed a pathogenic heterozygous missense variant in exon 16 of the SCN5A gene. This R814W variant was a gain of function mutation at exon 16 of the SCN5A gene. So this gain of function that then potentiates the fast sodium channels that are present results in hyperexcitability of the His-Purkinje fibers that are present and which can hence result in these aforementioned VPCs. So now we come to finalizing the diagnosis. So the presence of these multifocal PVCs of most likely Purkinje fiber origin, a DCM phenotype with autosomal dominant mode of inheritance, and the finding of this pathogenic heterozygous missense variant in the SCN5A gene with a gain of function variant led us to the diagnosis of an SCN5A channelopathy, multifocal ectopic Purkinje-related premature contraction syndrome. So regarding this, literature is as yet sparse, but we reviewed a few case reports in which sodium channel blockade with class 1C agents showed good therapeutic response. So our patient was switched over to flecainide in a starting dose of 50 mg twice a day and then gradually increased to 100 mg twice a day. At her follow-up, her repeat Holter showed a marked reduction in her VPC burden from 31 to 3%. QTC interval remained within normal range. Her echo at the end of 8 weeks revealed a near normalization of her EF to 55%, And although we don't have an initial GLS, her GLS after marked suppression of PVCs was minus 19. 4 months now after initiation of the flecainide, our patient remains asymptomatic, and on her ECG, there is complete absence of these VPCs. Flecainide continues to be well tolerated. So this mutation, our SCN5A variants, are detected in nearly 2% of cases, and rare SCN5A variants may lead to unique biophysical phenotypes. So this MEPPC phenotype was first described by Laurent et al., who described this novel autosomal dominant form with this cardiac arrhythmia characterized by VPCs of a Purkinje fiber origin. So reports have shown that appropriate therapy with appropriate sodium channel blockers and antiarrhythmic drugs such as flecainide, quinidine, and mexiletine has successfully reduced the PVC burden and has led to a restoration of the LV systolic function. So although current guidelines do not advocate the use of class 1 drugs for the treatment of multifocal PVCs in patients with DCM, recognition of this MEPPC phenotype in a patient with DCM along with the genetic confirmation allows us to probably use these class 1 agents with therapeutic success. We had the opportunity to publish this case report in the JACC case report issue this year.
At no point of time you offered ablation to the patient. There was a high burden of Purkinje PVCs, no?
Yes, sir.
I would rather, given that as an option. I mean, it's great that you have a normalization of EF and near no Purkinje potentials, but I would be very, cautious about starting flecainide in a patient with a EF of 35.
Yes, sir.
Could you have avoided a defibrillator if you had started flecainide first and documented the EF improvement?
Sir, no, given her strong family history at that point of time, given her recurrent palpitations, a documentation of NSVT, probably we would have gone ahead with the ICD and then worked up as we did further.
Okay, last case. Dr. Vinod Naik. He is be presenting failure of auto capture algorithm causing PMT.
Good evening, everyone. My talk is titled Failure of Auto Capture Algorithm Leading to RNRVs and Pacemaker Tachycardia. So we had a 65-year-old gentleman with history of complete heart block, had undergone St. Jude dual chamber permanent pacemaker in 2023. He's also a known diabetic and hypertensive. He had presented with history of palpitations, sudden onset, offset of 6 months duration associated with atypical chest pain. So this was his ECG at presentation, showing ventricular paced rhythm at a baseline rate of around 60 beats per minute with no preceding atrial activity. The retrograde P waves could be seen in especially in V1 and inferior leads, submerged in the ST segment and T waves. The chest X-ray showed the device and the leads projecting to a good position. The leads don't seem to have moved from their intended locations. Baseline device interrogation showed the mode to be set in DDDR mode with a lower rate limit of 60 pulse per minute and a maximum tracking rate of 130 beats per minute. Paced AV delay was programmed at 200 milliseconds. Sensed AV delay was set at 150 milliseconds. PVAP was programmed to 350 milliseconds. And around 352 atrial high rate events were recorded. Percent pacing, A pacing was at 80% and V pacing was at 95%. Also, high atrial lead threshold was noted both in uni and bipolar lead configuration. This was the post-implantation EGM which was available with the patient. Sorry for the quality of the EGM tracings. So we're able to see the repetition of A pacing, V pacing, and AR intervals. AR is atrial retrograde AR sensed event in a post-ventricular atrial refractory period. So at the fourth beat, the delay between the ventricular pacing and atrial sensing is delayed, so that the retrograde atrial activity is now falling out of the refractory period and is labeled as AS, initiating a AV delay and ventricular pacing, triggering a pacemaker mediated tachycardia. So the pacemaker mediated tachycardia was identified at another center and the PVARP and the postventricular atrial branching period duration were increased. So in this, this was the EGM recorded at our hospital. So there's loss of atrial capture and a retrograde VA conduction with the retrograde A wave falling into the PVARP. This is followed by an atrial stimulus which does not capture because of the high atrial threshold. This atrial non-capture here is not because of the atrial refractoriness, because the stimulus is occurring well beyond 350 milliseconds. So following the programmed AV delay, the device delivers a ventricular stimulus, which again leads to another retrograde P wave perpetuating RNRVAS. The manual atrial threshold test demonstrated a loss of atrial capture at 4.25 volts because of the high atrial threshold. The auto capture algorithm programmed atrial output amplitude was less than 0.25 volts at with a pulse duration of 0.4 milliseconds. There were multiple erroneous atrial high rate event recordings due to the presence of RNRVAS. With the start of RNRVAS, the retrograde conducted A wave falling in the PVARP and the non-captured A pacing with the activation of the sinus indicated rate response, all these events were perceived as AMS entry by the device, leading to mode switch to a non-tracking DDDI mode. So management for this patient, we gave a trial of higher output for the atrial capture and rate response. Subsequently, patient underwent implantation of a new atrial lead. Coming to discussion, dual chamber and biventricular devices are commonly programmed to pace in an atrial tracking mode to preserve AV synchrony, and it is not uncommon to observe ventricular atrial synchrony and pacemaker mediated tachycardia driven by persistent retrograde VA conduction. Two main forms of pacemaker mediated VA synchrony arrhythmias are endless loop tachycardia and repetitive non-reentered ventricular atrial synchrony. The mechanism of RNRVAS in this patient, he exhibited high atrial threshold. However, the pacemaker was programmed with an auto capture algorithm which detected the atrial threshold to be less than 0.25 volts at 0.4 milliseconds, leading to atrial non-capture with ventricular pacing and retrograde VA conduction. The retrograde atrial depolarization fell within the PVAR, hence not tracked, this functional undersensing, and subsequent atrial pacing failed to capture, triggering the ventricular pacing at a programmed paced AV delay. The mechanism of PNT was there's a loss of capture with ventricular pacing and retrograde VA conduction. However, the retrograde atrial depolarization had fallen into PVAP, hence was tracked, triggering the AV delay and ventricular pacing. Coming to the clinical significance, the potential adverse effects of these would include pacemaker syndrome due to loss of optimal AV synchrony, inappropriate increase in the ventricular pacing, inappropriate diagnosis of atrial high rate events, inappropriate mode switch with associated mismanagement, and proarrhythmia. To conclude, failure of atrial auto capture algorithm with high atrial threshold leads to RNRVAS and pacemaker mediated tachycardia. Patients on auto capture algorithm should have the threshold testing manually during in-office pacemaker interrogation annually, or if there is any change in symptom status. Both RNRVAS and PMT may cause symptoms and induce further atrial tachyarrhythmias, thus highlighting the need for recognition and appropriate device programming to prevent the occurrence. To prevent RNRVAS, should consider certain programming options that would allow atrial tissue recovery, like lowering minimum to lower minimum rate if it's high, or disable rate modulation if non-essential, or shorten AV delay and PVAP durations. And finally, newer algorithms for diagnosis and prevention and suppression of RNVAS are required in the current devices. Thank you.
Thanks. Questions? Any questions? So I think we can break food in that.
Thank you.